بسم الله الرحمن الرحيم. السلام عليكم. Good morning. Is my sound clear? Can you hear me well? Dr. Suhail.
I can hear you. Good morning.
Good morning. Good morning. And welcome to the second day of MAC Congress. Yesterday was a very successful day. All the eminent speaker, very nice, informative presentation. And hopefully today it will be the same success, and we will continue our series of the presentation. We will start today with Dr. Marcella Espinal, and she is a consultant pediatric immunology and allergy from the Royal Hospital for Women and Children in Bahrain. She will talk about the skin prick test in allergic disease. Welcome, Dr. Marcella, and the floor is yours.
Good morning, everyone. Good morning or good afternoon, doctors.
Good afternoon.
It's okay? It's ready?
Yes.
Everything know that?
Perfect.
Okay. I would like to say thanks the Congress organization, Dr. Suhail, Dr. Mohammed for inviting me. Congratulate the colleagues whose presentation, their themes yesterday is really, really nice. And now, so the presentation would be about the skin prick test in allergic disease, okay? And the most common questions. This is my disclaimer. Our agenda today. And okay, the allergic manifestations are caused by production of a specified immunoglobulin E, IG, for allergen present in the environment such as dusty, foods, insects, and mold. The diagnosis of allergy disease is made primarily by detecting clinical history and physical examination. To confirm the diagnosis, it's necessary to demonstrate the presence of the specified foreign allergy or other allergen in the clinical history, when be possible to prevent the participation of this allergy and provoking the clinical manifestation. This currently wide variety is monitored in vivo and in vitro to assess the presence of specific allergy. Our focus is skin prick test. Okay, we know 4 types of allergy reaction, okay? The type 1 is mediated, cytotoxic reactions, complex reactions, and delayed reactions as contacted dermatitis type 4. We need to remember that the innate immunity system will work integrated stimulation for environment triggers, infection, stress, injuries, and utilize in the inflammation to adaptive immune system. Intricate cells in tissues respond to micromodels, model associated with lesions or alarms with change, and phenotypic that determines the T cells and the response to the function generated by the presentation of the antigen. The T cell macrophages also respond to environment stimulus and release cytokines. This started the immune response to antigen derived from the tissues. For example, the intricate cell and peripheral blood of the patients with food allergy have altered phenotypicity compared to the healthy controls, leading to increase the production of the pro-inflammatory cytokines responsive to allergenic stimulus. The such response are probably linked to a signally and by FC reception for IG. IG total, when should you orders? The determination of the IG total is usually requested in the assessment of allergy conditions. Factors contribute to the serum's IG level, for example, genetic predisposition, environment factors, infections, age, undetectable in the neonate, and the reaction maximal contracting in the concentration in young adults, pollution, smoking, type and intensity of allergy sensitizations. Serious elevated levels are observed in most of atopic dermatitis and eczemas, allergy, asthma, but more rarely in patients with exclusive allergic rhinitis. The IgE determination is performed by immunocyte, famous ELISA, okay? The result is quantitative and can be expressed in international units per ml, kilo units per ml, or nanograms per ml. IgE total determination helps to differentiate diagnosis when are in the suspicion of the eosinophilic esophagitis, occupational allergies, unclear causes, allergy pulmonary aspergillus, or allergic sinusitis by fungal. In our service, we use the unit international per ml. IgE high level is not synonymous of the allergy disease. IgE can be elevated in several conditions such as intestinal or cutaneous parasitosis, myeloma, hyper-IgE syndrome, viscosity syndrome, pulmonary aspergillus, and filariasis, among others. IgE total high level is regularly detected in no atopic individual. They probably reflects the degree of the personal exposure to the microorganism in general. But when did the skin tests come? In 1998, Dr. Charles Mantoux proposed the intradermal reaction, the famous PPD, later adapted for Scholz for use in allergic disease. In 1924, Sir Thomas Lewis first discovered for the prick test modified by Pepsi in 1968, with a minimal chance as it is used today. What are the variable skin prick tests? The expected result of the skin test, they evaluate for type 1 reaction. It's a function of quantity and quality of the antigens in the skin. The presence of the IgE is specific. The number of the cutaneous master cells at the site of antigen injection, the granulation against a certain antigen, and the patient's skin cutaneous reactivity to mediators releases, mainly histamine. Reactive to histamine may vary with age, the region of the body that you use to place that antigen. For example, back more than for arm, okay, for arm. The route is application, epidermal or intradermal. The time of the day, 6 to 7 p.m. is more histamine in the serum, and with some drugs which the patients have used before testing. But what's the skin prick test? It's a test of mediated allergic reaction, and the result they measured specifies IgEs for specialized antigens. A test of mediated reading is considered the main method to confirm IgE-mediated allergic sensitization. It's a little invasive production, and when performed correctly, it has a good reproducibility. It is a little invasive procedure. When performed correctly, it's good. The procedure is education also for the patients, since all of the allergic inflammatory response, they affect their eyes, nose, bronchs, and the gastrointestinal tract to be visualizing on the skin. It's really nice for the patients. How to use the skin prick test in clinical practice? Skin prick tests are used to confirm the clinical sensitivity induced by wide variety allergens found naturally in the environment, such as in allergy allergen and food allergy. Okay, this way it's making environmental or health orientation for the patient if this is an aeroallergen or an allergy allergen. If it's a food allergen, and exclusive the diet proposal is made. The test is also important to formulate specific immunotherapy for the patients if this therapy is chosen for the patients. What are the strategic characteristics? Most fulfill the following characteristics: contain active allergen in qualified proportion and those found in the allergy natural sources. The concentration must be defined, the biological units. No contamination with other allergens, must have no irritation in our toxic components, must have documented, stabilized, and within acceptable limits. The quality and the qualification of the allergen present in this tract is very, very important for interpretation and the valorization of the tests. In aqua solution In aqueous solution, progressively lose potency. The loss of potency can be delayed, but not prevented by the use. 0.03% serums one albumin effective for stabilizer if double being inhibitants. 1500 and glycerin is more active than albumin to prevent the loss of potential and should use our structure story of the use the spin test. Should be also keep refrigerated to 280 degrees when it will not use in use. Okay. How to choose the allergens? Okay, the number of allergen tests will depend on the patient's characteristics, such as age, for example. If the patient has the patient's 11-month age, it's impossible more than 10 parameters. Okay, clinical condition, especially to regional allergy, among others. The skin prick test is a safe procedure, although systemic reactions have been observed and describing the scientific traits. We need negative and positive control for assist the test interpretation. The solution used as negative control are user diluent using the extractive preservative and serve to detect demographics and no specific skin reactivity to diluent or puncture. The positive control helps to detect expression for drugs and or disease and variation in the performance of the technique and staminic phosphate in the concentration 10 milligrams per ml in January used that. The positive response reflects the presence of the specific allergen antibodies linked to multi cell. However, it's not demonstration that this allergy is cause of the clinical manifestation. Okay, the positive response reflects sensitization. These are our material. Okay, we use the positive and negative control. Positive control, we use histamine hydrochloride, and negative control, phenylated glycerin salines. We use the single-use sterile prick test needles like plastic blood lancet. How to perform? Is the most important used for good reproductivity and ease of application. The skin prick test is preferred in the inter-evaluation. It's faster to perform, causes less discomfort, allows tests several allergens at the same time, and they offer less risk of the system reaction. In addition, when performed with suitable extractive, it corrects with clinical sensitivity. After prepare the region, okay, back or interior form, with use 7% alcohol, a drop each one potential allergen substance, apply with a minimal distance of 2 centimeters between each one. After the antigen drops applied to the skin, a needle or lancet, you use a lancet, it passes through the drops, and the most superficial layer is the skin reproducers. It's different in the intradermal test in the antigens because you need injecting into the darts. The reading of the results and should be done between 8 and 10 minutes for histamine, and after 50 to 20 minutes for allergen. The hormone record for me and send me, okay, is the kids 5 years old, really nice, calm, relaxed, no pain, no blood out. It's really relaxed for the patients, really good for the patients. Use blood lancet with through the drops. We wait for, sorry. You wait for few seconds and dry the drops because the drops doesn't take the running in the arm. now. I'll wait for 20 minutes, but the histaminic reaction starts yet. How to read this skin prick test? The means in millimeters, okay, of largest and the smallest diameters of the wheel and the rectangle should be recorded. Do you note the largest diameter and the perpendicular diameter at the midpoint of the largest, add and divide by 2. Some suggestion that you mark the external limits of the reaction with pen, and the reaction considered clinical relevant, and therefore this positive result present a papule with 3 millimeters or more with average diameter and 10 millimeters or more with very thin. I prefer focus in the papules and everything. How to understand the skin prick test result? The positive control more 3 millimeters. The allergy more 3 millimeters or more at 50% of positive control, the result is positive. Less 3 millimeters is negative. The negative control has negative, okay? Less 3 millimeters. For understand, 0 to 3 is negative, 3 to 5 is positive, but not so much, but is considered positive. From this one is really important count. You need to pay attention first and food allergy, okay? Because the size of the papules relationship with the severe disease. How to compare advantageous skin prick test and intradermal test? More specific use to the test for inhalant allergen and the food allergens. Low risk for systemic reaction, easier to performance, less invasive, is usually done first. The advantages of the IDT, the intradermal test, is more sensitive. It's good for some antibiotics, penicillin, for example, but it's contraindicated for food allergy because high false positive and risk for systemic reaction. Mainly used in 2 situations, drugs allergen and the skin prick test is negative for highly suspect for antigen. What the production should be taken to perform skin prick test? Is a physician procedure. The application, reading, interpretation should be performed only by specialists qualified and to perform them. Patient discretion to synthesize allergy, even in small amount, but a risk of the systemic reaction, therefore also for safety reasons. Should be at hospital with emergency equipment and medicine available, for example, adrenaline, steroids, and antihistaminic, with training staff for it to use that, and should not be applied to patients who have uncountable symptoms for allergy. What factors that can influence in the test result? For example, age. From 3 months old, the reaction papule or widow is in every time can be activity. Up to 5 years old, low skin reactive, but the patient has 5 years old and appear everything, okay? Have a reaction. You young children with predominance of erythema and skin reactivity decrease after 60 years old again. It's our patients from German patients, 5 years old, from Bahrain patients, 7 years old, from Brazil, 9 years old. Medicine. Some drugs inhibit the test reactivity, especially antihistaminic. Of course, the duration of the inhibition depends on the pharmacokinetic and the active metabolism each drugs. Class C anti-AG1 drugs reduce reactivity for several days, and it is recommended patients avoid antihistaminics for 4 to 5 days before applying immediate reading test. Ketotifen suppress the skin response for up to 30 days. And tricyclic antidepressant inhibits the well for a few weeks, depending on the patient's 3 to 4 weeks. Short courses of the systemic corticosteroid do not interfere with the skin reactive. However, application of topical corticosteroids for 1 week reduce immediately in the late phase of the cutaneous reaction. How does skin prick test analyze in the food? The food analysis investigation has been shown that the relationship between the skin reaction, of course, depend of the IgE level and the positive response of oral provocation. In a study, for the oral provocation test, observed skin prick test with a mean real in diameter of at least 8 millimeters for cow's milk, 7 millimeters for egg white, and 8 millimeters for the nuts, was 100% diagnosed for allergy reaction used the setting convention. Okay, in the children under 2 years, 6, 5, and 4 millimeters respectively. What is prick to prick? Okay, the prick to prick sometimes is a technique some allergists prefer. Is the most really used consumer performance a picture and a lens on the food just before perform the picture and on the patient's skin, and as it provoked to be practical technique reproductively resulted. For the allergies, more solid, consistent. For example, nuts can be mashed and diluted in 1 per 3 salines, okay? And the result showed better correlation with oral provocation. The disadvantage is no standardizations and the risks for hyperreactivity. For the analyzer with the medication, okay, is representative of the challenge in the allergens, especially when more the drug is involved. Hypersensitivity reaction to the drugs when a suspected IgE-mediated reaction. This possible when adverse reaction for the beta-lactams, antibiotics, neuromuscular, insulin, protamine, and the others. When these medicines are related to immediate symptoms of urticaria, angioedema, rhinitis, and the other anaphylactic symptoms. We need to pay attention in the reaction area to the medication. Skin prick tests with medication should be considered with great caution. They are absolutely prohibited in the patients with hospitalization history for the reaction to drugs, life risk reactions, and severe skin reactions such as Steve Johnson syndrome. Patch test is a topic contact test, is not traditional, but among development, they representative to food, allergy, and some medication. The appreciation of the patch test is still discussed of the allergy and time of application of the test on the skin. The problem is you need to wait for 48 hours or 72 hours, maybe. Can specific IgE be detected in vitro? Yes, for the radioallergen sorbent test, famous RAST. Is a critical promoter for the diagnosis of the IgE-mediated allergy. It's good for identify the sensitization allergy and to monitor the evaluation of the allergy disease, atopic disease, and manifestation possibility triggered by IgE body, such as insects, reaction to food, and eventually to the medicine. Determination of the specific IgE in several, but the last one can be read immediately. This production are often compared of the term of efficacy, sensitivity, specificity in the routine clinical diagnosis. In vitro tests is the disadvantages terms of is a conjunctival cost and sensitive for some arts. But there are good best alternatives such as patient use antihistaminic, patient with eczema, dermatographism, severe, post-anaphylactic shocks when in vivo tests may risk for systemic reaction in situations where it's important to confirm skin prick test and when there is not allergy strategy available. The result, the test is semi-quantitative and result were distributed in class, 0 to 6 class. Up to 3, you consider a positive test, but of course, depend the relationship between the clinical manifestation and the level of the IgE antibody must be stabilized. When you compare prick test and RAST, the both is efficient, prick test for agility, both is safety. When positive, when both these only analyze a probably allergy, RAS, you need fast at least 4 hours, as most common because skin prick tests don't have any same hospital, and skin prick test is more comfort than RAS. Others approach the diagnose IgE-mediated allergy sensitization. Okay, among the hypersensitive reaction conditions associated with type 1, occupy a prominent place due to their high incidence and the potential for severity. Due to the low serous level of the immunoglobulin, okay, I finished. I gotta finish. It's inflammatory mediated result of the cell granulation and basal fluid can be used for indirect method IgE detect. You can pay attention to this, first this, and highlight microarray is a good in the last 10 years. Is a blood needs is a good grade is because if you only do 20-30 of the serums for you quantify this and protein at the same time. In the conclusion, skin prick test must be first test that we must request of allergy patients, have a good sensitive and specificity. It has been fast and simple and safe, no pain. Is also important for formulating specific immunotherapy for the patients, and skin prick test must be done by a specialized physician at hospital. Key messages available, the skin prick test may favor bad practice, exaggerate inappropriate requests. Certain content must avoid such requests for a specific IgE reaction that are not mediated by IgE. For allergy, no patients has contact before. An agent that not induce the production of IgE, for example, DACE, painkillers, and anti-inflammatory. The select allergies is good relaxation for medical and physical examination. It specified IgE contribute to clinical practice depending on the criteria used for its indication, the technical and skill, and the laboratory quality. That's it. Thank you very much.
Thank you, Dr. Marcella, for this nice presentation. And please, dear audience, if you have any question, you can write on the question and answer box. From my side, I have one question. You have mentioned that age is one of the factors affecting the result. So what is the suitable age that we can transfer the child for the SPT?
The age for starts from 3 months. Okay, neonate is indetected. 3 months age is good. Up to 5 years, the papillus is not so much. You can see the papillus and the erythema, but you can use for all the ages.
Thank you.
Welcome.
Is there any question?
Yes, I have a question. Marcella, thank you very much. This is very nice lecture, enjoyable, really. I have a couple of questions. The first one is, give us an idea about the new trends or the trends that were started to be accepted.
Dr. Suhail, your sound is not clear. Can you adjust your sound?
I'm sorry.
Yeah.
Okay, let me just check that. Is it better now? Is it better now? Is the sound better now?
Yeah, it's better than before, but still.
صباح الخير كيفك حكيم؟ I don't know what's going on with this thing. Anyhow, Marcella, can you please give us an idea about what's the new trend in the management? I know that now they are shifting from skin injection sensitivity desensitization into oral type.
Dr. Suhail, sorry,
yes.
your sound still is not clear. So can you write your question and answer, and Dr. Marcella will answer?
Because is it better now?
Still there is, the sound is not clear, and we need to move to the second speaker. You can write your question.
Can you hear me now?
No, Dr. Suhail, still.
Can you hear me now?
You can write your question, Dr. Suhail, on the question box. Because the time we need to move to the next speaker now, and we will back to you for your question.
I'll change my microphone.
Okay, doctors, thank you for the opportunity to share so important subject.
Thank you. And now we will move to the second speaker, and it's my honor to present my colleague, Dr. Hassan Isa. Dr. Hassan is a senior pediatric gastroenterologist working in Salmania Medical Complex, and he will talk about child constipation, one of very common complaint and problem.
I'm back. Can you hear
and
me?
we will hear from him about his practical approach. Dr. Hassan.
Thank you very much, Dr. Muhammad, and the rest of the panel. Actually, I'll just share the slides now. A second. So I wish that you can see it. Dr. Muhammad, you can see now? Is that...
Yes, it's clear, Dr. Hassan.
Okay, thank you very much. And thanks, everybody. I know it's your precious time, the weekend, so I will try to be as practical and fast as possible. So we'll talk today about a very common problem that you will face definitely whether you're a clinic or the emergency, or I mean, maybe at your home also, if you have a child that is suffering with chronic constipation. Now, I don't have, oh, why it's not going to the next slide? Okay, no. So these are my outlines. We'll just talk briefly about the prevalence of constipation and what are the risk factors. How can we take a history from parents about, with a child with constipation, how we can do the examination, and how can we start treating these patients, and if there are any associated diseases. Now, for the prevalence. So I'm sure that you agree with me that constipation is very common, whether we as pediatricians or general practitioners, we see it a lot. Like, and we have certain percentage here, like it accounts for 30% of the kids. So it's very common, and in our clinic, like pediatric gastroenterologist, we see it in about 25% of the visits to the gastroenterologist, and for the general practitioner to reach to 5%. So it's like a considerable prevalence that we cannot ignore. Now, despite this prevalence, still our knowledge is not very really, I mean, enough to practice medicine with children with chronic constipation. For example, now we have a study here that's been done in Saudi Arabia on 850 pediatric caregivers, and including GPs and gastroenterologists, and they've been asked about the definition of chronic constipation, and the stool withholding, and the painful defecations or episodes, and still they found a significant gap of knowledge, even in the pediatric gastroenterologist, which reaches here around 50%. So we are practicing medicine, we are treating kids with chronic constipation, but sometimes we lack some theoretical knowledge about it, though it looks very easy. Now let's go to the definition of chronic constipation. Now the definition is can be actually referred to by a different way. Now the most commonly used and most adopted one is the Rome 4 criterion. We consider constipation as a functional GI disorder. So even if the parents insisted to search for a cause, you might not reach to the cause. So let's take this definition that's been agreed by Rome 4 criteria, which is the latest criteria used nowadays for chronic constipation. Now, for infants and toddlers below 4 years, which is the common age for constipation, and we can divide for those, it will be a little bit changed after the age of 4 years. Now, you need at least more than two of the followings over the last 1 month. So you need a 1 month period for duration for chronic constipation. Now, the child has to have less than or equal 2 defecations per week. So you can say constipation confidently if the child is actually passing less than 2 times per week. Now, if the child is having excessive stool retention, painful, hard stool, sometime with a large diameter, and sometime it will even block the toilet when he passes. So the mother will tell you that the stool might be huge, like an adult stool, and it's difficult to flush it. Now, for the children over than 4 years, it's not necessary to have excessive stool retention, but they will have like excessive violational stool retention. So it's just a minor change in the definition, but I mean, you can just follow the infants and toddler definition. So in summary, that you need like the child to, if he is passing less than 2 times per week over the last 1 month, that's enough for you to define, especially if the mother's says that the child is really straining while defecation. And sometimes they will tell you that my child is not passing stool over the last 2 weeks or 1 month, he did not pass any stool. Or sometimes they'll say it's like a pellet stool. Now, what are the different causes of constipation? The most common cause is the non-organic cause, followed by some like other few organic causes like Hirschsprung disease and hypothyroidism. This is a study from Iran on 556 children, and they found that 87 of them, they were constipated, and most of them are non-organic. So, and this is also another study from India, and showed that functional constipation, or the non-organic constipation, accounts for 87%, followed by like other Hirschsprung, anorectal malformation, spina bifida, cerebral palsy, celiac disease, and hypothyroidism. So let's say the most common organic here is like Hirschsprung. So if you're dealing with a child that's difficult to treat and he's not responding to your conventional treatment, then you think about Hirschsprung disease. Okay, and you can do the enema for him and send him to the surgeon. Of course, premature, they are more prone for any functional GI disorder. Patients with impaired neurological status, like cerebral palsy patients, hypothyroidism, those with the spina bifida or meningomyelocele, and children with some psychiatric disorders like autism. So now, let's move to the risk factors. Now, what are the possible risk factors for constipation? So this is a Turkish study on more than 1,000 child. They found that around 5% of them, they were constipated. And they found that the age group is like between almost after the age of 1 year, older than the age of 1 year. Of course, premature, they are more prone. Those with delayed meconium passage, with positive family history of constipation. Those who consume a lot of cow's milk, they are more prone for constipation. And of course, breast milk will be protective. The early toilet training is one of the risk factors, and less dietary fiber. Now, this is a study also from Italy, and it talks about the risk factor of constipation. And they said that family history of atopy is one of the risk factors, and less breastfeeding is also a risk factor. Now, and another study, like this is from Turkey, I think, and they said that enuresis is more common with those with constipation compared to the healthy, those with family history of constipation, and of course, the less educated. Working mothers will be having less children with constipation. I think I totally disagree with that. I think working mothers will be busy and the child will be constipated. Now, with the new technologies and the presence of the iPhones, iPads, making the child, of course, at risk of having constipation, because they would be really withholding their brain impulses to go to toilet. So they will be inhibiting it and delay the passage of stool. So they are more prone for constipation, and watching TV, of course, for us as old-fashioned people. Now, how can we take history from parents with a child with chronic constipation? There are certain questions that you can ask while you are in the basic clinic. Did the child pass meconium within the first 48 hours or not? Is the stool large or small in caliber? Was it hard? Also, some of the mothers will tell you he's passing normally, but in fact, even the normal stool for some children is considered hard. If there is any like fecal soiling, painful defecation, And if the child is actually trying to withhold his stool, like he will be dancing, having a bee dance in the house or going to one of the corners, and the mother will tell you that he's going to one of the corners and trying to start dancing. And if there is any blood mixed with the stool, any anal fissure, chronic abdominal pain, the child's appetite sometimes will be reduced. And also ask about the different types of foods that he takes and and if he is avoiding going to toilets or not. So all these are very important words in the history. And the Bristol chart is very good for it can help you in the clinic. So you can save it and keep it as a paper with you and just show the mother what does it look like, because this will save the mother time explaining what is the shape of the stool. So if you have like type 1 or 2, so this is definitely constipation, while 3 and 4 is normal, 5 is leaking fiber, and 6 and 7 is actually diarrhea. So this is the Bristol chart. Now, let us move to the more like other studies. This is a study from Shiraz, and they were also looking at the description of the mother. So of the mothers about children with chronic constipation. The majority said that they have a stool like a sheep dung. Okay, and بالعربي يعني يسمونه التبعر. So small pieces of stool. So he will be just passing small pieces or small balls of stool so many times in the day. Okay, so this is one of the things. And on the examination, they found a fecal mass on the rectum. Other clinical presentations here from North India, they found that delayed passage of meconium and fecal infections are more common with children with functional constipation, with organic constipation. Now, this is a study from Jordan by our colleague Iyad Tamimi, and he started also looking at the different presentations, and he found that fecal incontinence would be more in children in the school age group, and they will be also having urinary complaints and abdominal pain, while withholding behavior will be more with the preschool in the preschool age. So this is in the history. And now let's move to the sorry, it seems I missed the, oops. Oh, sorry, I'll go back. So this is in the history. Now let's move to the physical examination. Yes. So now on physical examination. So after you took a good history from the mother, now what you will do and look at in children with the chronic constipation, just focus on certain points like presence of abdominal distension. If you are lucky to feel some palpable fecal mass, especially on the left lower quadrant, examine the anal area and you see the anal sphincter, if the rectum is full or not, the presence of anal wink and cremasteric reflux. So these are important in examination. Then also Dr. Iyad Tamimi has actually did the examination for children, and he found that the most common thing is actually presence of fecal mass in the rectum in the preschool. And for infants, they will be very anal examination like skin tag or fissure. So this is in his study. This is a skin tag, and you can see the anal fissure. So the mother will tell you actually that what I can feel small skin protrusion in the anal area, and she will be really concerned. I noticed that in the parents. She will be really concerned about this, and just tell her that this is a sign of a fissure, and it will take actually time. Sometimes it won't go. It takes time to go after the recovery of the anal fissure. So just reassure her that this is not a malignancy or something that you'll be scared from. Now, the other thing, examine the back, look for any sacral dimple or any remnants in the back, and see if there is any hair tuft, or of course, meningomyelin will not be mistaken, it will be diagnosed immediately at birth. Now, do we have to investigate these children? In fact, most of these children, they will not need initial investigations if you are thinking of functional constipation. So the first visit, you don't have to do a lot of investigation. Just take the history, physical exams, try to treat. And if the patient is not improving, then you move to the other investigations like abdominal X-ray or stool for occult blood, barium enema, colonoscopy if that's really advanced, and investigate by barium study for Hirschsprung disease, or if it is so severe, you can go to the anorectal manometry or rectal biopsy. Most of us, I mean, we know how to read chest X-ray, but abdominal X-ray will be a little bit tricky. So this is the normal X-ray. Usually, normal abdominal X-ray, you will see that there is an air in the whole, let's say, colon, so on the ascending, transverse, and the descending, and the normal small bowels. But it is normal to find some stool in the rectum and in the cecum. So that's the normal finding. But look at this X-ray, straightforward. You can see a mass here in the rectum, a huge mass, and this is a sign of chronic constipation. And unless this mass actually passes, the patient will not improve. The other thing you can see here also, of course, the black will be the air, and like the shadow. This shadow is actually the stool. So you'll see the child is really full of stool. And even if they say that they are not really constipated or having diarrhea, sometimes the child is soiling. So it's a way that you can confirm your diagnosis if you are in doubt. But most of the time, you're not needed to do an X-ray unless it is really necessary. Now, the X-ray also will help you to diagnose some skeletal anomalies. Like, look at here there is the sacrum is there, but here you can see that the sacrum is absent. And this is one of the causes, the sacral agenesis. And I remember I've seen one child here in Bahrain, and sometimes it will be familial. So you'll have multiple families having, or multiple members in the family having sacral agenesis. Very tricky to treat. It's not easy. Now, and of course, Hirschsprung disease, if you have transitional zone in the barium study. And now let's move to the management. So how can we manage these children? Let's follow the algorithm of evaluation. So if your child is fitting the criteria for functional constipation, then you just assess for fecal imbection. If the child needs disinfection, you start with disinfection first, and then you move to the maintenance and dietary advice and follow up. While if he has any reflex signs and symptoms, then you investigate for the organic cause of chronic constipation. As easy as this. But just remember that disinfection is a 50% of the treatment. So try disinfect, not to give small doses of laxatives. Okay, so we'll move to the laxatives. Now we have different types of laxatives in the market. So the most common one here, we see the lactulose or Bifilec. Also, we have the milk of magnesium or Bolite. These are osmotic laxatives. Lactulose is quite weak laxative, and but it is palatable and can be, it has the sugar taste. So most of the infants, they like it and they take it, but it's very weak. Milk of magnesium is more strong, and of course the polyethylene glycol is also the best, one of the best laxatives. Now we have Movicol. Again, Movicol is equal to the Big Lick or the polyethylene glycol, but in small sachets. So it overcomes the issue of maintenance therapy for chronic constipation that you cannot do it actually with Big Lick. Now we have the polyethylene glycol with or without electrolytes, and this is one of the best laxative, as we said, and this is the Big Lick that we use for preparation for colonoscopy or for treating inpatients in the hospital, or sometimes even outpatients. So we have the mineral oils. These are also strong laxatives. They have the taste of oil, and the drawback is that it's not easy to clean it. So, and it's actually contraindicated for children who are neurologically impaired because they might aspirate the oil and cause pneumonia. So it's contraindicated for this type of group of patients. Now we have so many others in the market, like herbal medications, Agilax, Synacort. All these are stimulant laxatives and can be given, let's say, above the age of 12, and they are effective medications. Now, we have the Dalcolas or Bisacodyl. Also, this is another stimulant laxative, and especially the tablet. Nowadays, I started to use it more because some of the kids, especially like at the age of 10 or 12 years, they will say, we don't want to drink syrup, so I give them Bisacodyl, and it's very effective, but it can cause abdominal colic. Now, we have the enemas. For the enemas, I mean, we have the phosphate enema, saline enema, different types of glycerin enemas, so many enemas. And they need, of course, somebody who is skilled to give these enemas. Now, this is a study, but for the suppositories, like be liberal with using glycerin suppositories. They are very effective, less side effects, very safe, and you can use them more frequent. But on long run, they can cause desensitization of the rectal mucosa. but they are very safe. Now, this is a study done in Saudi Arabia and showed that most of the physicians, they use the lactulose and the glycerin suppositories, followed by phosphate enema. Of course, phosphate enema is contraindicated for patients with renal diseases. Now, we have also the fibers like the normicol, benefibers, and I noticed that some of the parents, they reported to me that they are very effective, even if they use the fibers alone. Nowadays in the market, we have the fibogel also, you can use it as sachets. But just there's one point that we have to remember, that if you give fibers, give more water, because they work if there's a lot of water as a laxative for the kids. So if you will give fiber, give more, like 2 to 3 cups of water with them. Now, the issue of probiotics nowadays also started to raise. Still, there are lots of controversies about their use, but you can try them if you have patients who is not responding to your conventional therapy. Now, the mother always will ask you about the type of foods that they can give. So which type of food, and they like dietary advices. So be very specific. Tell them that in general, anything that is white will cause constipation. And of course, fruits and vegetables, they are so mention to them, give, let's say, grapes, pears, kiwis, plums, beans, and of course, anything that's like brown bread, and etc. And try to avoid some like milk and dairy products, bananas, meats, and chocolates and caffeine, because they can cause constipation. Now, milk is a problem for me in the clinic, because most of the families, they think milk is good. Of course, milk is good for kids for calcium, but they continue giving milk for longer time, which causes kids constipation. And even if they say, oh, we are not giving actually milk, they will be giving like strawberry milk or chocolate milk. So it's at the end, it's all dairy products, and milk can cause more constipation. And this is also confirmed by studies in India, and they said that most constipated kids, they drink a lot of milk and they take baked items. So milk can cause also a problem. Now, let's go to the associated diseases. Sorry, I don't know what's wrong with that. So let's go to the associated diseases with patients with the chronic constipation. Now you will see, and I got a lot of referrals from nephrologists actually. So from nephrologists, that patients with enuresis, and sometimes from patients with, sorry, I just moved to the associated diseases. I don't know what's wrong with that. So yeah, I got so many referrals from nephrologists, and they said that a child with enuresis that is not improving. Unless you treat constipation in these children, the enuresis will not improve. So try to give more of like laxative for these kids, and they will be getting better. So enuresis is a very common, and this is also confirmed by a study from China, and that there's an association between constipation and enuresis. Of course, parents' anxiety is also one of the associated diseases. Now, I would advise you to go and visit this website, and it's very helpful actually for kids. You can advise the parents. Like there is a website called You Can Poo Too, and this is done for kids who cannot pass motion, just to support them and show them what is the mechanism and how they can handle this chronic disease. The other side is the Poo in You, and when you go to the YouTube, you will find a very nice video about it, and it teaches the kids how they can go and sit in the toilet the way, because most of the kids actually, they lean forward while they are defecating, while they should be sitting like straight and not to have any distractions in between. I mean, we should not put the parents in more stress. We should tell them that try not to, avoid any child abuse, because these kids are really prone for teasing by their peers. They might be spinning, they are soiling, so they need really a psychological support also. So I think I'm done. I'm done on time. So if I can receive a few questions, Dr. Muhammad.
Yeah, thanks, Dr. Hassan. It's an excellent presentation as usual. This is what we are expecting from the expert like you in gastroenterology, pediatric gastroenterology. And still the constipation is one of common complaint that we are facing in our clinic. And as you mentioned that detailed history is very important to reach to the risk factor and also to the diagnosis, and then sure you'll proceed to the management. We are looking if any doctor have a question.
If there's no question, I have a comment.
Yeah, Dr. Suhail.
Dr. Hassan, thank you very much. This is
gastroenterology coming from his practical approach.
Dr. Hassan, can you hear me?
Yes, yes, Dr. Suhail, I can hear you.
Perfect. Sabah al khair awalan. Thank you very much for this very nice lecture. I appreciate that in our symposium congress. I have a comment. I mean, you did everything perfectly. My comment is, I just want the audience to understand, as much as you focused on functional constipation, they should look vigilantly on a cause. For example, this week, I saw constipation diagnosed. I was able to diagnose hypothyroidism, eosinophilic gastroenteritis, anterior ectopic anus with anal stenosis. Nobody looked at the anus for 6 months, and redundant colon. These are basic problems with constipation before we call it functional. Please look at the anus. It's very important. The other thing I want to comment is major cause of functional constipation is lack of movement. And this is what we are facing now with COVID-19. Kids are at home, they are playing with computers. I see kids say, I have clinics, patients in my clinic, it's 8 to 12 hours a day sitting by the computer. And they come to me with chest pain, symptoms of reflux, symptom of upset stomach, and constipation. I turn them back to less computer games by asking the parents, make computer game half an hour as a reward for something they did, rather than staying with their games all day long. And I do see some improvement. This is stress on the colon. You know, these games are very stressful, and they are affecting these children. And I started to introduce it in my history. I started to asking about these games. I started to introduce it in my management of constipation. And I really do see changes, Dr. Hassan.
Yeah, totally agree with you, Dr. Suhail. Actually, yeah, we have so many risk factors. And we notice also some seasonal actually variation. And you will see that most of the kids, they come after Ramadan. Even the adults, they will, after Ramadan, immediately they will come with constipation. So totally agree. We have lots of risk factors, and we have to focus on physical examination. We should not miss any physical sign that will delay the diagnosis of organic cause. Yeah, I totally agree with you, Dr. Suhail. All bones are valid.
Okay, thank you for both Dr. Hassan and Dr. Suhail, our expert pediatric gastroenterologist. And please, Dr. Hassan, can you?
Yes. Yeah. Now let's move actually to Dr. Zakaria Hubail, and he is the consultant pediatric cardiologist working in Salmania Medical Complex. It gives me a great pleasure to introduce Dr. Zakaria. And Dr. Zakaria will give you like a brief about the tetralogy of Fallot. And yes, the floor is yours, Dr. Zakaria. Are you with us, Doctor?
Yes, I am.
Yes, okay. You can proceed.
Thank you, Dr. Hassan, Dr. Muhammad, for inviting me. I'll be talking about tetralogy of Fallot. Can you see my screen?
Still. I'm not seeing it. So, started sharing. Is it okay from your side? Yeah, now it started. Yes.
You can see it now?
Yes, I can see it. Yeah.
Okay. In the next 25 minutes to half an hour or so, I'll be talking about tetralogy of Fallot. I understand we have a mixed audience here, so I'm gonna try to make it generalized, simplified, and I'll throw in some entertainment every now and then just to spice it up. Congenital heart disease in general can be simply classified into three main categories. We have shunt lesions like atrial septal defect and ventricular septal defect. And another category are obstructive diseases like coarctation and pulmonary stenosis. And a third group, which is a very important and serious group, is the cyanotic heart disease. And in this group, we have tetralogy of Fallot as being the most common type, it has the highest incidence among this group. So we'll be talking about it. It's named after a French physician from the 19th century, Etienne Louis Arthur Fallot. And it is not a very common disease in overall, but among cyanotic heart diseases, it is the most common. Roughly, the birth incidence of this disease is about 1 in 3,000. So in a country like Bahrain, where there are about 15,000 deliveries every year, you expect to find about 5 patients born every year with this anomaly. It has a multifactorial etiology, like many other congenital heart defects. It can be associated with many chromosomes, including trisomy 21, Down syndrome, trisomy 18, 13, and other associations like charge and bacterial associations and other dysmorphic syndromes. And as far as single gene defects are concerned, the most consistent one and common is microdeletion of chromosome 22 on the long arm Q2211 deletion, popularly known as DGeorge syndrome. So what are the features of tetralogy of Fallot? These are the features. Tetralogy means 4. So one is pulmonic and subpulmonic stenosis. The obstruction can be at the valvular level, pulmonary valve, or the subvalvular level, or most commonly, a combination of the two. So pulmonic, which is valve, subpulmonic, which is muscle. There's a ventricular septal defect. It is usually large and located subarterially. And these are the two main features. Overriding of the aorta is because of this part of the septum is deviated to the right and anteriorly. So it pulls the aorta along with it towards the right side. So it tends to override the septum and takes origin from both the left ventricle as well as the right ventricle. And the last component to ventricular hypertrophy is a secondary component. It's due to the obstruction. The muscle just becomes thicker. So this may not be present initially or at birth, but it develops as the patient ages. There are also degrees of tetralogy of Fallot. It's not just one entity or one disease or one type. Depending on the obstruction, the most important feature is the obstruction in the right ventricular outflow tract. So if the obstruction is severe, you will tend to get less flow to the lungs and more shunting right to left. And the most severe one, when you do not have a pulmonary valve at all, is atretic. So that is pulmonary atresia. and the less severe one when you have mild stenosis. Most patients will fall in the middle with moderate to severe stenosis, and the mild stenosis actually may not even be cyanotic because they have enough flow. They still have the anatomy of tetralogy of Fallot, but they're not blue. So there are also the subtypes. The most common one is tetralogy of Fallot with pulmonary stenosis and subpulmonary stenosis. There's the pink tetralogy of Fallot I alluded to in the previous slide, and tetralogy of Fallot with pulmonary atresia, which is considered the most severe form of the disease. Another entity is tetralogy of Fallot with absent pulmonary valve syndrome. This is different from atresia. Here you have a patent right ventricular outflow tract, but there are no valve leaflets. So there is stenosis and there is regurgitation because there's nothing holding the blood back from going to the ventricle. And this is associated particularly with DiGeorge syndrome, and it has some other important features like very dilated branch pulmonary arteries. Tetralogy of Fallot in association with atrioventricular septal defect is particularly seen in patients who have Down syndrome. So the symptoms of tetralogy of Fallot may not be present at birth. Usually the murmur is present at birth because of obstruction, but oftentimes the obstruction is not severe enough at birth, and it becomes progressively more severe as the child grows. So they may not be cyanosed at birth, or they have just borderline saturation detected by pulse oximetry, but clinically the patient is not overtly blue. The cyanosis can be present as a baseline cyanosis, and in addition to the baseline cyanosis, they can have what we call hypercyanotic spells, meaning acute worsening of the obstruction leading to these features. They become, the children or the patient becomes hyperpneic, irritable, and deepening of the cyanosis. And the reason behind this is thought to result from subpulmonic obstruction. This is muscle here. In the area below the pulmonary valve, there is muscle. And the muscle, if it constricts or it goes into spasm, is going to limit the blood going to the lungs. And preferentially, the blood will be shunted to the aorta, and the child will become deeply cyanosed. So the way we treat this is to try to reverse this process. One of the maneuvers that we teach parents to do, and can be done also in the hospital, is the knee chest position. And older children can squat. And what that does is that it kinks the femoral arteries and increases the pressure in the aorta. So you increase the pressure in the aorta, it makes it harder for the blood to go to the aorta, so it goes preferentially to the pulmonary artery. The knee chest position in infants simulates the squatting in older children. One of the things also we always do is try to sedate this patient to reduce the irritability and hopefully reduce the spasm in the right ventricular outflow tract. Giving oxygen, of course, makes a lot of sense. These patients become acidotic because of hypoxemia and buildup of lactic acidosis in the blood. So correcting the hypoxemia will decrease the pulmonary vascular resistance and will ease the blood going to the pulmonary artery. We can also, by pharmacological means, increase the pressure or resistance in the aorta in the systemic circulation. The drug that we commonly use for this purpose is phenylephrine. It is a sympathomimetic alpha agonist. We can also give beta blockers, and the theory behind giving beta blockers is that they reduce the spasm and they relax the muscle in the right ventricular outflow tract. It can be quite severe and sometimes life-threatening. These spells, if not treated properly, and sometimes they do not respond to medical intervention, and urgent surgery has to be taken. The clinical features, beside the cyanosis, there is a right ventricular impulse and injection systolic murmur. Most of the time, the clinical suspicion of tetralogy of Fallot arises from a chest radiograph. And this is a classical chest radiograph that comes in textbooks and exams and taught to students and residents. The shape of the heart resembling a boot, called boot-shaped heart. The features are the following. This is the main pulmonary artery segment, and because of the stenosis and hypoplastic main pulmonary artery, this segment becomes deep and it's like punched out. The other feature, the right ventricular hypertrophy, causes upturning of the apex. So the apex, instead of being in the left lower border of the heart, it's turned upward. Other features that can support the diagnosis is the oligemic lungs. There is paucity in the vascularity of the pulmonary vascular markings because of the decreased pulmonary blood flow. Not all patients have this classical picture. In fact, there's a spectrum. All these 4 patients I'm showing you, the x-rays here, all of them have tetralogy of Fallot. This is the one on the left, in your left-hand side, is a neonate, and he does not have much in the way of boot-shaped heart. The main pulmonary artery looks okay, the apex may be slightly turned. The one next to it, you can see more upturning of the apex and more oligemia of the lungs. So that is a little bit more suggestive. The one next to it, the third one, is clearer. The shape is like a boot, and the one on the far right-hand side is the most obvious one. There is oligemia of the lung, apex is turned upward, and there is the concavity in the pulmonary artery segment. So you can have a range or a spectrum, even on the chest radiograph. They do not all look the typical shape you would expect in the textbook. One caveat, just because I get a lot of referrals for suspicious chest radiograph, the technique of doing the chest radiograph, the beam of the machine has to be perpendicular to the chest. If it is taken from angulation below, so the radiologists call this the lordotic view, it can make the apex look like turned upward and can give you a false impression of tetralogy of Fallot. So the technique is important. The definitive diagnosis, of course, is done by echocardiography. This is a subcostal view for a patient who has tetralogy of Fallot. I know most of you are not familiar with echocardiogram, so I'll just show you these structures. This is the right atrium, and this thing that moves here in the middle is the tricuspid valve, and this is the right ventricle. And the right ventricle, as you can see here, has 2 outflows. One is the aorta, because it takes origin partially from the right. This is the aorta. And the other one, which is smaller here, is the pulmonary artery. And there is a narrowing just beneath the pulmonary artery, and there's a hole here connecting the aorta to the right ventricle.
Doctor.
Yes? You can see it? The diagnosis can also be made in utero. This is a fetal echocardiogram in a pregnant woman. This is the left ventricle here. This is the right ventricle. There is a hole between them. That's the ventricular septal defect. And you can see the aorta is taking origin from both the right ventricle and the left ventricle. It's this is the septum. It's overriding the septum. The pulmonary artery is not shown in this clip here. So how do we made the diagnosis? So how do we treat tetralogy of Fallot? What is the treatment? Treatment is basically by surgery, that is corrective treatment, but there are sometimes issues with this. He cannot do it because the child is too young or too sick or he's too small. So we do some other things sometimes before going to corrective surgery in the end. Many centers now around the world are doing neonatal surgery, but other places do not have that facility or expertise in doing it, and it's done later on during infancy or early childhood.
Egg. عودة big egg. ما ان شاء الله زين عاد ما اعرف انا ما شفت ما لقيت.
Can we have the others mute, please?
Hello?
Yes, Dr. Zakaria, continue, please.
You can hear me clearly?
Yeah, I can hear you, yes.
And the video was okay, Sean?
Yeah, the video is slow a little bit from my side, but it should be okay.
Okay, maybe connection is not very good in your side. So medical management, we give beta blockers in the hope that they will relieve the outflow obstruction. They're not always effective. So when the patient has severe cyanosis or they have hypercyanotic spells, and they're not suitable for corrective surgery or it's not available, we do palliative treatment. And palliative treatments means we're trying to relieve the obstruction or provide enough blood flow to the lungs without actually correcting the anomaly. The earliest one done is shunt, and we'll talk about it in a minute. There are other procedures like balloon valvuloplasty, putting a balloon in the right ventricular outflow tract and dilating it. This only works when the obstruction is the pulmonary level. When it is subpulmonic muscle, it doesn't work because you inflate it, it deflates back again, it goes back to square zero. So it doesn't work very well when the obstruction is subpulmonic. Another palliation we'll talk about also in a few minutes, putting stents in the right ventricular outflow tract or a stent in the ductus. And of course, the definitive treatment is by surgery. The shunt, the classic shunt, and the modified shunt were first invented by a group of physicians in the 1940s. And it's named after Blaylock and Taussig. This is Helen Taussig, a cardiologist, and this is Alfred Blaylock, a surgeon, and it's named after them. It's called aortopulmonary shunt. It connects the aorta to the pulmonary artery. There is obstruction to the blood flow to the lungs, so we can bypass this by providing blood flow from one of the branches of the aorta, and here it's from the right subclavian artery to the right pulmonary artery. And this is a modified Blaylock-Taussig shunt. The original one was connecting the artery directly to the pulmonary artery. And Helen Taussig and Alfred Blaylock bear the name, but there's a major contribution from a third person who is not usually acknowledged. His name is Vivian Thomas, and because he was born black, he wasn't acknowledged properly. But nowadays we recognize his role, pivotal role. There was actually a movie produced a few years ago called Something the Lord Made, and it concentrates on the role of Vivian Thomas in doing the surgery, which was done in 1944 in Maryland, Baltimore, United States. And this is a picture of the room where it was made. I'll show you another movie clip about surgery, just to lighten the mood.
They won't page him. Why not? Something about hospital policy? I need Vivian Thomas immediately. What's wrong? What's happened? I won't tell you again.
We're only allowed to page doctors.
Vivian Thomas. Paging Vivian Thomas. You want it in OR right now. Come on, right. This is Blaylock. Thank you. Jesus.
About time, scrub up. Scrub up. You're coming in with me. Would you find Mr. Thomas something to stand on? What for?
It's not showing very properly, so I'll try to run it back again.
I'll see about this.
Should we say a prayer?
Forget it. He won't listen to me.
Dr. Blaylock, a word. You can resume your duties.
These are his duties. Can you see now?
Yes.
Okay, I think we're ready to start.
Okay. We're going in.
We're just fine.
Incising the mediastinal pleura from the main left pulmonary artery.
To the apex of the pleural space.
And dissecting the pulmonary artery.
Well back into the mediastinum.
That's all right, Vivian.
That looks fine.
A right angle clamp. Okay, I think it's holding.
Are you able to deliver the left subclavian artery?
I believe so. Blood pressure?
70, falling.
I do not move that line. Now, I'm dividing beyond. Clamp it.
I can't reach it, Doctor.
I got it. Hemorrhage control.
Can you see, Doctor?
Not really. Nurse. For goodness sake, can't you even see my ears? Surgeon.
Blood pressure 68.
Yes, beautiful.
Watch the carotid. Yes, traction on the suture.
Okay, now the clamp, Vivian, mate.
A clamp.
The one just right here. Yes.
We're about to connect the shunt.
Blood pressure 60. No, 59.
I know, I'm almost there. Now, front interrupted. Removing the bulldog clamp.
I see some bleeding.
No, I see it too. Suture. Suture.
Blood pressure is rising.
Evacuate the blood in the chest cavity, Bill. Put it in the chest tube. Ready for closure.
So another procedure is putting a stent in the right ventricular outflow tract, and this is done by catheterization. Ballooning doesn't work because the doesn't stay open, by putting a metal stent, like shown in this video, will keep the right ventricular after flow tract open. The disadvantage of this procedure is that it damages the pulmonary valve, so you cannot use it later on. So it has an advantage of avoiding surgery, but the disadvantage is that you lose the valve. And this is another procedure which is stenting the ductus arteriosus and keeping it open so that it provides blood flow to the lungs. Again, this avoids surgery. This is a catheterization loop. There's a stent deployed in the PDA and it's being inflated. It's a connection over the internet, so the video is kind of jumpy, not streamlined, but you get the idea. Not all PDA are suitable for this. So types.
5 minutes left.
There are types of PDA that you cannot do this procedure on, but if it is suitable, you can do this and can avoid surgery and provide blood flow to the lungs. But the definitive treatment is surgical treatment. And that will correct the underlying pathology, not just go around it and bypass it. And there are two components for the surgery. One of them is closure of the ventricular septal defect. This is done by a patch of usually it's a cloth-like material. It's sutured on the defect and it closes it. And over time, it gets covered with endocardium. And in addition to closure of the VSD, relief of the pulmonary and subpulmonary stenosis by dilating the main pulmonary artery and excising the excessive muscle bundle. So the survival of tetalogy fellow, this is a graph showing unoperated, untreated patient. The thick line here is the normal population. This is the survival for the normal population who do not have any disease. And on the left-hand side, there are different studies of tetalogy fellow. So you can see, so rarely they live above 30 years of age without treatment. With treatment, however, you can see that the survival is not perfectly normal, but it's much better. And we're seeing patients living to their 50s and 60s, and they're surviving. The long-term follow-up is needed for this patient because the fact that they were treated with surgery does not mean that they're fixed and completely normal. They still have complications. And this is a slide for a study that shows freedom from survival, and it's related to how the surgery was done initially. The one at the top was without a transannular patch, and the one at the bottom, which shows poor event-free survival, is because of the use of transannular patch. That's technique in doing the surgery. So what do we do as a long-term follow-up? We see these patients regularly. We never discharge them from our care. Most of them will have variable degrees of residual stenosis and pulmonary regurgitation. Right bundle branch block is universal in this patient. They can have also arrhythmia because of the scar tissue in the right ventricle. And they can have right ventricular dilatation because of both the pulmonary stenosis and pulmonary regurgitation. And these sometimes will need treatment, and they will need repeated surgery or repeated catheterization to take care of these complications. So this is my last slide, and I think I finished in time. We talked about the components of tetalogy fellow, its subtypes, some of these features and radiological features, palliative and corrective treatment, and what we do for long-term follow-up. Thank you all for your attention.
Thank you, Dr. Zakaria. It was really very nice. I like the video, also nice presentation, as usual. And I think maybe we have only a room for one question. If anybody is writing the question, nobody so far. So maybe in the chat. Now, yeah. So I will just ask you a quick question, Dr. Zakaria, because most of us are like a general pediatricians or general practitioner. When we see these patients with tracheophila, we'll see them like after the surgery has been done. So what are the precautions that we can, I mean, as a first liner, that we can take before we refer the case back to you, of course? Like if someone comes with diarrhea or fever or upper respiratory tract infection, how can we handle such patients?
Yeah, if the patient comes to you and he's repaired and operated and he's not anymore cyanosed and he's not taking any medication, they're usually doing okay. So they can be treated like any normal child. If they need the fluid or boluses of fluid or medication or antibiotics or beta blockers or beta agonists for asthma, for example, that can be usually given safely. If the patient has residual disease or they're taking medications, then you have to be a little bit cautious in some medical intervention that we give freely and we take it for granted for other children. For example, the use of beta agonist can cause tachycardia and they can cause arrhythmia. Giving boluses of IV fluid can overload the already dilated right ventricle. But most of the time, if they're not on any medication, they're usually fine and they do not need any specific precautions. If you're a surgeon and you're contemplating doing a surgical procedure in these patients, usually the anesthesiologist will ask for a cardiology review before. And if the surgery happens to involve the oral mucosa or dental, gums, upper respiratory tract, they have to be given prophylactic antibiotic prior to the procedure to prevent development of endocarditis.
Perfect, Dr. Zakaria. Thank you very much. I'm afraid that we have to move to the next speaker. And for any more questions, they can actually write it to the Q&A. So we'll move to the next speaker. Yes. So yeah, it's really a pleasure to present Dr. Hussein Hamdi. He's a consultant pediatric surgeon from the Royal Hospital for Women and Children. And he will be talking to you about acute abdominal pain in children. So the floor is yours, Dr. Hussein. Are you with me?
Good afternoon, everybody.
Good afternoon. Yes, you can start.
Is the voice clear?
Yes.
Okay, I'll just share the slides.
Mr. Hussein, can you be a little bit faster?
Mr. Ahmed, can you share the slides, please, from your side?
Yes, we will do. We will do.
Okay, so good afternoon, everybody. The topic that we are going to talk about today is acute abdominal pain in children. First, just to give some highlights why we chose to talk about this topic, because it's a very common topic which is shared by pediatric surgeons, pediatricians, and sometimes also the gynecologist. When we are talking about children in our area, we are talking about age from birth to 14 years old. But if we are talking about European countries, then we are talking about age up to 18 years old. So here in the lecture, I'll extend the age till 18, so we'll have much more of differential diagnosis and possible causes of abdominal pain in children, and that will help us to know more about what can the child present with. So let's start by definition. So acute abdomen is any serious acute intra-abdominal condition that present with pain, tenderness, muscular rigidity, and in which these cases needs emergency surgical intervention. Another definition is abdominal pain is defined as a sudden onset of severe abdominal pain less than 24 hours of duration. So what is the pathogenesis of the acute abdominal pain? Abdominal pain may be classified as visceral pain, somatoparietal pain, and referred pain according to the nature of the pain receptors involved. So it can arise from three origins, and this can give us different types of pain. So if we are talking about the visceral pain receptors, they are located in the serosal surface, in the mesentery, and within the intestinal muscles and mucosa of a hollow organ. The stimulus for these receptors is usually either chemical or mechanical stimulation, and visceral pain is usually dull, poorly localized, and perceived in the midline. So if the pain arises from the foregut structures like the lower esophagus, stomach, it's felt in the epigastric area. Pain from the midgut, like the small intestine, is felt in the periumbilical area, and pain from the hindgut structures is felt in the lower abdomen. So also the location of the pain where the child points the pain will help us to know where this pain arises from. So parietal pain is arising from stimulation of the parietal peritoneum. The stimulus is usually ischemia or inflammation, and also stretching of the parietal peritoneum. This pain is usually sharp, intense, and localized, and coughing or movement can aggravate this pain. So usually when you see a child with parietal pain, the child will try to stand still to avoid increasing this pain. Talking about referred pain is felt in a remote area which is supplied by the same dermatome as the diseased organ. And the clear example of that is patients who presented with pneumonia. They also presented with abdominal pain because of the shared dermatome, which is D9 between the lung and the abdomen. So we have also to keep this in mind because the source of the pain could be totally different from the cause or the site of the pain. So this table will show you the causes of abdominal pain in children. And here we classify abdominal pain in children by organs or systems like gastrointestinal, genitourinary, drug and toxins, liver, spleen, and biliary, metabolic, hematological, pulmonary, and other miscellaneous causes of abdominal pain. So under the gastrointestinal cause of pain, we have the most common cause of abdominal pain in children, which is gastroenteritis, followed by the most common surgical cause of abdominal pain, which is appendicitis. Mesenteric lymphadenitis, where now the name is changed to an acute non-specific abdominal pain, which represents about 60% of the cause of abdominal pain in children. And it was previously called mesenteric lymphadenitis, but the name was changed because to say mesenteric lymphadenitis, it means that you have taken a lymph node biopsy and you had also examined this histologically to find inflammation of the lymph nodes. So the name was changed from mesenteric lymphadenitis to acute non-specific abdominal pain. Constipation is one of the most common causes of abdominal pain in children. Abdominal trauma, intestinal obstruction, peritonitis, food poisoning, peptic ulcer, Meckel's diverticulum, inflammatory bowel disease, lactose intolerance, and intussusception. All these can cause gastrointestinal abdominal pain. Under the genitourinary, we have urinary tract infection. No, can we go back to the slide, please? We have urinary tract infection, urinary calculi. We have dysmenorrhea, mid-cyclic pain. So that's why I said we'll include the age until 18 years of age. Pelvic inflammatory disease, ovarian and testicular torsion, Especially testicular torsion, it's very common misleading that you have the child present with abdominal pain. So if you did not examine the genitalia, then you are missing the cause of the pain in this child. Hematocolpus and ectopic pregnancy can also cause abdominal pain in children. Drugs and toxins like erythromycin can cause abdominal pain, salicylic acid, and some lead poisoning as well. Hepatitis, cholecystitis, cholelithiasis, splenic infarction, rupture of the spleen, and pancreatitis. Under metabolic causes, we have diabetic ketoacidosis. So if you have a diabetic child present with abdominal pain, then you have to check his blood sugar and his blood gas, make sure that he is not in ketoacidosis as a cause of his abdominal pain. Hypoglycemia, porphyria, and acute adrenal insufficiency. Under hematological causes, very famous sickle cell anemia and sickle cell crisis, purpura, dehenexation purpura, and hemolytic uremic syndrome can cause abdominal pain as well. Pulmonary causes, and mostly this will be like a referred pain, like pneumonia, diaphragmatic causes, and pleurisy can also give abdominal pain in children. Under miscellaneous causes, we have infantile colic, which is very common in neonates. And the family complains a lot of the abdominal pain, that the child is crying and screaming all the night. So that is infantile colic. And we had a lecture yesterday about infantile colic, so we know much about it now. Functional pain, pharyngitis, angioneurotic edema, and familial methydarian fever. So this is one of the also common causes in our Middle East area that can cause abdominal pain in children. So now, if we have a child with abdominal pain, how we are going to evaluate this child? So first of all, we have to start by taking the history of the abdominal pain. Now, what we need to focus in the history is age at onset of the pain, because patient age is an important factor in the differential diagnosis of abdominal pain, and we'll see this soon in the table, how we can classify abdominal pain according to the age of the child. Onset of the pain, when the pain started. This is one of the difficult part of the history, because children sometimes they cannot verbalize, and the initial 24 hours of vague abdominal pain may be unreported or go unnoticed. So this can make these children present late, or they may present with complications. History of recent trauma, because trauma can cause the abdominal pain as the main cause of the abdominal pain. So if you did not ask about trauma, then you are missing the cause of the abdominal pain in this child. Precipitating or relieving factors. So as we said, parietal pain is aggravated by movement. So if you have a child with abdominal pain and he told you that when he moves, that abdominal pain increase, then you are talking about a parietal cause of this pain. Then you can think about the causes related to this. And if the pain is relieved after bowel movement, this usually suggests colonic source like constipation. So this can also guide you what is the cause of this abdominal pain. Associated symptoms. This is one of the important things that we need to ask about in the history, because associated symptoms can also direct us to the cause of the abdominal pain. So if the child presents with vomiting. So in the acute surgical abdomen, pain generally precedes vomiting, where in the medical causes it's the reverse. So it's important to ask the patient which started first, the vomiting or the abdominal pain. So if the pain is started first, then mostly we are talking about something surgical. But if the vomiting started first before the abdominal pain, then mostly we are talking about medical cause. See, simple question can help you to differentiate, is it medical or surgical cause of the abdominal pain? Bilious vomiting. Bilious vomiting is one of the red flags that we always talk about in pediatric surgical cases, because the patient who present with bilious vomiting usually have intestinal obstruction. So if we are talking about neonate 2, 3, 4 days old and present with bilious vomiting, then we have to talk or think about malrotation and volvulus, which is very serious problem, because when you have volvulus, you have obstruction of the superior mesenteric artery, which is very proximal obstruction, and that can lead to loss of the bowel from the second part of the duodenum till the mid-transverse colon if the child was not managed in the correct time. Diarrhea. Usually, diarrhea present as gastroenteritis or food poisoning, but can occur with other conditions as well. So not every child present with diarrhea and abdominal pain having gastroenteritis. You can have a child present with abdominal pain and diarrhea, and he has perforated appendix. He might have pelvic appendicitis causing him irritation and diarrhea. He might have an appendicular mass, an appendicular abscess. So diarrhea, yes, mostly with gastroenteritis, but also keep in mind that it can be a serious surgical problem as well. Bloody diarrhea is usually due to infectious disease or inflammatory bowel disease. Don't forget the red currant jelly stool, which is a sign of intussusception, but unfortunately, this is a late sign of intussusception. So if a child with intussusception presents with red currant jelly stool, it means that he has necrotic mucosa and means that he is delayed presentation. So if you have a child with intussusception and red currant jelly, you have to act fast and ask the surgical consultation immediately. Urinary symptoms as a cause of abdominal pain. So you have to ask about urinary symptoms like frequency, dysuria, urgency, and malodor of the urine. This all suggests urinary tract infection. Respiratory symptoms, because sometimes the child presents with pneumonia and abdominal pain. So the cause of abdominal pain is chest infection, not something related to his abdomen. So you ask about cough, shortness of breath, and chest pain. Fever is very important question to ask because this will tell you if this abdominal pain is due to an inflammatory cause. Gynecological history, as we said that we extended the age above 14, so we have always to keep these things in mind. And also our colleagues who is attending with us from the gynae can also get benefit because they can see adolescents who is above 14 up to 18 years and present with abdominal pain. So they have to include these questions as well, which is the menstrual history, contraception, amenorrhea, and mid-cycle pain. We'll have some more highlights later about these things, but if the child is 17, 18 years old and present with amenorrhea, then we have to think about ectopic pregnancy or disturbed ectopic as a cause of the abdominal pain. So if we did ask about menstrual history in the child, then we can miss the cause of the abdominal pain, which is clear that this is ectopic pregnancy. It's very important to ask about the past health history of hospitalization because sometimes the abdominal pain is chronic and recurrent and the child keeps admitted for abdominal pain many times and he will have recurrent history of abdominal pain and the child get admitted to the hospital, get observed, then discharged, then admitted again, observed, and discharged. So in these cases, you have to dig more in the history and ask and try to know why this child is having recurrent abdominal pain and why he is getting admitted frequently. History of significant illnesses, as we said that some hematological diseases can cause abdominal pains like sickle cell crisis. So you have to know about the significant illness in the child. Surgery is very important because if the child has an abdominal surgery before, then presented with abdominal pain and distension, then you might think about intestinal obstruction secondary to adhesions. So every part of the history that you ask about will guide you more and more towards what is the cause of this abdominal pain. It's important to ask also about drug use because some drugs can cause abdominal pain, or if the child has a previous condition and he related to his abdomen and he is on medication, then you have to know what he is taking. Family history is also important because, as we said, some diseases runs in families. So this will help you also to exclude some causes of acute abdominal pain in children. Now, this table will make things a little easy, which is classification of abdominal pain by age group. So when you have a child in this age group, you can think about mostly these causes of abdominal pain. So from birth to 1 year, we have infantile colic, gastroenteritis, constipation, urinary tract infection, intussusception, volvulus, and incarcerated hernia and Hirschsprung disease. Now, regarding incarcerated hernia, this is one of the common causes of abdominal pain in children from birth to 1 year. And let me tell you that it's one of the most common missed diagnoses because usually we don't examine the groin well. So if you examine the groin and you find a swelling in the inguinal area and the child is screaming of pain, then you can diagnose incarcerated hernia, which is irreducible hernia. So this will cause pain. Talking about children from 2 to 5 years, we are talking about gastroenteritis, appendicitis, constipation, urinary tract infection, intussusception, volvulus, trauma, pharyngitis, sickle cell crisis, and purpura. 6 to 11 years, gastroenteritis, appendicitis, constipation, functional pain, urinary tract infection, trauma, pharyngitis, pneumonia, sickle cell crisis, and purpura again. 12 to 18, appendicitis, gastroenteritis, constipation, dysmenorrhea, mid-cyclic pain, pelvic inflammatory disease, threatened abortion, ectopic pregnancy, ovarian and testicular torsion. Again, this table is a guide, but you can also still have mixed diagnosis between age groups. So you can still have a child who present with diagnosis which is related to other age group, but in different age group. But this always will guide you what is the differential diagnosis and what are the things that you need to think about in this child related to his age group. Now, after taking history, we have to go to the physical examination. And this is one of the things that we need to focus about because we have to examine the child carefully, fully. It's not only about his abdomen, and we have to examine the child head to toe and make sure that we are not missing anything. So first thing that when you enter the room to examine a child who has abdominal pain, you have to look to his general appearance. Because the general look of the child may give you an idea about his or her problem. As we said, if the child has a parietal pain, then the child will be trying to stand still. So he won't like to move because any movement will increase his pain. If you enter the emergency room and you find 9-month-old who is screaming and the mother is telling you that he has abdominal pain, then you might think about intussusception because the child will be screaming, then he will be quiet for some time, then he's screaming again, and this can tell you that, oh, this child might have intussusception. If they have a child with peritonitis, so the child, as we said, will try to avoid any movement, so not to increase his pain. The important thing also is to check vital signs. So if the child has fever, so this indicates underlying infection or inflammatory cause. If the child is tachycardic and hypotensive, so we have to think about volemia, hypovolemia, which could be abdominal trauma causing bleeding or disturbed ectopic pregnancy. The respiratory pattern also in a child, so if we have cosmal respiration, so this might direct us to diabetic ketoacidosis. So everything that we see in the child will help us to know what is the possible cause of abdominal pain in this child. Then we'll move to abdominal examination. One of the very important techniques to examine a child is to distract the child, because the child will be irritable sometimes, he will be scared, he is in the hospital, he is afraid of injections, he is not in his normal condition, so the child will not be cooperative. So it's very important to distract the child. Before you examine him, talk to him. Start any conversation, talk about school, talk about his brothers and sisters, talk about what he likes, what he doesn't like. Don't go directly and examine his abdomen, because if you started doing this, so you will get nothing of his abdominal examination, because the child will be afraid, will not be cooperative. He will have some sort of guarding, voluntary guarding, because he doesn't want anybody to touch him. So involve the child with your examination, talk to him and take him through the examination, then things will be easier. So we start always by inspection. So what we are looking is for, by inspection, we start looking for distension, previous scars or previous surgery, hernia is very important, not to forget dilated veins and so many other things. The child should be asked to locate the site of his pain by one finger only. And this is very important for you to know what is the cause of the pain, because as we said, if he directed his finger to his upper abdomen, then we are talking about things related to stomach and esophagus, mid of the abdomen, around the umbilicus, small intestine. If he's talking about left side, then we are talking about colon. Right side, then we are talking about appendicitis, Meckel's diverticulum, and this will help you a lot to know what is the problem with the child. So after that, when you start palpation, you have to start away from the site of the pain, because if you started from the site of the pain, then you will lose the trust of the child and you will not be able to complete your examination. So you are always looking for tenderness, guarding, rebound tenderness, and rigidity. Then percussion, we are looking for rebound tenderness. And this is one of the important techniques to use to check rebound tenderness in children, which is by percussion. So surgical examination in children is different than adult, that you put your hand in the right iliac fossa, press hardly, then suddenly release your hand. This is very painful to children. So what we do is that you percuss on the area that you find tenderness, just to find if there is rebound tenderness or not. Auscultation, we usually talking about bowel sounds in children to see if the bowel sound is sluggish or hyperactive, to tell you if it's something related to the bowel. Rectal and pelvic examination, and usually this is the most part that get missed in the examination, because we tend to ignore it and we say, yeah, fine, it's not important. But actually, it's very, very important, because rectal examination can help you to find tenderness, sphincteric tone, and the presence of mass stool and melena. Imagine if you have a 10-year-old child present with abdominal pain, you examine his right iliac fossa and he has just a mild tenderness. But when you do BR examination, you have him very tender in the right side. It means that this child has pelvic appendicitis. So it's very difficult to detect this through the abdomen, but rectal examination can help you to detect this. In boys, it's very important to examine external genitalia, as we said, because testicular torsion can present with only abdominal pain. So if you did not examine his genitalia, then you are missing testicular torsion as a diagnosis of abdominal pain, which need immediate surgical intervention. Otherwise, we'll go into ischemia and we lose the testes. Also in girls, it's important to examine the vagina for vaginal discharge, vaginal atresia, and imperforate hymen. We have seen this many times, that the child has years history of abdominal pain and has seen so many times in so many places, and they miss the diagnosis of vaginal atresia or imperforate hymen. And if you ask specifically about the character of the pain or the nature of this pain, the child or the family will tell you that the girl has cyclic abdominal pain every month, which lasts for a few days, then it disappears, and she did not start her menstruation. So if you examine the vagina, then you can find vaginal atresia or the imperforate hymen, then you can start the management and solve the problem. So missing a small part of the examination can let you miss the diagnosis, and will let the child suffer for a long time before he gets the diagnosis and management.
2 minutes left, please.
Yeah, fine. Special signs that we are talking about, like ileocecal test or obturator's test for retrocecal appendicitis or ileocecal abscess, positive Murphy sign in cholecystitis, and Colles signs in intraperitoneal hemorrhage. These are the important investigations that we always need to ask about, which is CBC, inflammatory marker, liver function test, renal function test, electrolytes, lipase and amylase. Beta HCG is important, blood culture, urine analysis and culture, stool analysis and culture. Then radiological examination, we always start with abdominal X-ray, just to get the gas distribution and if there are air fluid levels, and if there is fecal loading, chest X-ray to help us to see if there is pneumonia or air under diaphragm in case of perforation. Ultrasound abdomen and pelvis. This is the most common diagnostic radiological tool that we use in children. CT scan is rarely used in children, and there is also always a debate about the amount of radiation the child has. So this X-ray showed multiple air fluid levels as the cause of abdominal pain with intestinal obstruction. Here we can see air under diaphragm as perforated bowel. And this is an ultrasound show target sign of intussusception. So radiology is very important to help with the diagnosis of children. How to manage? We have to identify and manage the underlying cause of abdominal pain. Serial physical examination may be the key for diagnosis. Analgesia, that is very important to give a child with abdominal pain. Analgesia, don't wait to get the diagnosis. Analgesia will not change the picture, will not change the diagnosis, but it also helps the child to get relief of the pain and help you to examine him well. Antibiotics, usually don't start antibiotics until you have proof diagnosis that you have an inflammatory or infective cause. And early surgical consultation is indicated when the child has something related to surgery. And these are the most common indications for surgical consultation: severe or increasing abdominal pain with progressive signs of deterioration, bile stained or fecal and vomiting, involuntary guarding and rigidity, rebound tenderness, marked abdominal distension, signs of acute intraperitoneal bleeding, significant abdominal trauma, suspected surgical cause of the pain, abdominal pain without an obvious etiology. So this is just a summary.
Sorry to interrupt you. Yeah, sorry to interrupt you, but the time is over. So
yeah, this is the last slide. This is just a summary of what we have said, so we can finish and go to the next slide, and that's it. So this is the conclusion. So as we said, history and physical examination is the most important key to diagnose abdominal pain in children. Thank you very much for attending. Sorry for being long, but as you see, the topic is heavy. And if any questions or comments, please.
Yeah, thank you very much, Dr. Hussein. Yeah, I really enjoyed your talk. So I think there will be some questions in the Q&A. If you don't mind, if you can just directly answer them, because we have to move to the next speaker. Okay, thank you very much. Have a good day.
Thank you.
So now we'll move to the next speaker, Dr. Sadiqa Hussein. Please, Dr. Ahmed. Yeah, so Dr. Sadiqa is a consultant psychiatrist from Gulf Complex Medical Units Management in Bahrain. She'll be talking today about coping with stress, which will everybody need nowadays, and that's including COVID-19 era. So please, Dr. Sadiqa, the floor is yours. So, Dr. Sadiqa, we can't see you. And I can't hear you too. Dr. Sadiqa, can you hear me, please? Hello? Hello? Hello, Dr. Sadiqa, are you with us? Hello, hello. Dr. Ahmed, can we move or? Dr. Sadiqa?
Dr. Sadiqa, you can't hear us? But your sound is not clear for us.
Yeah, I can't hear you.
Yeah, me also.
Maybe there is a problem with the mic or?
Can't talk now, Dr. Sadiqa? We cannot hear you. No, still your sound is not clear. There's no sound. I think maybe you are choosing mic or the computer mic. You can't change between them.
I'm not hearing Dr. Sadiqa. So what can we do, Dr. Muhammad?
I'm calling here. Dr. Sadiqa, yeah. انت حاطه شنو على الكمبيوتر ولا من الموبايل؟ خليه من الايفون بالله الصوره مالتك. استعدادات عندنا هي موجوده ارسلتيها؟ اوكي ما في مشكله. ادخل من التليفون.
Now we need to cope with the stress.
This is one of the stress, yeah.
Okay, now we can see the slides.
Yeah, it's from our side.
Yeah, the slides are clear, but the voice of Dr. Sadiqa is not visible.
Yeah, she's now entered from her mobile.
Hello?
Yes.
Now you just remove your computer completely, or you close your computer, please.
Okay, I leave computer.
Okay, you can start, Dr. Sadiqa. Okay, everybody.
1 minute. Sorry. Sorry for this. Leave meeting. Okay. Yeah, you can hear me now, no?
Yes, we can hear you. Yes.
Very good. Sorry for this. I know it's Friday afternoon. I'll try my best to be simple and straightforward and not take much time and try to learn few words at least by this session. Today we are going to talk about coping with stress, which is really very important. COVID-19 part of it. If we learn how to cope with stress, we can learn to do so many things in our life. So today I'm going to acknowledge the causes of stress, learn what stress can do to your physical health and mental health, and help you to learn practical skills for dealing with stress. So there's 3 simple objectives I'm trying to cover. Causes of stress can be major threats and can be minor. Cause of stress, it can be domestic violence, a drug, at family, war outside home. School closing is a major, not minor, it's a major problem. Overwhelm at work, displaced from your home, being ill, seriously ill. All these are major threats causing major problem. Well, we have some minor, like argument at homes, uncertainty about future. All these are minor, but they are stress, and we need to learn how to cope with it. We have to know that 7 strange things stress can do to our body. We have to know, even for our physician, for pediatrician, it's really important. First of all, muscle and joint. Stress can cause pain and tightness and soreness in your muscle, as well as a spasm of pain. It can lead to flare-up symptoms of arthritis, fibromyalgia, and other conditions. It's because of lowering the threshold of the pain. According to American Psychological Association, when you experience stress, your muscles tense up altogether. When stress goes away, your muscle releases the tension. Always you can find those people in physiotherapy, in Institute of Physiotherapy, they go for muscle pain. Only back pain they have. It's because of stress. The second part of the body which will be affected, it is the heart and lungs. This situation makes your heart rate increase. Too much stress, hormone cortisol, make heart rate and lungs worse. Arrhythmia can cause arrhythmia, abnormalities, high blood pressure, stroke, aggravate the symptoms of asthma. Alongside the condition, stress can cause shortness of breath and rapid breathing. The third part of the body which will be affected by the stress is the skin and hair. Nowadays, there are so many hair products dominate in advertisement. However, if you are stressed, those products won't do much to help the condition of your skin and hair. If you have a skin condition such as eczema, psoriasis, stress can make it worse. It also leads to hives and itches, excessive sweating, and hair loss. I mean, if you are under stress, you present to the dermatologist with so many products, but it will not help you. It will not go. It's always there. So you need a psychiatrist as well. Number 4, it is gut. It is really common in children. I don't know why Dr. Hussein missed this aspect of psychological aspect of children. Abdominal pain, it could be one cause. It is psychological stress. The children, they do present to the GP and pediatrician with early morning pain, abdominal pain, only mainly in the morning. They don't want to go to school and they are complaining of abdominal pain. And most of the investigations shows that they are normal. It takes a while till they be referred to the psychiatrist. Abdominal pain, it is very common among the kids. It is also common among the adult. There is correlation real because stress shows in your digestive system, from simpler systems such as pain, gas, diarrhea, constipation, and more complex like bowel syndrome and acid reflux. All this because even peptic ulcer can cause by stress. When stress may be tendency to make you tendency to eat more or less. It can lead to, if stress is more, you can even vomit too. So don't underestimate stress. Always remember gut problem, GI problem, especially kids with abdominal pain. The best solution for it is family therapy. I don't want to forget about it. The 5th problem causes by the stress is shoulders, head, and jaw pain. Again, we see these people in dentists and in physiotherapy. We used to get referral from the dentist, jaw pain, chronic jaw pain. They have severe pain in their jaw. The effect of stress in your body can move through the tension triangle, which includes shoulder, head, and jaw. Stress can trigger tension, headaches, tightness in the neck, jaw, and node spasm in your neck. The 6th thing is immune system. It's really, really important, especially nowadays with COVID-19. You can see all the family, they have the virus, but some people, they are getting very sick and other people, they die because of stress, who are under severe stress because immunity is low. You must not be under stress so you can help yourself to fight with COVID-19. You need a strong immune system to fight disease, but stress weakens your body's defense. It makes you more likely to catch a cold or flu. For example, Werns, Dr. Lang, he said it is also make autoimmune conditions such as lupus and inflammatory bowel disease worse. I mean, even COVID-19, once you are stable, once you are not stressed, you can fight with the COVID-19. Number 7 is mental health problem caused by stress, depression, anxiety, irritability, which is easily provoked to be anger, low sex drive. You can see your husband has been changed for the last 6 months. He's not like before. He has been changed. 20 years he has been okay, but now he is not like before. Memory and concentration, you cannot remember where you put your keys, what was your plan, where you want to go. Compulsive behavior, you buy and sell, you do shopping therapy, and you buy things you don't need it. And mood swings. Depression, it does affect your relationships with your boss at work and with your wife and with your kids at home. It's mainly a relationship problem. So I covered the 2nd objective. Now we are going to talk about stress. You have to know that these power thoughts and feelings are nature part of stress. We cannot live without stress. Stress is always there, always there. The problem is if it is hooked we are hooked by certain feelings and thought. We have to know about, they are different between stress and hooked. You have to know that you are hooked now. You have to know what does it mean hooked, and we are trying to give some practical tools to get rid of hooked ideas. Hooked mean that difficult thought and feelings are always with you. At one moment, you might playing with children and smiling. Another moment, you can be hooked and be angry to them and just withdraw from the family and your colleague. Changing. So those difficult thoughts and feeling hooked pull us from our values. So number one, what are values? We have to know what are values. Values mean deepest desire, the sort of person you want to be. You want to be a gentleman, kind, quiet, cooperative, giving, but unfortunately, sometimes it cannot be because of stress. You want to be living, loving, wise, attentive, persistent, calm, caring, protective. This is what you want to be. But stress will not allow you to be like this. You think you want to be like this gentleman presenting yourself in the community, but unfortunately, you will present differently like this anger man. This anger man has been hooked by his thought and feelings. He has stress problem. He needs to learn how to cope with his stress. And this is not acceptable, of course. How to cope, how to learn? First of all, we need to learn how to focus and engage and pay attention to learn what we are hooked with. To learn the simplest things to engage, it is just drinking a coffee. A simple practice. Take a coffee, take it step by step. Don't just drink it. Learn how to drink a coffee. First, you have to check the temperature. Yes, by holding the mug, by drinking slowly, you will learn how to focus. You will engage movement from the throat to swallow. Then test the feeding from your tongue as you swallow. Again, take another steps. So you will learn how to engage and focus. So this is one practice. Try to enjoy your food, your drinking, so you will learn how to engage. So sometimes it is too much, stress that you cannot even get engaged. It is very hard because tremendous of painful memories, fear of future, painful feelings, anger, fear, sadness, too much stress. So sometimes they are overpowering you, so-called emotional storms. Emotional storms mean that experience intensely difficult for thought and feelings. They are so strong and they are likely a mighty storm. And they can easily overpower you. You cannot focus on your food and drink. It is very hard. So in this stage, we have to learn some techniques. It's called grounding yourself. Connect to your body. Try how to learn how to feel comfortable. First of all, connect to your body. Be yourself. Feel that you do exist in this world. Be real in this world. If you feel that you are derealized, you are not exist, you don't know if you exist or you don't exist. First of all, you have to feel that you do exist. You can go to a quiet place, any place, even in the washroom. It happens during presentations, in the classroom, anytime. You can go directly to any quiet place. Washroom is good, especially if you open the warm water. It's running warm water. It makes you to feel calmer. First of all, grounding. How you can connect to your body? First step, you need to notice your feelings and thinking. Slow down and connect to your body. Slow down by breathing. I'm going to talk about breathing process now, how we can do the breathing. Second things, just empty your legs. It's better to be empty your legs and refill as slowly as slowly. Slowly press your feet into floor. Third things, just stretch your hand and slowly press your hands together. Breathing, it is very special technique, very simple 5, 4, 3, 2, 1. It just take a deep breath for then 5 seconds. Set 5, 4, 3, 2, 1. Hold it for 5 seconds. Again, 5, 4, 3, 2, 1. Breathe out again for 5 seconds. 5, 4, 3, 2, 1. Make it slowly within 5 seconds. Continue this pattern of breathing until you feel calm down. This breathing, it will not learn you how to cope, but at least make you to connect to your body and make you to feel safe. First of all, you have to feel safe, that there is no threat outside. Again, once you connect it to your body, another tools you have to learn, it is called again 5, 4, 3, 2, 1. Once you connect it to your body, try to focus again try to see 5 things around you. It will be very simple things. 5 things around you. Just focus. Okay, there is a wall, there is a door, there is a person, there is a water, there is a tap. 5 things. If you focus 5 things, then move to 4 things you can touch. 4 things you can touch. 4 different things. Then move to here. Try to hear 3 things. Your voice, your friend's voice, water voice, your shoes, your walk, anything you can hear. Then try to smell 2 things. Any smell, you soap smell, any smell, 2 smells you can smell. Then try to taste 1 thing, anything you can taste it. So again, there is another exercise, 5, 4, 3, 2, 1, to reconnect with your body and focus. Grounding is always, remember, to help you to feel safe. Grounding is really very, very helpful. Then unhooking. Unhooking, how they present unhooking. You have to know that unhooking present, they abuse alcohol, they do isolate themselves, especially in children. They don't play with other children. There always be argument between couples, or a person will be argumentative. Spend more time in bed. This is very common that you see people spend more time in bed. This is called away moves, because we act like this, being away from stress. This is not a solution. It is a behavioral. We need to find a solution. During unhooking, you need to notice those that you are really, I'm hooked with thought and feelings. Now I need to unhook myself. You need to name those feelings and refocus on what you are doing. So now we have talked about 2 tools. One is grounding. Second tool is hooking and unhooking. Slow down and connect with your body, refocus and engage with the world around you, unhooking yourself from thoughts and feelings. Of course, this all needs to practice. It won't be easy, like building a muscles. It cannot be by just hearing this lecture. You need to practice. You need to attend therapy if you could not do it. You need 10 to 12 sessions to learn how to cope with your stress. When you finish grounding and unhooking, there is, and it is more severe stress, you need to act on your values, on your personal values. What are your personal values? Values are different from the goals. Goals are something to achieve in future. But values, you need to, you're a person you want to be, like freedom, persistence, courage, curiosity, creativity. These are my values. You should keep your values. In all situations, try to learn how to keep your values. Be yourself. Don't be out of your character. For example, if you are jobless and you want to get a job, your goal is to get a job, but there is no job. If there is no job, don't change your values. Try to be supportive and loving to your friends and family. Don't change your values. Don't be aggressive towards them. Don't let your thought and feelings affect your values. You should separate your feelings and thoughts from your values. Keep your values with you. If it is more hard, more stress, try to be kind to yourself and others. If you go to Europe, everywhere is written, every little helps. It is really good things. Smile, smile. We have in Islam, كلمة طيبة صدقة. Every little helps. Smile. At least try to smile to people. If you smile to other people, they will give you a positive energy. You will get some energy. You need that energy. Try to be kind to yourself and others, even if you are living in a tremendous stress. Last thing is making room. You have to learn this skill. This is very important. I mean, you have to act like a sky. You have to be like a sky. No matter how the severe weather, the sky has room for it. As the sky never be hurt or harmed by the weather, whether is intense heat, freezing, always the sky can contain all type of weather. As sooner or later, the weather always changes. Our thought and feeling like the weathers. And we can learn to be like the sky. We have to be the sky. Make room for the bad weather of our difficult feeling and feelings without being hurt by it. I mean, it is just like we have to be like sky. Try to contain different types of feelings, happy, sad, freezing, different things. Remember, the journey of 1,000 begins with one step. You have to practice. It's like building muscle. More you practice, better you become. A tiny seed grows into a mighty tree. We have to sum up. Coping stress, it's first of all grounding. Grounding is me connecting to yourself. Breathing is very important. 5, 4, 3, 2, 1. 5, 4, 3, 2, 1, and focus again. Unhooking, you have to sit and realize what are you hooked with your thought and feelings. Try to name them. If you could not, try to attend with therapists to help you to name those feelings. If you could not find the feelings, I mean, you are just unwell, you are isolating yourself. Acting on your values, never be out of your character. Try to be yourself, be kind, try to give as much as possible. Every little helps. Don't say this smile does not help. Yes, it does help. Try to make room for every single thing. Try to be like a sky. The weather, you're feeling just like a weather is changing all the time. We have different types of feeling and try to be like a sky. I mean, coping stress with the stress, it's a huge subject, but you have to learn that connecting to yourself, be yourself, connect to your body first of all, then realize the thought and feelings that you have. Try to name them. If you are anger, if you are disappointed, if you are feeling failure, try to name those. So we can, help yourself and try to find abnormal behavior that you are doing. So try to be yourself. So final, I have to say thank you to you. I want to say thank you to teacher. I miss you all. We are passing through a very difficult time, but be yourselves. Don't be out of your character. Sorry, I have been very fast today. I just finished. I have been very fast because I know it's Friday and I missed some things.
It's been fine, Dr. Sadiqa. We really enjoy your talk.
Thank you very much.
Thank you.
Sorry, I don't know how much I have taken. I don't know.
It's okay. We have 2 minutes left, actually.
Okay. Thank you. Okay, I just finished. But if you have any question, let me know, please.
1 second. Let me check the Q&A. Okay, so far.
Sorry, I've been very fast.
No. It was fine. It was really fine. I mean,
good.
I was just closing my eyes and listening to the way you were talking about stress and how we can handle it. Was really helpful.
Alhamdulillah.
Yeah. So
thank you. It's really
you made a big change in the schedule instead of just talking about pure like medical things. I mean, that's what we need nowadays.
Yes. Always keep it in your mind. Yes.
Actually, Dr. Fadila was saying that this is mindfulness, slow to smell the roses and to enjoy the smell of your coffee. Very timely presentation. And she's thanking you also. And so many people are
Thank you
thanking
very much, Dr. Fadila. We miss her.
Okay, have a good day. And Dr. Muhammad, we'll move to the next speaker.
Yeah, thank you, Dr. Hassan, thank you, Dr. Siddiqa. And now we are reaching to the last speaker in the pediatric session, but it's not the last day, it's just the pediatric session. After the pediatric session, we will move to the infertility session. And our next speaker is Dr. Omar Al-Masri. He's a consultant pediatric nephrology in Sheikh Khalifa Medical City in UAE, and he will talk about very important topic, the proteinuria in children. Dr. Omar, the floor is yours.
Assalamu alaikum.
Alaikum salam.
Can you all hear me?
Yes, your sound is clear.
Okay. So my name is Dr. Omar Al-Masri. I'm a pediatric nephrologist in Abu Dhabi, Sheikh Khalifa Medical City. And I'm really honored to join such a great group of physicians with important topics. And it's really difficult to speak after such great speakers, actually. So I'll do my best. My topic today is, I hope, going to be interesting and practical, and some important piece of information will be learned and remembered for the practicing general pediatrician. So it's about proteinuria in children, and it's one of the reasons why we get referrals. And hopefully, during today's talk, we will basically go over introduction about the structure of the functioning unit of the kidney, which is the nephron. Specifically, we'll focus on the filtration barrier so that we understand proteinuria. And we'll understand how it happens. By the end of this talk, you should be able to understand the definition of proteinuria, types of proteinuria, what is pathologic and what is not pathologic. And I will also, by the end of this talk, give you a very important tip, what I call it the 5 pillars of nephrology, how to identify a child with a high risk for a kidney condition. So bear with me until the end of this talk. And this is kind of an afternoon, so grab your cup of coffee, speaking about the smell of coffee, and I hope you enjoy this talk. Now, in general, looking at the screen for a long time this afternoon, I like to remind you all about the rule of 20. So every 20 minutes, remember to look away from the screen for approximately 20 seconds and look at an object that is at least 20 meters far away. So if you haven't done it already, please do it. You can feel free to stand up, take a deep breath, stretch your back, and so we can go on with my talk. Since my talk will be starting with, unfortunately, reminding you about the basic medical science, I'll try to keep it as simple as possible. So the structure of the nephron, I like to simplify it with this diagram. So this diagram of how the nephron works, it has 2 parts. The part which is here resembles the glomerulus, which basically splits the plasma from the cellular elements, and it will filter plasma, leaving behind the protein. So this is an important part here. And then the processing of the filtrate, including reabsorbing most of it. And whatever is left behind here is the urine. Can you see the pointer, by the way, as I'm doing it? Is it visible to all of you when I point somewhere here on the screen and the slide?
Yes, Dr. Omar, yes.
Good. So the philosophy of the kidney function is fascinating. We say, subhanallah, where basically it's an organ that basically modifies the definition of waste from minute to minute, where water in some circumstances can be in excess, so it can be a waste, or it can be in high need, so it is not a waste, it is conserved. The same thing applies for a lot of other things. So the design of the kidney is absolutely amazing. So this is the part which we're going to focus on, which is basically creates the filtrate, and it's the glomerulus. And this filtration barrier, going back to the histology, is mainly the basement membrane, which we can see in yellow. From the blood side here in red, the basement membrane is lined with fenestrated endothelial cells. From outside, it's covered by epithelial cells called podocytes. And these are ultra sophisticated, highly differentiated cells. From their name, they look like octopus actually, or like food processes. And it has a cell body, and it has extensions and secondary extensions that wrap the capillaries to strengthen the structure of the capillary and add to the filtration barrier and create what we call interdigitation between the food processes. And this little gap between the fingers here, or the food processes, is actually bridged by something called slit diaphragm. So this slit diaphragm actually takes important part and role actually in the prevention of proteinuria. And some of the proteins that take part of this structure here and the structure of the cytoskeleton in the podocytes or adhesion molecules, if any of these proteins is missing due to a mutation, that will result, as you would expect, in proteinuria early in life. That would be called something like congenital nephrotic syndrome, infantile nephrotic syndrome, or later on it could be steroid-resistant nephrotic syndrome. All right. So this is the beautiful filtration barrier, and we talked about the mutations that could take place in different type of proteins. We can just skip that. So when you talk about proteinuria, then you know maybe there is something wrong in this system that is supposed to prevent proteinuria. And this is why we tend to take proteinuria seriously. In fact, more seriously than hematuria. Hematuria, blood can be coming from anywhere. It could be coming from the ureter, could be coming from the bladder, anywhere. But when it comes to proteinuria, you start getting worried that there is something wrong with the kidney. Now, there is glomerular proteinurias and there is tubular proteinuria, which is extremely rare. So don't get distracted with that. So just focus on glomerular proteinurias, which means something is wrong with the glomerulus. It could be, it doesn't necessarily have to be pathologic, by the way. Proteinuria can be transient, which we will see later, in cases of a fever, exercise, stress, or change in posture. We call it orthostatic. And this is because of hyperfiltration or increase in venous pressure that will result in excessive filtration and leakage of some protein. It does not indicate pathology, but the source of the protein is coming from the glomerulus. Injury happens due to different types of mechanisms. It could be, let me just see if we can here. Okay, it could be from circulating factors, like what we see in minimal change and focal segmental glomerulonephritis, glomerulosclerosis, FSGS. Could be due to immune complexes, as we see in other types of glomerular diseases, without going into their long names, just keep it simple. Or it could be due to mutation, as we discussed earlier. So it could be congenital or immune-mediated injury. So whatever happens, it results in increase in the filtration permeability to big molecules like albumin. And there are two types of filtration, or the restriction of the filtration usually is due to two mechanisms. Due to something called charge selectivity and something called size selectivity, which simply means that there are pores that basically don't allow molecules to pass due to their small size, but also there is a negative charge that basically prevents the protein from passing. Most proteins, or not all of them, have negative charge. And the presence of negative charge on the filtration barrier will basically prevent the filtration of the proteins in general. In minimal change, it is believed that just one second. It is believed that the loss of anionic charge is what is causing the proteinuria. And there is a visible so-called effacement of podocyte foot processes. Effacement means flattening. And in the upper diaphragm here, you see the healthy, normal foot process with the slit diaphragm in between. And in the pathologic state, you see flattening and abnormal structure, and subsequently will be abnormal function of the podocyte foot processes. And that will allow proteinuria. By the way, minimal change, which is the most common cause of nephrotic syndrome in children, still poorly understood, despite hundreds of papers. So we still think it is a combination of loss of anionic charge and the changes in the level of the podocytes. Now, to move on to the definition of proteinuria. The proteinuria, to be well defined, you need to have it quantified. And quantification requires collection of 24-hour urine. So we have definitions based on what you get. And in pediatrics, we don't have one size fits all. So you always have to basically reference it to the body surface area. Anything less than 4 milligram per meter square per hour is normal. And that will be acceptable. So you say normal proteinuria means, yes, we expect to see tiny amounts of proteins in the urine. Half of that is usually secreted by the renal tubules, and the remaining mostly are albumin and so-called low molecular weight proteinuria. Okay. Now, when the proteinuria exceeds the 4 milligram per meter square, it becomes abnormal. If it exceeds 40 milligram per meter square per hour, then we are talking about nephrotic range proteinuria. Now, the detection, for the practical reasons, detection of proteinuria requires the urine dipsticks, which picks only albumin. In the lab, however, they use different reagents that pick all types of proteins. But there is one important take-home message here when you use urine dipstick, that it gives you the proteinuria as reported as either trace 1+, 2+, 3+, or 4+. And that actually varies according to the concentration of the urine. I'm sure you all know that, but just as a reminder. So whenever you record or document proteinuria as 1+ or 2+, for example, you have, along with that, to document the specific gravity at that time. Was it a concentrated urine or diluted urine? So for example, if you have a very concentrated urine with a specific gravity of, let's say, 1030, and you barely got a 1+ protein, this means if this patient had more water before, enough to dilute the urine, probably you wouldn't have detected any protein, or you'd have only had some traces, and vice versa. So again, urine dipstick is an indicator of the concentration and doesn't tell you about the absolute amount. So to correct this issue, we have to basically do lab, not only looking for the protein in the urine, but also looking for the creatinine in the urine. And we can do the protein to creatinine ratio on a random urine. However, we prefer this random urine sample to be in the first morning void. We'll come to that later. And also 24-hour recollection will be definitely good in quantification of the proteinuria as well. Now, how much is normal for protein to creatinine ratio? Less than 0.2. But if you're dealing with a child younger than 24 months, we accept up to 0.5 milligram protein per milligram creatinine. We talked about the timed urine, about the 4 milligram per meter square and the 40 milligram per meter square as the range of the proteinuria. Now, what to do when you have a child who has proteinuria? Like we said, always give it attention, but don't get too excited. And we'll come to that now. I promised you with the so-called the 5 pillars of nephrology. And if you get a child, for example, who has a manifestation or presentation that has to do with the kidneys, always ask yourself 5 questions. Number 1, what does the kidney structure look like? And we know about it by doing a kidney ultrasound usually, which is the easiest, least invasive, and very informative. So if you get to know that the kidneys, there are 2 kidneys, and they are normal size for age and gender and body size, weight and height, there are actually calculators for that and tables, plus the details of the kidneys on ultrasound, including echogenicity, corticomedullary differentiation, lack of stones, cysts, or hydronephrosis. This is definitely good to see a normally looking kidneys on ultrasound. Next is GFR. And I would encourage all of you to get into the habit of converting the creatinine as plasma creatinine into a GFR using the Schwartz formula. Look for it, write it down, and whether you're using the milligram per deciliter creatinine or micromole, apply the Schwartz formula. And in pediatrics, any value below 90 is considered abnormal, and we start talking about some degree of CKD. However, in adults, they accept GFR till 60. So anything less than 60 ml per minute per 1.73 meters square is abnormal in adults. One more time. In children, normal is 90 and above. In adults, normal is 60 and above, provided, of course, in adults that the kidneys look good on ultrasound and it's not getting worse. Third one is actually presence or lack of presence of proteinuria. So this is how important proteinuria is in basically telling me if the glomeruli are healthy or injured. So, and this is why I'm giving this lecture today, is basically it's a kidney vital sign, the presence or lack of presence of proteinuria. And fourth one, as you would expect, blood pressure. And again, I would encourage all of you to have the updated tables for pediatrics about the blood pressure centiles. The last one here is family history of kidney disease, for obvious reasons. In children, vast majority of the cases of chronic kidney disease are both congenital and genetic. So it's very informative to ask about family history. So if you have somebody, for example, who comes to you with hematuria, for example, and you go over the 5 elements and you see that all of them are reassuring, then you can reassure yourself as a physician, and you can also reassure your patient. Okay, so back to proteinuria. When I said don't get too excited, because 5 to 10% of kids can test positive at some point of their lives. In a random urinalysis, they can get 1+ or more. However, if you keep repeating the dipstick, you only get to only 0.1% of children will have persistent proteinuria. So if you want to do a simple classification of proteinuria, I did them in a kind of a color-coded, where the one I'm worried about is in red, which is the persistent proteinuria. And the ones I'm not really worried about are the transient, intermittent, and orthostatic. So the transient proteinuria, it's benign. It is the most common cause. And as you would expect, it's encountered in situation when there is acute illness, acute febrile illness, exercise, stress, seizures, dehydration, etc. And as you would expect, it resolves once the underlying etiology resolves as well. Okay, now the orthostatic proteinuria is a relatively common cause of proteinuria we deal with. And we get a lot of referrals from general pediatrics for orthostatic proteinuria. General pediatricians will worry about proteinuria and they will just refer to nephrology. from our end, we suspect proteinuria when basically history is reassuring, exam is reassuring, no blood pressure, no hypertension, I mean. And we can confirm it as follows. We have to get a negative urine test in the early morning. So what we do is basically we give detailed instructions to the family that the child before going to bed has to empty his or her bladder and stay at night in the bed in the recumbent position. And first thing the child will do as soon as he or she wakes up is to give us the urine specimen. So this is basically the urine that reflects the formation of urine while the child is in the recumbent position and without any impact of being in upright position. So we need to get a first morning voided urine and do protein to creatine ratio. And that will be negative usually. Persistent proteinuria, obviously, if there is proteinuria despite collecting the specimen properly in the first morning void, this one you worry about, and it has to be properly investigated. You do history and physical for everyone. Look for any finding that would suggest an underlying renal disease, edema, hypertension. Ask about recent streptococcal infection. We talked about getting the protein creatine ratio and telling the difference between orthostatic and persistent. We do labs definitely whenever we feel there is a persistent proteinuria or whenever you are worried. Nobody will fault you if you do labs even for a transient proteinuria. That would include renal function test, electrolytes, cholesterol, albumin, protein, and whenever appropriate, you can add complements, ANA, and others. Kidney ultrasound can be considered if you have concerns about parenchymal damage that is visible by ultrasound. Persistent proteinuria usually is a red flag and indication for referral. Back to the orthostatic proteinuria, it's one of these few conditions in nephrology where you have a worried parents coming to you because they were told that their son or daughter has something wrong with their kidneys, and they come concerned. And once you basically establish this is an orthostatic proteinuria, they get really relieved. And you tell them, you know what, your child is well, and there's nothing wrong with him or her. And they leave happy. And this is actually one of the rare situations in nephrology where we actually have parents leaving our clinic happy and satisfied. Unfortunately, most of the kidney conditions are chronic, and patients have to always be regular customers for us for years and years to come. And if the general pediatrician does what I'm saying now, you can get this credit and you can get a rewarding smile and thank you from the parents for reassuring them on the spot instead of getting them to wait for the appointment with the nephrologist and the suspense and then getting the relief later on. So back to the persistent proteinuria. So when the proteinuria is there all the time, standing, sleeping, it's always a source of concern. And definitely it's an indication for referral to the nephrologist. We do quantify it as 24-hour protein, and we check for the parents to see if there is a familial condition. We consider doing a kidney biopsy, even if it is an isolated, asymptomatic persistent, which means all the other kidney vital signs are fine except proteinuria. However, it depends on how bad it is. If it is more than a half a gram per meter square per day or less than half a gram, there is a debate. We continue to monitor those children in terms of kidney function, blood pressure. If there is any progression of the condition, we tend to expedite the kidney biopsy. When we do a biopsy, we may find things like, or entities like minimal change, FSGS, IgA nephropathy, membranous, and diffuse mesangial proliferative GN. So, in summary, the proteinuria is a condition that happens in children. It is not rare. It is a source of concern to physicians and parents. It can be sorted out by general pediatrician if they follow the algorithm, which is basically to rule out orthostatic proteinuria, do a proper history and physical exam, and just think of the three possible entities the 3 types of proteinuria. Remember always the 5 pillars of nephrology. And I hope we have time to talk about nephrotic syndrome in the future, which is basically, that will basically complement this talk. Finally, pictures of the 2 olive trees from land next to my home in the city of Nablus in Palestine. Thank you very much.
Thanks, Dr. Omar. Really, we are, it's a very nice presentation, and we are here all what we need to know about the proteinuria. And yes, as you say, we need more details about the nephrotic syndrome, which is the more diagnostic about the proteinuria. I will looking for any question. There is one question. We don't want to deny the nephrologist from seeing a smiling parents. Just
okay.
Is there any question? Any doctor would like to ask question to Dr. Omar before we ending the pediatric session for today?
Okay, well, thank you very much.
Thank you, Dr. Omar.
Okay.
And now we will move to the second part of our day 2 from the MAC Congress, which is the infertility session. And I would like to welcome Dr. Salam and Dr. Hafsa. Both are the consultant, obstetric and gynecology and infertility, who will sharing the fertility session. We are waiting. Dr. Hafsa, welcome.
Thank you, Doctor. We are most welcome.
Yeah, and we are waiting Dr. Salam also to join us. Okay, Dr. Hafsa, you can the infertility session while Dr. Salam will join us.
Very good afternoon to everyone. I am excited and happy to be here in this an excellent virtual meeting, which is actually this is the first virtual meeting held in Bahrain regarding the woman and child health. My lot of thanks to the Mr. Chairman, Dr. Hatem, the sponsors and the organizer for this excellent virtual meeting. The speaker for today, the first speaker will be Dr. Hatem Shawqi. He is consultant Obs and Gynae. He is one of the senior consultant in the infertility, and he is head of the fertility certificate in Royal Hospital for Women and Child. And his topic for today is sophisticated placebo and the infertility. The floor is yours, Dr. Hatem.
Sorry for this delay.
Sorry, Dr. Salam. You can restart again if you want.
I thought it's another 5 minutes. I'm sorry for this.
No, I can't start. I can't start except when you are online.
حصلت لي credit أنا حصلت لي credit.
You are always having a credit.
Thank you both. Thank you very much, Dr. Salam. Thank you very much, Dr. Hafsa. And thanks for all the panelists. And thanks for the my great attitude to all the attendees. And my talk today, maybe it has a peculiar title, but it will be clear at the end what did I mean. Actually, when we assist any couple to have a baby, when this assistance is successful, because of our ego, we say it is our credit. But when it is not successful, we say it's God's will. But I think that the proper answer, that both answers should be God's will, either the success or the failure. And the reason for this is, in spite of science gave us all the information, very, very deep information about the details of conception, yet the information about implantation is still challenging for us, for further researchers to explore its logs. Still, implantation for us is the black box. We know so many things about it, but still we don't know its secret. Implantation, by definition, is the process by which the embryo attaches to the endometrial surface of the uterus. By this adhesion, fetus receives oxygen for nutrients from the mother for growth. The physiology of implantation, precondition for implantation, is to achieve successful implantation, the uterus should undergo structural and functional remodeling. Estrogen and progesterone are the master hormones mediating these things. It happens through three stages or three steps. Apposition, the blastocyst contacts the implantation site of the endometrium. Adhesion, trophoblast cells of the blastocyst attach to receptive endometrial epithelium. Invasion, where the invasive trophoblast cells cross the endometrial epithelial basement membrane and invade the endometrial stroma. We know this physiology, we know it, but we don't have a concrete control on it. We cannot control it to happen or not to happen, although we know all about it. This video shows very briefly what I'm speaking about. This is what happens in implantation. Very simple, few seconds video. How it happens, but we don't know why it happens. Why sometimes this is the problem, or this is the challenge. So, taking it from this, science added to us that there are molecular mediators for the implantation. Yes, and these 7 mediators, we know all about it also. Further science is giving us another clue rather than the physiology, that there are mediators for molecular mediators for implantation. But still, this is not enough. Enough for what? That although we know all about this, we cannot guarantee that what we transfer to the patient will implant or not, although we know all about this. So scientists all over the world tried to, they would not watch this and say we will stand still. They tried to propose how to create, how to think about facilitators for implantation, saying, okay, let's help this procedure and make it easy by a way or another. They made it easy by trying to make it easy through this 5 subtitles: by hormones, by some procedures, by some drugs, and by some herbal medicine, and by some supplements. For the hormones, they agreed, and it is evidence-based, that progesterone and estrogen are the pillars, are the master hormones controlling the process of implantation. Others, like thyroxine or prolactin, or any deviation from their normal values may influence on this. That's why they also have to be on the normal values. But the pillars for the process of implantation, which is evidence-based, is the progesterone and estrogen. Number 2, the procedures. So many procedures have been addressed to us all over the last 25 years to facilitate implantation. Careful embryo transfer technique. Yes, there are so many papers concluding at the end, evidence-based, that the proper embryo transfer is a step which influences the result. And there are papers of optimizing the process of embryo transfer technique. The second procedure is the choice of the embryo. Good embryos, yes, it's evidence-based that the better embryos or good quality embryos have a better success rate than the poor quality blastocysts. Then they came up to us in the late 80s, I think, or yes, late 80s or early 90s with the assisted hatching. After evaluating this procedure, you will find most of the papers using this type of adjectives: suggests, uncertain, may, low grade, something which is hazy in the gray area, which does not say that it really helps. Embryo glue, a chemical called hyaluronan, yes, which is added to the lab dish where embryos develop to increase the chance of implantation. The result of this also the same hazy gray area words. It suggests, it may, it improves, but still it's not a clue. It's not something concrete we can follow. The PRP, it has been fashion in the last 5, 6, or let us say 10 years, maybe using the PRP in the media, in the conferences, but still at the end, when you come to proper analysis, you will find it that very limited, insignificant variation in the results. It's actually, it is a proposal, but you will find also it is present in the gray area. 5, endometrial extracting. The global trial in 2021, the first sentence is, it is time to stop scratching the endometrium. Enough. Enough is enough. It has no implement at all. So this is one of the procedures which we also use to market ourselves that we are doing it. So evidence-based, no, it's stop. It doesn't do anything. Some endometrium add-on procedures. This is a group of procedures. They call it sometimes adjunct procedures, including the immune therapies, the ERA, endometrial resistivity analysis or array, uterine vasodilatation, human chorionic gonadotrophy. All these techniques attempt to improve uterine receptivity, but the review authors found no robust evidence to support the efficacy or safety of any of the procedures. 8, the PGS, yes, the PGS improves the normal embryos, the normal chromosomal embryo tested before transfer. Yes, it improves the implantation. This is evidence-based. Heparin. Also, you will find heparin, the results, Cochrane, heparin for assisted reproduction. No benefit, no firm conclusions, do not justify. Still, we don't have something concrete to say that the heparin is the magic solution for us. After this, we go to some drugs. So we finish the hormones, we finish the procedures, we go to drugs. Maybe the drugs will help. Low-dose aspirin. The result shows the need of further randomized clinical studies in larger population to confirm the improvement of its use to improve the implantation rate. Still, it's in the gray area. Nitroglycerin treatment, no effect whatsoever. Aromatase inhibitor with GnRH agonists in patients with repeated failure also may improve. Still, it is may improve. It's nothing which we can rely on to solve the logs of implantation. Prolonged progesterone, yes, it is significantly implement on the increase of implantation rate. Whatever the type of progesterone, I will not go through the types or the route of the progesterone or the duration. Maybe Dr. Hafsa will speak about this after that speech, but as an idea, as a strategy of using prolonged progesterone, yes, it is significantly having an increase in the implantation rate. The steroids can affect, still can affect antibody positive, may, still we don't have something concrete in our hands. 6, insulin sensitizing drugs, no effect. No effect. Oocytes development and embryo quality are not affected whatsoever in the implantation process. Okay. Some people will say, okay, I will go for herbal medicine. Maybe the religious background and the traditional background will help to follow the herbal medicine. For your surprise, experimental studies of the effects of herbal medicine on the meter receptivity are gradually increasing. But still it's in the gray area. But I don't know what will happen in the future. We finish the hormones, we finish the procedures, we finish the drugs, and finish the herbal medicine. Let us go for the supplements. Maybe the supplements will work. NAT is an effective, cheap, and safe adjuvant to commensurate is long-standing unexplained infertility undergoing IUI. Still, it may also. It's nothing. The acetylcysteine is something which still it's not that in very selected patients, and this is the journal in 2017. The vitamin D as one of the supplements are the medical reps are eating our ears and giving us too much headache that vitamin D is the magic supplement for all diseases and it will solve all problems of all diseases. But actually it has no effect whatsoever. Could be, may, uncertain, suggest. That's it. Myoinositol, the member of vitamin B complex, still under research and not evidence-based. Folate, no, folate is clear evidence. The folic acid is clear evidence in successful implantation, not only for neural defects of the embryo, for successful implantation. Journal of Reproductive Medicine, 2019. I think more research is needed to confirm this still. Right? Selenium, more research is needed to confirm its importance. Nothing is concrete, nothing is evidence-based. Omega-3 can improve clinical pregnancy. But what do you mean by can improve? It's just something which are all proposals to solve the problem. Vitamin E for 12 weeks among women with implantation may affect endometrial thickness. Magnesium can be beneficial in cases of unexplained infertility. Vitamin C, no significance. So in this table, I gathered all what I have said. I found that the only significant is the careful embryo transfer technique, the good quality embryos, the PGS, the prolonged progesterone, and the folate. And others are sophisticated placebo. All the list is sophisticated placebo. We are just giving our patients placebo. But the question is now, are we going to use all what is stated, although we know most of it is placebo? Ask your belief. Whatever you believe in, do. I can't implement to anybody to use it or not to use it. Whatever your belief, whatever you think, khalas, do it. Is it necessary to estimate the serum level of each element before giving its supplement? If you want to give vitamin D or give vitamin C, you will give zinc or give selenium. If she has a normal serum level, why you are giving her tablets? She has normal selenium, she has normal magnesium, she has normal zinc. So why we are giving her? Third question, will we sell the idea to the patients that we are doing magic indifferent from other centers that I'm giving her magic? Of course, should be never. We should counsel our patients in a proper way that this is not the magic treatment. Will we bid on each other? I'm speaking globally, not in Bahrain. That I will give you the magic tablets, I will give you a different protocol than the other center and blah, blah, blah. Ask your conscience. Right. The last thing, will we share and participate together in related research hoping to improve or confirm the use of any of these, although we know it's placebo? Yes. We should work on this. We should finalize it, either to use it or not to use it, on an evidence-based, on a global study, on a multi-centric studies, so that we reach a conclusion which of all this list we should use and which we should not use. For me, Mo Salah is like implantation. We know that he scores, but we don't know how he scores. It's God's will. Thank you very much.
Thank you, Dr. Hatem, for this nice presentation and conclusions at the end. I agree totally with you on the last comment which you have given us. We should all work together in the hope of giving good, precise, and honest information to our patients so that we would get at the end to the best result, which is take home babies to those couples who are seeking this treatment. I think, again, as you have mentioned, some of us believe in something and hope that will improve the outcome for his or her patient. And I hope me and Dr. Hafsa and the rest of the colleagues will emphasize on that point from their own point of view. Thank you for this nice presentation.
Thank you, Dr. Salam.
Thank you, Mr. Chairman, for this an excellent presentation. I just want to comment about, I attend maybe 4 months back and virtual webinar. Speaking was Dr. Yaqub Khalaf. He was mentioned about the ads-on treatment for the improving implantation failure. By the end of his presentation, he mentioned one thing. If you want to, are you selling an ice cream? If you want to sell an ice cream, stay away from the evidence base. That's why he was supporting that. By the end, he mentioned that be calm and randomize. Okay, now we have a few questions in the Q&A question cube. There's some appreciation regarding your interesting presentation. There is an anonymous attendee asking, thank you for this presentation. What are the herbs mentioned in the studies? And does the effect of psychological effect of the placebo make any difference? I think the answer for this question, we'll hear it from later in the end of the presentation. But the first question, what are the herbs mentioned in the studies?
The herbs are Korean sperm, the Korean herbs, and they are written in the slide. Maybe I will show it to you. Yani, they left everything and they quote the herbs. Maybe I have the list in the original paper. I can just send me the email of the one who is answering. I will send it to her because it is very difficult names of plants. It's not salt and pepper. It's not salt and pepper, yeah. Very difficult names of plants.
I don't have any more questions in the Q&A box. Thank you, Dr. Hatem. Thank you very much.
Thank you, Dr. Hatem. That was a nice presentation.
Thank you, Dr. Salam. Thank you. Very good of you.
Now, it's a great pleasure to introduce my co-chair and a colleague, Dr. Hafsa Bouarki. Dr. Hafsa is a consultant obstetrics and gynecology, obstetrician and gynecologist, and an IVF consultant as well in Al Jawhara, and she is as well in Salmania Medical Complex, a consultant obstetrics and gynecology. Dr. Hafsa, an interesting subject, and everybody is eager to hear from you this progesterone and its effect on the IVF outcome. Please, Dr. Hafsa.
Thank you very much, Professor Salam Jibril. I am so excited and honored to be as a co-moderator with you on this. It's my pleasure to be with you as a coordinator in this virtual webinar. My talk today, it will be about interesting subject. It is the progesterone supplementation effect and optimization in the duration in the live birth and the XC, IVF and the birth with, and improving the birth rate and the ongoing pregnancy. I will focus here about the progesterone and its use as a luteal phase support in the fresh IVF cycle and frozen embryo transfer. As we know that luteal phase support has been neglected for many years, but with the new recent evidence base and the studies day to day, there was showing that the luteal phase support, it have been improved and it have successful in improving the pregnancy outcome and live birth. My content of the presentation, I will talk about the progesterone and its roles. Implantation, I think I may skip this part because Mr. Chairman, Dr. Hatem, I think he وفى وخلص منه, but I will go briefly about it. I will talk about luteal phase deficiency. Is it really deficient in IVF? Yes. Do we need a luteal phase support in IVF? Yes. But without even questioning this, there is different options to use of luteal phase support. We have the progesterone, which is the topics for today. We can use HCG, a human chorionic gonadotropin. It has been used and supported by many studies, but it has been less used nowadays because of the risk of OHSS and recombinant LH and GnRH agonist as a bolus. The last two also has been supported by a few studies to be used as a luteal phase support, but it was not approved in the ROARS, in the ISHRI, and it was used in a clinical trial. I will talk briefly about the new trend, it's luteal phase support and frozen embryo transfer, which is a frozen embryo transfer, which has been used around 70% in the most of the center, and then and individualized luteal phase support, and I will end with some conclusion. Progesterone is a fascinating molecule which has been discovered in 1939 by Odell Cotton, and he received one Nobel Prize. And 3 Nobel Prize also they got it because of the discovery of the use of progesterone in different maternal aspects. So we stated that the progesterone is never an ending story. A quick review about the timeline of the progesterone. In 1672, D. Graff, he described the corpus luteum. After 15 or even more years back, they identify and isolated the progesterone by Corn and Allen. Again, in 1939, progesterone structure has been discovered by Bottenland, and in 1980, progesterone has been used as luteal phase support for agonist cycle. And recently, 2020, the progesterone has been used for recurrent pregnancy loss in a huge randomized studies. This slide, my colleague, Dr. Khulul, she mentioned it yesterday. I just will go briefly about the classification of progestogens. Is either it's natural or synthetic. From synthetic part, there is something is called erythroprogesterone, which is digesterone. The synthetic part, progesterone, we are not using it in luteal phase support on pregnancy because of estrogenic and androgenic effect. So what is the role of progesterone? Progesterone, it's induce secretory transformation of the endometrium, help in desidualization, and help the endometrial receptivity for implantation. Another rules of the progesterone is immunomodulatory effect by increasing the nitroxide oxygen production. This is help in vasodilatation and improve uterine muscle relaxation. So without progesterone, we'll have improper uterine muscle relaxation, increase the risk of miscarriage and ectopic pregnancy. Progesterone is help in pregnancy maintenance. As Gasco mentioned in 1972, that if we remove corpus luteum before 7 weeks of gestation without adding exogenous progesterone, it will lead to pregnancy loss and miscarriage. I will try to explain this sophisticated draw, but I will try to simplify it as much as I can. Progesterone has, as I mentioned earlier, is immunomodulatory effect. It will shift the T helper cell, which is cellular immunity, to humoral immunity, which is driven by pregnancy-inducing blocking factor, to T helper 2 anti-inflammatory cytokines. And in the right side of my slide, which is a paper published by Grissner from Germany in 2018, he studied the effect of progesterone in the mouse model. And we have to confirm it again in the animal. He mentioned that progesterone, it will help in desidualization of a trophoblastic and invasion, and also it will affect an epigenetic silencing of different cytokines, which will affect in T helper 1 and T helper 2. So it will also increase pregnancy-inducing blocking factor, which help to increase immunosuppression, especially galectin-1. With the increase of galectin-1, it will arrest the dendritic cell, and all this, it will affect and mediate in the maternal immunity by increasing the local and systemic of T regulatory cell. All this, it will help in a prerequisite improving of the implantation and successful pregnancy. If we go again here for the role of progesterone in pregnancy maintenance, this is a huge randomized study. I think more of our physicians as IVF specialists, when they know about PROMISE trials and PRIMES trial. PROMISE trial, they studied the effect of progesterone with a patient who have more than 3 or 4 recurrent pregnancy loss. And PRIMES study studied the effect of the progesterone with a patient who have early pregnancy loss and threatened miscarriage. But the conclusion of this study showing that it's not in favor of the use of progesterone in prevention of the miscarriages. But, oh, sorry. Sorry. Sorry, I'm so sorry. But if we go back, if we see here in the subclasses, subgroup analysis of this 2 study, they mention that it's in favor of the use of progesterone if we have more than 3 of recurrent pregnancy loss. Why? If we go again to this graph in the left side, we saw that aneuploidy miscarriages or aneuploidy embryo are same. But the euploid or normal embryos miscarriage will be increased after 4 or more miscarriage. Here, there is a reason for luteal phase support. In the right side of the mice study, this is a lot of study which has been published regarding the use of progesterone in the recurrent pregnancy miscarriage and a threatened miscarriage. But it was supported in selective type of patient. So what is a corpus luteum? Corpus luteum is a temporary endocrine organ or transient ovarian gland. It is active mainly during the luteal phase and early pregnancy up to 8 weeks. Corpus luteum is produce a major hormone which is progesterone and the estrogen, and vasoactive substance like relaxin and vascular endothelial growth factor. This kind of substance, which is vasoactive substance, they are very important in maternal adaptation and the second thing for placental invasion. For example, if we are doing an IVF cycle with a frozen embryo transfer and use a replacement cycle with the use of exogenous estrogen and exogenous progesterone, there will be no active corpus luteum. This patient, and so there will be no vasoactive substance will be produced. So this patient with the frozen embryo transfer and replacement cycle, they are prone to have preeclampsia and pregnancy-induced hypertension because of inactive corpus luteum. This is, I will go briefly about this because Dr. Hatem, he talked excellent about the implantation. Natural timer of implantation for opening and closing, it's under effect of progesterone. But the time of the onset to reach a certain threshold is more important than the mid-luteal progesterone level. And if we see here, this is supposed to be kind of a synchrony between the embryo and the endometrium. We don't know who is the dominator here. Is it the embryo? Is it the endometrium? It should be kind of symphony between the embryo and the endometrium. If we go to the left side, we have optimal window of implantation, which is around 4 to 5 days and maximum of 2 days. Receptivity is, Dr. Salam, inshallah, he will explain deeply about this part. Receptivity is the endometrium, which is prepared to be ready for proper implantation. Selectivity is to keep the endometrium accepting or rejecting non-potential or bad quality of the embryos. And if we go to the other side, which is the embryo, we should have good quality embryo. And aneuploidy rate, we know that's increasing with a patient who have advanced maternal age. Developmental stage of the embryo, either it is cleavage stage like day 3 embryo and a 5 days embryo, it should be implanted in certain days. And pastulation ratio, which is very, very less or even delay in a patient with advanced maternal age. Why do we have asynchronization in patient who's control ovarian stimulation? If we compare the natural conception and compare to the control ovarian stimulation, what we are seeing here in the natural conception, when the onset, with the onset of LH surge, what we have, ovulation, it will happen after 24 hours. With the ovulation, it will open the window of the implantation because progesterone, it will be rise. And then we have a synchrony between the progesterone and in the endometrium. Opposite will be in control ovarian stimulation. In control ovarian stimulation, the window of the implantation, it will open earlier because progesterone, it may raise or came out earlier before the egg collection. So it will be out of phase. There will be asynchrony between the endometrium and the embryos. Do we have a luteal phase deficiency in IVF? Yes. Why do we have a luteal deficiency of IVF? There's many mechanisms which has been explained by Jones in 1996. If we see in this graph, stimulated cycle and normal cycle. In a stimulated cycle, can I continue? Hello?
Yes, Dr. Hafsa. Yes, Dr. Hafsa.
I'm sorry.
Please, everybody, mute your microphones, please, everybody. Sorry, Dr. Hafsa.
No, it's okay, doctor, my pleasure. In the stimulated cycle, we have a short luteal phase length, but in compared to normal cycle. If we see here, there was a dramatic increase in progesterone, and then suddenly decrease and premature luteolysis. And this gap مو قاعد يشتغل. Stop. Sorry. Hello?
Yes, Doctora. How can I help?
مو قاعد يشتغل لي السلايد.
Just click again.
No, okay. I'm sorry. If we see here, the gap between the stimulated cycle and normal is called luteal phase, the gap. This is the area where we have to replace the exogenous progesterone. Why do we have a luteal phase deficiency of IVF? There can be mechanical, like granulosa cell removal during oocyte collection, or because if we are using GnRH agonist or antagonist, HCG will induce suppression of LH, and supraphysiological level of the estrogen, it may suppress the LH and causing early luteolysis or the combination of all. If I will go here briefly about what happens if we are using GnRH agonist with the HCG trigger plus HCG as a luteal phase support, if we see in the left side in the graph, we see the progesterone, it will be raised very high and will continue high up to day 14. But if we use a GnRH protocol with HCG trigger without luteal phase support, and the half-life of the HCG, it may end in 10 days. We see from 10 days and onward, the progesterone, it will be decreased. So that's mean we have to use a progesterone for the luteal phase support in patient using GnRH agonist. So why do we have to use a GnRH antagonist in a patient going through fresh IVF? When you are using GnRH agonist and we stop it, after 24 hours, there will be GnRH secretion. But if we see in this study, they use different trigger shot, either HCG recombinant LH, and GnRH agonists. And in the left side, we see that the progesterone, it will drop even earlier than day 10. So we have to replace the luteal phase support with GnRH agonist and antagonist. And this is because of supraphysiological level of steroid, which is causing luteal phase deficiency in the late follicular and early luteal phase. Let's talk medicine and guideline and recommendation. This is luteal phase support in fresh IVF has been supported by many guidelines. Cochrane reviews more than 8 randomized studies. They support the use of progesterone because it will improve the live birth, it will improve the ongoing pregnancy, and it's in favor of the use of progesterone and improve the ongoing and live birth again. And also, they compare progesterone as a luteal phase support to the other luteal support like HCG or combination. Also, they in favor the use of progesterone even alone and compared to the other luteal phase support. As I mentioned earlier, there is no difference in the live birth or ongoing pregnancy either of use any other modalities of the luteal phase support. Progesterone is associated with low OHSS, but HCG, if we use it as a luteal phase support, it will shift the estrogen and upsetting the ratio between the estrogen and progesterone. So, ISHRI recommending the use of progesterone for luteal phase support, ISHRI 2019, and has been supported earlier by ASRM and NICE guideline. So now we believe that progesterone has been used as a luteal phase support. Then when we have to start, there is a 6 randomized control study. Let's go one by one. They said, if we use the progesterone on the day of oocyte retrieval versus the day after the oocyte collection, there is no significant difference in the live birth. If we use it in the evening of oocyte collection versus the evening of the embryo transfer, there is no significant difference in the clinical pregnancy. But if we use it before oocyte retrieval versus after oocyte retrieval, there's a significant lower clinical pregnancy rate when luteal phase support was started before oocyte collection or retrieval. And then on the day 3 versus day 6 after oocyte retrieval, there is also a significant lower clinical pregnancy rate when the luteal phase support started day 6 in compared to day 3. And this is the explanation of this study. They compare day 12 hours before egg collection and the day 0, which is the day of egg collection. They saw a big difference in the clinical pregnancy. And they compare again this study, day 3 in compared to day 6, there is also a significant difference. And so the conclusion, don't start before oocyte retrieval, not after day 3 or post oocyte retrieval. And this is the recent study in 2018. They compare if we use the luteal phase support in the day of oocyte retrieval, evening of oocyte retrieval, or in the day of the oocyte retrieval, there is no difference. So, ISHRI guideline 2018, starting of progesterone for luteal phase support should be in the window of between the evening of day of oocyte retrieval and day 3 post oocyte retrieval. Now, what is the progesterone route of administration? There is different route. There is no consensus regarding or agreement which route is better than the others. Dr. Hatem, he mentioned earlier. If he optimize patient satisfaction, personalized, which mood is better? Is it IM, patient discomfort? So this is a huge worldwide web survey. And we see here are using mainly vaginal progesterone and North American progesterone. Says 77% as a single agent in combined with the intramuscular progesterone. As I talked earlier, this is around 45 randomized control study. They study around 30,000 of patients. They are using different routes of progesterone administration. There is no difference except which is favor intramuscular versus vaginal progesterone. So I will go briefly about the luteal phase 1 and luteal phase 2. Randomized study, they compare the dihydrogesterone with 30 milligram and compared to the micronized vaginal progesterone. Did not find that dihydrogesterone is inferior to the other routes of administration. And also the huge question is safety, Lotus 1 and Lotus 2, and the finalized, there is no significant impact on the incidence of adverse events associated with congenital familial and genetic disorder. Of different routes of progesterone in the H3 2019 for luteal phase support we are using in a fresh IVF cycle. Coming to the end of the luteal phase support in the fresh IVF cycle, and this is here the debate will start. When we have to stop the luteal phase support, is it the time of pregnancy test? Is it the time after the first ultrasound? Is it 8 weeks? Is it 10 to 12 weeks? If we see here by Scott in 1991, show that luteal placental shift, it may start around 8 weeks, but it may even start earlier, 5 to 6 weeks. Leo et al., he mentioned that when we have to stop, here two studies comparing the live birth rate, miscarriage rate with different time of stopping. 5 randomized study, they did not find any difference. Ongoing pregnancy rate, around 7 study, they did not find any difference. So, luteal phase support, can we discontinue it? Should be discontinued once positive HCG is detected. Even after this many randomized control studies supporting that, what will end? That is still around 80% worldwide. In the worldwide web survey, there's still most of the centers that are used continue up to 10 to 12 weeks, even me, even the speaker and moderators. And Leo, he mentioned that better be safe than sorry. If we follow the guideline, progesterone for luteal phase support should be administered at least the day, till the day of pregnancy test. This is new things like randomized individualized luteal phase support, but it's not clear a little bit because they do mid-luteal phase progesterone level, which is 7 days post oocyte retrieval, and they notice if it is less than 17 nanogram per ml, it may associated with lower cycle outcome. But again, we went to the dilemma, what time which is more better if we go to this study and to measure the progesterone level. Progesterone level, it will be fluctuating around every 6 hours, 10 to 20 times fold, it will be different. that if we calculate it, if we measure it around 11 p.m. or onward, it will be at the peak. But if we measure it in the early morning, it will be less. We'll go to another part from my presentation is a luteal phase support in frozen embryo transfer. There is a lot of FET preparation method for luteal phase support. Natural cycle, a true natural cycle, or modified natural cycle with the use of HCG trigger. Another preparation is ovulation induction with the use of HCG or with the use of clomiphene, tamoxifen, letrozole, or gonadotropin. Or the worldwide preparation, which is used around 50% of all the center, is hormone replacement therapy with the use of exogenous progesterone and estrogen, whether we add GnRH agonist or not, we add. In the right side of the study, this is mentioned when we have to start progesterone with the patient, if they are going modified natural cycle or replacement cycle, we have to notice the stage of the embryo when it is vitrified. And all of the study, they compare natural cycle versus a hormonal replacement cycle or substitute cycle or a program cycle. There's a lot of names. There is no evidence to support the use of one cycle regimen to the other. No, this is no need. Okay, I'm so sorry for this quality of the slide. I tried to find, but I did not find a clear slide. They mentioned that progesterone supplementation in the hormone replacement cycle, they are studied in many Cochrane reviews. And here they use different route of administration, but they did not find any difference in live birth, clinical pregnancy rate, multiple pregnancy, or even pregnancy loss. And I cannot see here, sorry. And here in UC Brussels, in a group of authors, they study what is the optimal duration of progesterone administration for the vitrified warm cleavage stage embryo. They saw here if we thaw the embryo at the cleavage stage and transfer the embryo in day 4, or compared to day 4 and day 5, they saw that the clinical pregnancy rate and the implantation rate is the same. But the early pregnancy rate and the miscarriage is very high if we transfer embryo in day 3 or day 4 of progesterone, and this is because of less amount of the exposure of the progesterone. And the same author, they compare day 5 embryo transfer in day 6 and day 5 embryo transfer in day 7. They did not find any clinical difference. Sorry. And this is an interesting paper by Laparta in 2017. This is part of the individualized luteal phase support in frozen embryo transfer or personalized luteal phase support in frozen embryo transfer. They are collecting progesterone level in the day of the embryo transfer. They notice if the progesterone is less than 9.2 nanogram per ml, the pregnancy outcome and clinical pregnancy and miscarriage rate will be increased, but clinical pregnancy it will reduce. And again, they reverse the study, and recently has been published in March 2020. If they saw if the progesterone in the day of the transfer or the day before the transfer, it's less than 8.8 nanogram per ml, the live birth rate, it will reduce from 35% to 52%. And how they can adjust this issue, they have to use either to abort the cycle or cancel if they notice that the progesterone is very low, or using of rescue progesterone like progesterone 25 milligram of progesterone sub-Q, which is not available in Gulf, or they add extra progesterone. And briefly, I will talk about individualized luteal phase support. With the new modern era of the control ovarian stimulation, we are using like individualized control ovarian stimulation. There is something called now individualized luteal phase support. And my colleague, Prof. Salam, he will mention and he will talk also about individualized embryo transfer. And there is two ways of individualized luteal phase support. It's depend on the type of the medication using for oocyte maturation and the level of the progesterone in the early luteal phase. If we use the HCG, that's mean type of the luteal phase support for the HCG, either we can use vaginal progesterone, intramuscular, or oral dydrogesterone, which is in the study now. But if we use GnRH agonists, we can use intramuscular progesterone plus estradiol or HCG. So the author concluded that after the administration of HCG for final oocyte maturation, vaginal progesterone is sufficient to maintain luteal phase. Utilizes after GnRH agonists for final oocyte maturation is patient-specific. Individualization of luteal phase support after GnRH agonist trigger can be performed with the use of a low HCG. My conclusion, progesterone is crucial for implantation and early pregnancy maintenance. Luteal phase support is necessary for GnRH agonist and antagonist. Luteal phase support, we have to start at least 3 days after the oocyte retrieval in IVF, fresh IVF cycle. There is controversy regarding stopping luteal phase support. Between bracket, be safe than sorry. Different route of progesterone administration demonstrate a similar clinical efficacy. Vaginal progesterone is worldwide the most used luteal phase support. Oral progesterone offer more patient-friendly as a luteal phase support in IVF. FET in hormone replacement therapy, progesterone supplementation is mandatory. Progesterone supplementation in natural cycle, in a true natural cycle, we can use it if we are suspicious there is a luteal phase defect. Thank you very much and be safe.
Thank you very much, Dr. Hafsa. This is truly a very wonderful presentation, which had covered all aspects, even the recent one, which I thank you on mentioning it, the rescue luteal phase support, which is only a recent thing. And now that study made us think again and screen for the progesterone level at the day of transfer so that we can increase or booster the progesterone supplementation for our patient. It's very important. And till now we haven't come across any case with the progesterone less than 8.8, as you have mentioned. And everybody who is practicing the assisted reproduction and doing IVF, I think it's better if we measure again the progesterone at the day of transfer, just the day before transfer or the day of transfer, so that we can make sure that the luteal phase support with the progesterone is at its optimal level. Thank you. That was a very nice presentation. And
my pleasure, Doctor. Thank you very much.
Have covered all aspects. Dr. Hatem.
Thank you, Dr. Hafsa. It was really informative and comprehensive. It covered, as I will not add few words more than Dr. Salam, because he covered all the positive points of the presentation. Really, thank you very much, and we will come back to your presentation from now and then to revise our knowledge when we will transfer and when not we will transfer. Thank you very much.
Am I in time or no?
You are.
Thank you.
You do whatever you want.
Thank you very much.
I think you have covered the question that Dr. Lani Ares have asked. Thank you, Doctora, for the excellent and informative presentation. What is the preferred route of progesterone for luteal phase support?
In a fresh IVF cycle?
A fresh IVF cycle? What's your preferable route?
For me, the only thing what we have available in Bahrain, it's only vaginal progesterone we are using.
So you are using vaginal progesterone. We are using vaginal progesterone.
Yes.
And I think personally, I prefer to use the vaginal progesterone as a luteal phase support.
Yes.
I'm not in favor of the intramuscular or sub-Q progesterone, because the sub-Q progesterone is not available actually in Bahrain. The intramuscular as well is not available as short-acting progesterone.
Yes, it's not. Thank you. Shall I introduce? We go with the Dr.
Yes.
Salam, are you ready?
I think there is no question there. Thank you for your nice presentation, Dr. Hafsa. That's a comment. I thought there is an answer. There is a question to answer.
Is there any question?
Audience, any question for Dr. Hafsa, please? Okay, if there is no question, we'll move on.
Our next presentation will be by Professor Salam Jibril. دكتور الصورة يعني غير ها؟ ما عرفتك في الصورة. He will speak about a modern era of the control ovarian stimulation. As I mentioned earlier, he will talk about one of the individualized embryo transfer, and he will talk about the endometrial receptivity and how it may improve the clinical outcome and live birth. And by the way, Dr. Salam, you are the pioneer of the ERA test in Bahrain. Maybe you are the only one who's doing it. We are ready to hear from you. Thank you. The floor is
thank you, Dr. Hafsa. Let me slide with you. Let me share the slide. Where is my slide? Share the screen. Share. Is my screen there?
Yes.
Am I sharing the screen with you?
Yes, it's clear.
It's clear, Doctor.
Okay. I'll start in a minute. I don't know what's happening with my. Okay, Bismillah ar-Rahman ar-Rahim. Actually, the ERA test, we have some difficulty in performing this test at the beginning. So it took us a bit of time. The first 6-7 cases, it wasn't easy to master the technique. I will tell you what we have done so that we can master this ERA test. In this presentation, I will talk about what's ERA test, when it is used, what's the important steps of the ERA test, and the types of ERA test, and the data we have, and I'll mention some studies in the literature. So what's the ERA test? It's used to evaluate the stage of endometrium to determine if it is receptive or not receptive. That's based on the genetic study of the biopsy and the timing. We know in agriculture, the throwing of seeds should be at a certain time so that the implantation will take place. It's a similar principle. We go to the genetics, we study the genetics of the endometrial biopsy and see how it will develop so that the lining of the uterus would be receptive. In the case where the endometrium is not receptive, the tests enable us to find a personalized window of implantation for each patient. This test, we have focused on it on the cases of who have repeated failures of IVF while they have blastocysts. We even have gone further and did PGS. I will tell you what happened when we did PGS for the patients. Screening. The timing, the timing of the implantation depends on what we call nucleoproteins of the endometrium. And if you see these slides, the upper 4 slides, we have studied the nucleoproteins. Actually, the one who have studied is the Valencia group, Carl Simon group. They extensively studied the genetics, the nucleoproteins of the endometrial sampling at the proliferative, at the pre-receptive, at the receptive, and post-receptive stages. They studied these samples and they have found that the DNA is different. And when they are receptive, you can notice that the nucleoli of those receptive cells of the endometrium become abundant, and that's the most proper timing of the endometrium to accept the implantation of the embryos. So what's the standard protocol? There are different protocols. We are using mainly the HRT protocol. The patient comes to us on the 2nd day of her menstrual cycle. We do ultrasound. We make sure that the lining is thin, around 3 to 4 millimeter maximum. And we have to make sure that the ovaries are quiet, no follicles larger than 8 millimeter. Then we start oral estradiol valerate, 2 milligram tablets, 3 times a day. They can use, some are using patches, but we are using the tablets. And then we ask the patient to come back on day 10. We do another ultrasound. We measure the lining of the endometrium. It should be at least, to us, it should be 7, not 6 millimeter, to be at least 7. And we also measure the progesterone, and it should be less than 1. Actually, we accept up to 1.1 nanogram per mil. And we ask patient to continue using the estradiol valerate, the same dose, 1 tablet 3 times daily. And we add progesterone. Usually we add cyclogest, 400 milligram substitutes, and we ask the patient to time when to start the progesterone. Sometimes we ask them to start at 10 p.m. and we tell them, please, when you come back 5 days later, tell us the time you have started using it so that we can confirm the timing. Sometimes some patients might not use it, forget it, and use it, for example, 3 hours later when they remember, or next day. Doesn't matter. What matters, they have to tell us the exact time they have started using the progesterone. And we give them 5 full days before we bring them back to have the endometrial sampling. When they come back, we take an endometrial sampling in the clinic, and we send that sample in addition to the level of progesterone at the time we started our progesterone and the endometrial thickness. And then we send this sample to the lab, and the lab will do the analysis of these samples. And according to the result, we can do transfer of the embryos on day 3 or day 5, depending on the timing they are sending us. I will show you some of the results of some patients. Of course, the time we start progesterone is called progesterone plus 0, and every day is counted after that. Usually, this is a pre-receptive before the day of transfer, and if we are going to do day 3 transfer, it is different from the day we are going to do blastocyst transfer. Of course, there are other methods, which is the natural cycle, or a cycle which is stimulated, which is added, which we add to it HCG triggering when there is ovulation. This is the natural cycle, and the HRT cycle. The difference between them is 2 days or 48 hours. The HRT cycle, we calculate 5 days and take the sample. The natural cycle, we calculate 7 days after the HCG. And of course, we know that the timing depends on the level of progesterone in those cases where we take endometrial sampling. And the accuracy and the reproducibility of the endometrial receptivity is better when we do the endometrial sampling to know the endometrial receptivity. So what we do in our place to minimize the errors of doing the ERA test, we read instructions completely line by line, and we divided the tasks to everyone. What should everyone do? Who is going to take the sample? Who is going to do the ultrasound? Who is going to do the collection of the sample and keeping it in the container and in the fridge? And who is going to make sure that the consent there, the information is there? And all these made the teamwork successful at the end. We should make sure that we get the consent of the doctor and the patient on the papers, otherwise the sample will be rejected by the lab. Of course, the receptivity depends on the gene expression, and that's very important when the endometrium is receptive, and that's what we call window of implantation. And we are not surprised, but we have found that some patients are non-receptive. We have tried and did for them 1 and 2 of these ERA tests, and all the time it wasn't successful. At the end, we had to do ERA on natural cycle only, not with the HRT sampling. This is what we are talking about. This is an individualized receptivity timing. And when we send a sample, for example, of this patient, it was receptive, and we were surprised that the patient receptivity was 131 hours, And that's the most important thing, to do the transfer not on day 5, but to do it later than the 5th day, something like 12 hours. This is the pre-receptive stage, and the patient sample was repeated according to the first test, and the second one, it was receptive. The test is done by 2 companies, Cooper Surgical and the Ergonomics. We are doing majority with the Ergonomics because we found that the Coopers are giving 24 hours interval. It's not as precise as the Ergonomics, which is 6 hours interval for the implantation window. This is one of our cases. We took sample at the beginning and we send it. We thought it is correct, but they have found that the material which we have sent is invalid, having invalid RNA, and the material was not good for study. We repeated the sample after 2 months, and we found that the patient is in what we call early receptive state, so that we have to transfer something like 12 hours later. And when we did that, this patient got pregnant. This is the same case. When we did the receptivity analysis for the first patient, let me show you, it was 150 hours. When we did the sample of another patient, it was 136 hours. That's the individualization of the window of implantation for those patients. This patient is another one, and it is 113 hours, not as much as the other cases. This patient had a late receptive, so we had to shift the transfer timing 12 hours earlier. This patient had 110 hours, and when we used to do the transfer, it was always post-receptive endometrium. That's the receptivity we are talking about. We have to go to the exact timing where we should do the transfer. This is the first group. We have collected 122 cases who have frozen embryo transfer and fresh transfer. And this is the age of all patients in the study group. Majority, you will see, they are between 30 and 37 years of age. The average age of the group was 33.4 years, and the youngest was 26, and the eldest was 45. And when I looked at the studies, usually the average age of the studies I have found in the literature is around 33 to 35. This is our finding. On the left side, you will see how many times the IVF have been failed with those patients. One case have 1 previous failure. 9 cases, 3 cases have 9 previous failures. And the majority of the failures are around 3 to 4 to 5 times. And what I'm talking about are the first group of patients whom we have done ERA test and did 1 transfer and got successful pregnancy. Those cases have the following receptivity. Majority were pre-receptive. Almost 1/3 of the patients were pre-receptive, and only 1/4 of them were receptive. And this exactly what I have found in the medical literature, that only 25% of the patients are receptive from the first time we do transfer. There were 6 cases, 5% of the group, who were post-receptive, and 15% almost in the late receptive, but the early receptive as well 16%, the pre-receptive 33%, and the insufficient RNA, we had 3 cases, and no information about the genetic material in the sent group, we have 2 cases. And the timing of the ERA for the patients, for all patients, the shortest time was 88, and I'm talking about ERA for blastocyst transfer. So this patient has to have the transfer of her blastocyst 88 hours after starting progesterone. And she had 9 previous embryo transfers which failed, even we have PGS tested for this case. A blastocyst for this patient were, when we transfer them, were PGS tested. And the longest timing was 197 hours. I want to mention one thing, that some of those cases who were above 135 hours, we had to repeat the ERA test to confirm that they have long timing, and it is more than 135 hours. And of course, the outcome was until October 1st, 2019. Now we have collected a large number. I think we are on the range of 170 cases of who have done ERA tests. Out of this group, 58 pregnancy of this group had pregnancy positive after the first transfer. We had 31 singleton and 4 twins already born. And also we have 5 abortions in the first trimester, and repeated transfer with, again, according to ERA, achieved, same ERA, achieved 2 more pregnancies. 3 cases failed with HRT ERA and were successful with natural ERA. I don't know if ethnicity has to do with the ERA test, but one was Greek, one was from Belarus, and only one was Bahraini. 6 cases who had PGTA or PGS, 5 of them are from the pregnant group. So with the PGS and PGTA, it was additive to the success of the implantation. In this study, Alonso, of course, have compared in 2,445 patients whom they have analyzed, and they found the implantation rate and pregnancy rate, and the ongoing pregnancy rate is definitely superior with the group of the ERA test. They have even found no pregnancy, ongoing pregnancy rate with those who were non-receptive at all. And that's why they emphasize that it is good to do the ERA test. And this is another study by Simon Group in Valencia, and in addition, in Sofia University as well, and in Stanford University. It emphasizes on the group with personalized embryo transfer, and with this, they have found that the pregnancy rate and the implantation rate is much, much superior when the personalized embryo transfer was there, which is the ERA test, and that made a difference at the outcome of the pregnancy and ongoing pregnancy in this group. This is another study from Japan. Tagasho have found that personalized embryo transfer after ERA and blastocyst stage are significantly correlated with the high implantation rate in Japanese infertile women with recurrent pregnancy, implantation failure. This is what I'm talking about, that only 25% of the patients with recurrent implantation failure, when they have gone into ERA test, they were non-receptive, and with the ERA test, they were successful later. My conclusion is only 25% of patients were receptive when they underwent ERA testing, and that's matching with the percentage in similar studies. More than half of our patients with recurrent implantation failure were successful, were having successful pregnancy tests with the first transfer after we did the ERA test for them. The chance of pregnancy could be improved when we add to the ERA test the BGTA and the PGS. Of course, those embryos are more genetically, they are genetically, and karyotyping of them is normal. Definitely, ERA has improved our pregnancy rate in the group in our center, and it decreased the recurrent implantation failure for our cases. Thank you.
Thank you very much, Dr. Professor Salam, for this an excellent and great effort about the ERA test. I think after your lecture, I changed my mind and we'll compete with each other in this part. Okay, I cannot see any question in the Q&A, but can I ask one question since
sure.
I am the
and I will ask after you.
Okay, regarding the, do you do a full workup for any patient she is proceeding with ERA test, like the patient if she's like hysteroscopy, any fully investigation for recurrent implantation for as a routine workup before proceeding to the ERA test? And the second thing, do you routinely doing also BGTA for all of the patient, or just you are going with the ERA test only? Thank you.
Thank you for these two nice, good questions. The first one, we do workup for cases of recurrent implantation failure before we start them again on IVF. We do not accept to go just for IVF and without hysteroscopy for them and screen them for other causes of recurrent implantation failure. We do all the blood work, we do the hysteroscopy, and we sit with them extra time to make sure that we are not missing anything. Yes, we do hysteroscopy for them if we need. We do all of the investigations before we even suggest to them that there is a test called ERA test. You can do it. It might improve your chance of pregnancy. The second question, we do not do PGS for all patients. We do PGS only for indicated cases. And if we do the transfer with ERA test and fail, we suggest for them to test the embryos, the frozen embryos, before we do transfer for them again. But screening, the PGS also have helped us, especially in patients, for patients who are above 38 years of age.
May I ask?
Oh, sorry.
Dr. Salam, thank you for this very nice recent presentation. And I have 2 or 3 questions. Maybe the first one is answered. Do you do the ERA test for all patients or only for the recurrent failures?
few cases we have done for them before as a request. They came to do ERA test. They don't want to do IVF alone. Some of our patients have about ERA tests, and even some of them have given me some names of other tests, like Receptiva DX test, and you learn from your patients sometimes. And this ERA test, once they read about it and they know that we are doing it, they come. Even I had 2 patients from Eastern Province in Saudi who came to do the ERA test, and they don't want to do the IVF alone before they have the ERA test. But usually we suggest this for those who are having repeated failures. If they have good embryos at blastocyst stage, done the transfers, more than 2, more than 3, usually more than 3, we tell them about this test, but not from the beginning.
2 more questions. The first question are encouraging, and you have the ERA test non-receptive. Will you transfer relying on it? Well, will you transfer? I mean, will you stop transferring? Will postpone transferring relying on the ERA test, or will you follow the positive criteria of the endometrial thickness and the progesterone level?
I have done both. The Greek patient have.
Which one will you believe? Which one will you believe more?
I believe with the ERA. If you do it, if you do it correctly and rightly, you will believe in it as I am. At the beginning, I was frustrated with the test. I was about to abandon it. But let me tell you about this Greek patient. We did for her ERA test, and it was non-receptive. We repeated that after 2 months, it was receptive. Every time we did the transfer, it was a failure. We checked on progesterone, and we found that her progesterone, the day before we do the transfer, the day before we started the progesterone, was a borderline. So what we did, we checked the day before and the day after. And it was definitely there was something wrong which made the progesterone rise so sharp and suddenly. And then we decided to do transfer according to the natural cycle. And in the natural cycle, it was successful only. ERA with natural cycle.
Thank you.
You have to individualize the patients. Not all patients will be receptive. I have also some patients who had ERA test done, 3 transfers on that ERA test in Saudi. It was a failure. She came to Bahrain. We repeated the ERA test. It was totally different, something like 30 hours difference in the ERA test. We did with the second ERA test, which is ours. She got pregnant with the second ERA test. So ERA test, first test, doesn't mean that this is going to be successful all the time. It might not. But our patients, our first group, 67% of the patients were successful from the first transfer. It was amazing. And that made us hold strongly with the ERA test as something that helped us to improve the chances of pregnancy.
Thank you.
Dr. Salam, I have one question here from our colleague, Dr. Khulud Darazi. Her question is, how many of your population were beyond 40 years of age, and what is their pregnancy rate? Thank you, Dr. Khulud.
Thank you, Dr. Khulud. That's very nice. Now we are going to collect all the data, and we are thinking of publishing it. The group above 40 is about 22%. And the pregnancy rate for this group was 12.8%.
Thank you. I don't see any more question in Q&A box. I think we can move to the next speaker, Dr. Salam, if you don't mind.
Thank you, Dr. It is my pleasure to introduce the second speaker, Dr. Tariq Al-Mudawi. Dr. Tariq is a consultant psychiatrist. Dr. Tariq is from Dr. Tariq Mudawi Medical Center in Bahrain. And I'm happy to have a psychiatrist to talk to us about infertility psychiatric aspects. We need your help all the time, Dr. Tariq.
Assalamu alaikum. Thank you very much, Dr. Salam. Welcome.
Alaikum assalam wa rahmatullah.
Welcome, everybody. It's actually my pleasure to be with you, eminent figures in Bahrain, and to give you some spotlights about psychiatric aspects of infertility. Definitely, we need to know what are the psychiatric aspects of infertility. So we'll start. Introduction, the inability to create a desired pregnancy that culminates in the birth of a child is likely to create a life crisis for women, for their partners, as well as the parents. Women seeking fertility treatment look for nurses, carers, counselors, healthcare professionals. They seek every person's help. As you all know, definitely better than me, 1 in 7 couples will experience this problem in their reproductive lifetime. In a study carried by Freeman et al., it was an old study, but very nice study, 48% of women and 15% of men stated that they regarded their infertility as their worst life crisis. Infertility, as you know, or know definitely, can be defined as a crisis with cultural, religious, class-related aspects which coexist with medical, psychiatric, psychological, and social problems. The relation between psychiatric and psychological factors stem from a mutual interaction of both. We will talk later about this. We have a term we call psychogenic infertility. Psychogenic infertility refers to the inability to conceive without having biological cause or physiological cause. In word that there is no physical or organic reason for this infertility. So 17% of couples might experience this, what we call psychogenic infertility. The main reason possibly being linked to psychosocial or psychological stress or stressors. Psychology of infertility. Individuals who learn that they are infertile, they are often experience the normal, but nevertheless distressing emotions common to those exactly they are grieving, as if they have a grief reaction. The typical reactions with this grief include shock, grief, depression, anger. They'll be angry from themselves, partners, doctors, anger. Anger, we see it projected to everyone dealing with them, as well as loss of self-esteem, self-confidence, and sense of being, they feel the loss. They feel that they are a failure. And this is very common. We are encountered with these symptoms in most of the cases dealing with infertility. What about the relationships affected? Relationships may suffer, not only the primary relationship with a spouse or a partner, but also with friends, family members, and we all see these family members, they always cause pain by offering well-meaning but unfortunate misguided opinions. Do this, go to this doctor, try to do this. So these are very stressful to the partners, to the female and her spouse. Couples dealing with infertility may avoid social interaction with friends, especially those who are pregnant and families who have children. They may struggle with anxiety-related sexual dysfunction as well, and other marital conflicts. What are the causes of stress? We have many causes of stress in these couples with this problem. First, medications. We all know that drugs and hormones used to treat infertility may cause a variety of psychological side effects or effects. For example, the synthetic estrogen, for example, frequently prescribed because it improves ovulation and increases the sperm production. These synthetic estrogen cause anxiety, sleep interruption, mood swings, and irritability in women. Other infertility medications, on the other hand, may lead to depression, mania, hallucinations. I saw one patient who developed psychotic episode after having medications for infertility. Patients and clinicians may find it hard to figure out which is which. Is it because of the medications? Is it a secondary reaction to the stress? But it is very important to determine the real cause to deal with it. So the first cause of stress, medications. Money worries. For patients who do not have insurance, many patients, they don't have insurance coverage for the or the means to pay for the treatment. They have that money burden. Even patients with insurance, Dr. Hatem many times told me about patients who were saying if this procedure is going to be covered by insurance or not. If not, okay, can we postpone it? Or so this is the money worries, another cause of stress. The choices and the outcomes. Infertility interventions help about, as you all know, half of the patients, with the likelihood of success, unfortunately, decreasing with age. So this is another cause of stress. Patients who learn that they are to become parents, they have a responsibility. Life change, another kind of stress. Change is a stress, even if it is a positive kind of change. Women who have suffered multiple miscarriages, for example, they are likely to have or to feel more anxious whether they will be able to carry to succeed or not. Older couples may debate whether to undergo parental testing like amniocentesis. So treatment failure, on the other hand, may trigger a renewed cycle of grieving again and again and again. So with every time trying to conceive, trying to have successful trial, there is a stress coming from all the reasons I mentioned before. Maximum stress. The psychological stress during the waiting period. This is the maximum stress. Waiting, the uncertainty, the ambiguity. Are we going to succeed or not? This represents the maximum stress because it's very stressful to wait and wait. Okay, next time, maybe waiting again. So this is the maximum stress. The burden, as I mentioned a few minutes ago, medical treatment, which is time consuming, emotionally, financially demanding, and an additional psychological burden for women. And this was a very nice paper, but it was two papers actually I found, one in 1995 and the other one is 2004, talking about the burden of the medical treatment and the whole process. We have a male factor. Men who exhibit an andrological factor describe themselves as being more anxious, and they have interpersonal sensitive problems compared with the norms. So males who have a problem, they describe themselves, we are more anxious. The female factor, on the other hand, even though not being able to have a child, and both sexes definitely will be affected, but women feel greater amount of stress and anxiety and depression, especially in our culture. Oh, when we all know, we all hear this all the time. Oh, your wife can't bring us a child, okay, go for another woman, marry again. So women are, unfortunately, are having more stress. And the consequences of infertility arise from short-term and long-term devastating effects of both individuals' physical and mental health, as well as marital relations. It is probably for this reason, as you all see, over half of the couples, despite lack of success, they don't complete the treatment cycles. Why? Emotional strain. Enough. Enough is enough. Women and their partners as well, when they questions, they say, enough. We can't go with this stress again. So they stop searching for help. Half of the couples in all research, they said that because of the emotional stress, they stop asking for more help. Many difficulties here. it is very difficult to know when to stop seeking treatment. Frequently, one partner wants to end treatment before the other. And in most of the cases, men, they say enough. Because they don't want more problems. And in their back minds, they say, okay, I can accept my wife like this. But this is very stressful for the couples. One of the couples saying, okay, enough. I'm not going to go again with this procedure. Or accepting that they would go for adoption or other options. So this is one of the very common difficulties facing these couples. What to do? Facing these problems, what to do? Counseling. Actually, infertility counseling is currently one of the very important aspects in dealing with infertility. Short-term counseling are very common, especially to increase the coping strategies or to provide other choices, making decisions. Patients facing many choices, they need someone to help them to have the proper decision making. Ideally, counseling should begin before patients start infertility treatment. And this is very important, especially in a facility like a Royal Hospital for Women and Children. We have to, before starting treatment, infertility counseling. Because most of the studies suggest that psychological factors like depression, anxiety, stress, they might be the real cause of infertility. As I mentioned earlier, psychological infertility. Clinicians working with infertile patients can provide information how to manage fatigue, stress, and anxiety, and they can help these couples to improve the communications with themselves and with others. Psychotherapy. Specific types of therapy may also be very helpful. We have interpersonal therapy, we have cognitive behavioral therapy. Interpersonal therapy, in this kind of therapy, we can focus on improving the relationships, couples' relationships and relationships with others as well. And CBT, or cognitive behavioral therapy, here we can identify the what we call thinking errors, toxic thoughts or behaviors, and we can help the couples to deal with these thinking errors. And actually CBT is very helpful in dealing with infertility conditions. Psychotherapy could be another factor, because these people are having anxiety, having depression, and they might have a lot of other psychosocial problems. And we can do it individually or in group. Here, I found it a little bit difficult to do group therapy because of the cultural restraints, but it's very helpful, either individual or group therapy. Medications. This is one of the most conflicting issues. is it okay to give medicine for people searching for having a child? Yes. If you have an anxiety, moderate to severe, if we have depression, moderate, mild psychotherapy is enough. But according to all guidelines, international guidelines, World Psychiatric Association, if we have definite anxiety or depression or any other like grief reaction, adjustment disorder, mild to severe, we can't leave the patients without medications. Actually, we have to weigh the risk, benefit, risk, giving medications for those who are planning to conceive. Yes, we have many medications which are known to be safe. We can give these medications even the first trimester, especially the new medications, SSRIs, except one of them, which is considered unsafe. But we can give small doses, SSRIs, but we have to explain to the patients the risk and the benefits of giving medications. We have other problem with the medications given to these women. Birth control medications, for example, prescribed to regulate ovulation, they might decrease the blood level of some benzodiazepines like lorazepam, Ativan, and they might increase the blood level of other benzodiazepines. Benzodiazepines, we can use it just PRN for an anxiety if we are not going to give real medications. So it might increase the blood level of other medications. So the medications prescribed for these women should be assessed properly, and there must be some kind of sharing opinions. The doctor in charge and the psychiatrist to discuss what to give, what about the dose, and what are the drug interactions between medications. Finally, the psychological aspects of infertility is very important to be looked after. And these couples who are seeking to have first child are in a real crisis and they need help. So please don't ignore this. Thank you very much.
Thank you, Dr. Tariq. That was very nice presentation.
Thank you.
Maybe I will start my question. If a patient coming for infertility treatment having a depression, should we treat depression first or treat her fertility first?
Okay, according to the all research done, we have to treat depression first, because depression per se might lead to infertility, secondary infertility, or primary infertility. So we have to treat depression, and treatment, as I mentioned, according to the severity. If it's a mild, we have the ability to assess mild, moderate, severe. If it is mild, psychotherapy, whether interpersonal or cognitive behavioral therapy. But if it is moderate to severe, depression should be treated first. I have a case shared with Dr. Hatton maybe 15 years ago. I don't know whether he remembers it or remembers this case or not. She was suffering from depression and infertility. And I was taking care of her, treated depression, and after that, Dr. Hatton successfully helped her to have her children. Definitely, Dr. Hatton remembers this patient, wonderful patient.
I have one question to Dr. Tariq.
Sure, go ahead.
Which is a continuation to the question of Dr. Salam. If we are going to treat depression first, from your experience, how much will it take time to be ready for the infertility treatment?
6 to 8 weeks. As simple as that. Because in depression, we have 3 R's. I'm always saying response, remission, recovery. Response, so the patient starts to respond. This will take 2 to 4 weeks. Remission, 4 to 8 weeks. Functional recovery after that. So we can start the infertility treatment when we reach the remission phase. Usually after 4 to 6 weeks.
Thank you.
Welcome.
Dr. Tariq, I have one comment and one question.
Sure.
I think we have to stop argue that stress that will affect infertility or not affect. We have to focus mainly on the patient. My question is this: we are as a physician exposing to this kind of patient in daily basis, patients feeling depressive and anxiety, drop out the treatment, asking for shopping between all the doctor. Do we, as a physician, do we need to see also as a counselor in monthly basis, or we don't need to see any counselor regarding we are as a physician?
I believe so. I believe this.
And the second question: what do you believe in acupuncture? It may improve this stress and depression in this kind of patient?
Actually, I believe in based evidence medicine. There is no strong evidence this acupuncture is helpful in our conditions. So it might help, like
sophisticated placebo, يا دكتور حفص. Acupuncture sophisticated placebo.
Ice cream clinic.
Added to the sophisticated placebo.
In almost 40% of conditions, placebo.
Okay, I have one question here from Dr. Shazia. Which antidepressant can be safely given along this infertility treatment? And here a question, also another question: do you recommend CBT for this patient? And do you provide this? If yes, can you leave your contact number and where we can refer patient for CBT? CBT, I think behavior therapy or something?
Cognitive behavioral therapy.
Yes. First question: what kind of antidepressant safely to be given for infertility treatment? This is the first question.
Okay, going back to the CBT, we can provide CBT in the Royal Hospital. I'm there, and I can help patients seeking for CBT, and we can do it in the hospital or Zoom or whatever. SSRIs, actually, selective serotonin reuptake inhibitors, are preferable to be taken while preparing patients to have infertility treatment, especially fluoxetine, which is the Prozac, sertraline, which is Zoloft, and escitalopram, Cipralex. These 3 medications are known not to have, there is no any evidence that they have any possible side effect or problem. We can give this for pregnant ladies, for children, even we don't prefer tricyclic or the old medications, but these 3 antidepressants are approved to be given for these patients with no possible side effects.
Thank you very much, Dr. Tariq.
You're welcome.
Thank you, Dr. Tariq. Thank you, Dr. Tariq,
Thank you
for your nice lecture.
It's my
Dr.
pleasure.
Hafsa.
We can move to the next speaker, please.
Dr. Hafsa, please.
Yes, the next speaker, Dr. Sarah Faour. She's a consultant obstetrician working in the Royal Women Hospital, Screen Disappear. She will talk about the very difficult subject, which is ambiguous, a lot of heterogeneity. She will speak about polycystic ovarian syndrome. Dr. Sarah, the floor is yours, please.
Thank you so much. It gives me a pleasure to be here today.
Your voice is not clear, dear.
Are you listening better now?
No.
Raise your voice, please.
Is it better now?
Yeah.
Little bit more, Doctora, if you don't mind.
Okay, like this it's better?
Yes, dear.
Okay, thank you so much for the presentation. So today I'm going to be talking about polycystic ovary syndrome. I'm sorry, just 1 second for the presentation. One second, I'm sorry. Okay, so today I'm going to be talking about polycystic ovary syndrome. As we know, PCOS is an endocrine and reproductive disorder with a prevalence ranging from 5 to 13% in the reproductive age group. It's the primary cause of hyperandrogenism and oligoanovulation, and 70% of the cases are associated with infertility. It presents most of the time with a very heterogeneous clinical and biochemical manner, and this is why it's challenging to diagnose it. And it also has a lot of lifelong implications with an increased risk of metabolic syndrome, diabetes type 2, cardiovascular disease, and endometrial carcinoma. So in this talk, I'm going to talk a bit about the definition of PCOS, go a bit over how to diagnose it, how it clinically manifests, the associated morbidities, and focus more on infertility, the treatment of it, and the challenges that we face as IVF doctors. So PCOS, or what we call hyperandrogenic anovulation or Steen-Leventhal syndrome, is one of the most common endocrine system disorders that affect women in the reproductive age. It was first described in 1935 by Steen and Leventhal as a condition in which we have around 10 small cysts of a diameter between 2 and 9 millimeter that develop on one or both ovaries, or that the ovary is at least 10 milliliter in volume. Up till today, we don't have a universally accepted definition of PCOS. What we know is that it's a spectrum of variably associated clinical features ranging from cutaneous signs of hyperandrogenism like hirsutism, acne, menstrual irregularities, oligo or amenorrhea, polycystic ovaries present on one or both ovaries, and in a lot of times we also have obesity and insulin resistance. How to diagnose it? Up till today, we don't have one consensus how to diagnose PCO, but the most common used one is the Rotterdam criteria of 2013, where it says that we have to have 2 out of 3 signs to diagnose a patient with PCO. So either the patient has to have signs of hyperandrogenism or oligomenorrhea or polycystic ovaries on ultrasound. They all agree that we have to rule out secondary causes of these presentations before we label a patient with PCO. So we have to test for prolactin and TSH and other labs. They all require to have more than one sign or symptom. So finding a polycystic ovary on ultrasound is not at all enough to label a patient with PCOS. And although insulin resistance has been noted consistently among many women with PCO, it is still not included in the diagnostic criteria. Patients with PCO usually manifest with hyperandrogenism, menstrual irregularities, and like we said, polycystic ovaries on ultrasound. The associated morbidities are usually obesity. Around 60% of PCO patients has been found to have a higher tendency to be obese. Insulin resistance is also very common. 1 out of 5 patients has been shown to either develop later on in life gestational diabetes or type 2 diabetes mellitus. Cardiovascular diseases has been found to be in a higher percentage in PCOS patients. Endometrial cancer also is increased in this group of patients, especially in the ones that are not treated for oligomenorrhea. Depression, anxiety, sleep disorders also have been found to be higher in PCOS patients, and infertility. So infertility that is defined as 1 year of unprotected sexual intercourse in women less than 35 or more than 6 months in women more than 35 has been found with a prevalence of around 70 to 80% in PCOS patients. And many treatments have been proposed for these patients, ranging from lifestyle adjustments to ovulation induction, IVF and IVM, and we will talk more about them now in details. I'm going to start by talking about lifestyle adjustment with weight loss. So weight loss has been studied in anovulatory women with PCOS who are overweight and obese. They have been studies prior to initiating ovulation induction therapy, either by going through lifestyle changes like diet and exercise, or even when necessary, performing bariatric surgery to lose weight. And the results were seen that even with a minimal weight loss of 5 to 10%, we have an improvement in the metabolic status of the patient. The glucose is better, the triglyceride and the lipoprotein are better. We have a reduction in the serum androgen concentration and a resumption of ovulation. And sometimes in studies, it has been described up to 70% of patients had the resumption of ovulation. But not all women did develop ovulatory cycles despite similar degrees of weight loss. And also the Cochrane review that has been done about this topic, including 6 RCTs, all of them did not include a direct effect between the lifestyle intervention and the clinical reproductive outcomes like live birth rate. It was shown more on the ovulation cycles. So, and also about bariatric surgery, there has been limited evidence linking the weight loss after bariatric surgery to reproductive outcome. So in conclusion, yes, we do encourage weight loss in obese women with PCOS and anovulatory infertility, but we should be cautious in older women with PCO, in patients more than 35, or in the one showing a diminished ovarian reserve. Should we give them time to lose weight, or should we go directly for treatment? Now, about ovulation induction, we know that women with PCOS have anovulatory infertility, and many pharmacological agents have been used to induce ovulation, from Clomid, aromatase inhibitor, gonadotropins, and metformin, and even surgical approaches like laparoscopic gelling. So just a quick brief, clomiphene citrate is a selective estrogen receptor modulator, and letrozole is an aromatase inhibitor. They both, we give them both for 5 days, starting the first day of the menses of the patient. The difference between them is that Clomid has been FDA approved for ovulation induction, while letrozole is not yet FDA approved for ovulation induction. So for PCOS patient, what agent is better? There has been a multi-center randomized double-blinded clinical trial to determine which oral ovulation induction agent results in better live birth rate in PCOS women. 750 women would actually randomize, and it has been shown that the cumulative live birth rate is significantly higher in the letrozole group compared to the Clomid group. There was no significant difference in pregnancy loss or in the multiple pregnancy rate, so it was concluded that letrozole is a preferred agent for ovulation induction in PCO women. Also, a Cochrane review in 2018 comparing both that included 14 trials also concluded that letrozole is more effective as far as live birth rate than Clomid, and there was no difference in the miscarriage or in the multiple pregnancy rate. And also in 2020, another study compared both showed the same results, that letrozole is a better alternative. And according to the American College of Obstetrics and Gynecology, letrozole is actually the first-line therapy for all women with PCOS that need ovulation induction agents. And the potential advantages of letrozole over Clomid, first is that it has a higher rate of monofollicular development. So theoretically, it should have It should offer a decrease in the rate of multiple pregnancy. It has a shorter half-life, so it predicts a lower risk of teratogenicity. And the most important actually benefit of it is that it doesn't have an anti-estrogenic effect on the endometrium, in contrary to Clomid, where we have thinning of the lining. So this offers actually a big advantage for letrozole. Now, what about patients who are resistant to either Clomid or letrozole? What do we do for them? Giving gonadotropin to these patients have been shown around 72% of them actually had ovulation. But when we give gonadotropin, we're expecting a multifollicular response, so we have a high risk of OHSS. Now, what about laparoscopic ovarian drilling? What's the role of it nowadays? We know that in women who do not respond to ovulation induction with either letrozole or Clomid, drilling is a surgical option as a second-line treatment. When it was compared to gonadotropin, it showed that it has similar efficacy as far as ovulation, but lower risk of multiple gestation and of OHSS. Drilling works by reducing the ovarian secretion of androgen, therefore increasing FSH and LH secretion. And in some studies, ovulatory cycles occur in around 80% of patients who underwent laparoscopic drilling. But this technique has never been standardized regarding neither the energy source nor the number of punctures, the dose, the duration of the puncture, or whether we should do it on one or both ovaries. And actually, it has a lot of disadvantages because it's a surgical procedure. We have risk of adhesion formation, and if not done properly, premature ovarian failure. And this is why nowadays we see that not a lot of doctors actually do perform laparoscopic drilling, and they prefer to go for actually medications. I'm going to talk a bit about the role of metformin. There has been an interest in the use of metformin, which is an insulin-lowering drug in PCOS patients, when it was appreciated actually that insulin resistance plays a very important role in the pathophysiology of the disorder. Metformin is approved, the only approved indication for metformin is treatment of diabetes mellitus. It has been used for treatment of oligomenorrhea, but it is a second-line therapy. Still, the first-line therapy for the treatment of oligomenorrhea is OCP. So what's the role of it in ovulation induction? We know that the first-line option are letrozole and Clomid. Studies that have been done to compare metformin to Clomid or to letrozole have shown that Clomid is actually superior to metformin when both of them are used alone regarding live birth rate and ovulation. But when we combine Clomid and metformin, this study showed that it was superior to Clomid alone for ovulation induction and for the clinical pregnancy rate. Also in 2017, in the fertility and sterility, there was a review about the role of metformin for ovulation induction, and it has been shown that it should not be used as a first-line therapy for anovulation because Clomid, the oral ovulation induction agents, are more effective in increasing ovulation, pregnancy, and the live birth rate in women with PCOS. In 2019, a Cochrane review also done about this topic showed that when comparing metformin to placebo, so in not giving any treatment to PCOS patients, yes, metformin has been shown to improve the live birth rate when compared to placebo. But when it was compared to Clomid alone, it was shown that it has a lower live birth rate when compared to Clomid alone. But what was interesting is that when they stratified patients according to their weight, it was shown that in the obese group, the high BMI group, metformin was actually inferior to Clomid, but in the thin patients in the low BMI range, it was shown that actually metformin might offer an advantage over Clomid. But it was said that these studies are a low quality evidence study and more studies should be done about this topic. Now, when comparing adding metformin to Clomid versus Clomid alone, the results were uncertain. It was shown that for the clinical pregnancy rate, it was improved, but for the live birth rate, it was not statistically significant to be better. And these patients suffered significantly from a higher GI actually side effect. So they concluded that metformin may be beneficial over placebo for live birth rate. However, it is lower when compared to the regular ovulation induction agent, and it is not really sure whether it helps if we add it to Clomid. So we concluded that letrozole and Clomid are actually more effective than metformin for the live birth rate. Now, what about the patients that failed that failed ovulation induction? We move to IVF. The challenging part about doing IVF for a PCOS patient is the risk of ovarian hyperstimulation syndrome, which is a serious complication, and it is potentially life-threatening sometimes in young and healthy women. The pathophysiology behind it is not fully understood. We know that ACG might play is somehow the triggering stimulus for OHSS because it increases the VEGF and it causes this massive fluid shift. It's a common complication ranging from mild to sometimes critical and life-threatening. And we know that PCOS is a risk factor for OHSS. So what's the better, how is it best to stimulate patients going for IVF knowing that they are PCOS? Comparing antagonist protocol to agonist, it was shown that when they did the meta-analysis, 9 RCTs were included, it was shown that actually antagonist protocol, they are significantly better in PCOS patients because of the lower risk of severe OHSS. And also a Cochrane review comparing both showed that antagonists are better as far as OHSS compared to agonists in PCOS patients. Now, what about comparing the low dose versus the standard dose of ACG? As we said that ACG is the trigger behind OHSS. So if we decrease the dose of ACG, giving, let's say, 5,000 compared to the standard dose of 10,000, would this be better? A study comparing both showed that no, the incidence of OHSS was not reduced in the high-risk population, even with a lower dose of ACG. So this is why the theory of changing the trigger and moving to GnRH agonists actually came. GnRH agonists work by an initial flare-up effect on the GnRH receptors, leading to an FSH and an LH release, and it might be used as an alternative to ACG. Studies where GnRH agonist was used showed that the OHSS rate was actually nearly eliminated in GnRH agonist group. And a study by Engman et al. Comparing both in 66 patients of PCOS showed that actually none of the patients in the agonist group developed OHSS compared to the ACG one, where 31% of the patients developed it. And it had no difference in terms of implantation and ongoing pregnancy rate between both groups. So why not actually use agonist? And we have an OHSS-free clinic for PCO patients. Because RCT is done on the usage of agonist in normal gonadotropic women. In 2005, we had 2 RCTs by Ahmadan et al. And Kolubiansky et al. And both of them were terminated, prematurely discontinued due to high early pregnancy loss rate and a decrease in the implantation rate. And a Cochrane review in 2014 comparing GnRH agonist as a trigger to ACG showed that GnRH agonist trigger lowers the chance of pregnancy. So the luteal phase insufficiency was found to be a barrier for the usage of agonist trigger. But it's worth mentioning, and also it was mentioned in the Cochrane review, that these studies were done on different patient populations. Some RCTs were done on normal gonadotropic patients, not on PCOS patients. And this is why we have a different result between the RCTs done in 2005 and the one that was done by Engman, which showed similar results. And we had different luteal phase support that were used in all of these studies. So there was some kind of an error in clumping all these studies together to come up with a conclusion on PCO patients. But still, in trying to rescue the luteal phase and rescue the idea of using an agonist as a trigger, they came up with something called the modified luteal support, where we use 1,500 units of ACG in the luteal phase. And when it was done on normal gonadotropic patients, it was found that we have similar results of ongoing pregnancy rate and early pregnancy loss rate, and there was no OHSS cases. In 2013, when they applied the same protocol on hyper-responders, also it was shown that we didn't have any OHSS risk. But another RCT done on PCOS patients using the modified luteal support came up with the conclusion that we had a 26% rate of severe OHSS. So although this protocol does decrease the risk of OHSS, but still severe OHSS might be present. So what applies to PCOS? These studies were not done on PCOS except the Engman one. where it showed similar results as far as pregnancy rate. We know that PCOS have a higher LH level. Can this actually play a role in improving the agonist protocol? We don't know. Is modified luteal support acceptable to be used on OHS on PCO patients, knowing that we still have the risk of severe OHSS? Is our only alternative to freeze all and give the GnRH agonist trickle? All these are still unanswered questions. I just want to talk a bit about the role of metformin, a pre-treatment of metformin on the OHSS. It was found that metformin pre-treatment 2 to 5 weeks before starting gonadotropin therapy for IVF reduced the risk of OHSS when 9 RCTs actually were included. So metformin also is a good option to be used for PCOS patients to try to decrease the risk of OHSS. Now, as far as the in vitro oocyte maturation, we know that in vitro oocyte maturation is an experimental technique where we convert the oocyte, we mature them in vitro from the germinal vesicle to the metaphase 2 stage. And to be successful, this technology must include both nuclear and cytoplasmic maturation of the oocyte to give rise to embryos that have a good developmental potential, like the one we usually take from in vivo matured oocyte. But the initial studies with IVM resulted in lower fertilization rate and a suboptimal embryonic quality. But it was shown that in PCOS patients, we have a lower OHSS rate. So even though this technique is not used a lot clinically, but it is more and more being thought of and studied to be used to try to decrease the OHSS risk in PCOS patients. So in conclusion, diagnosing and treating PCOS until today is a challenging process, especially the treatment of PCO women who plan to get pregnant. It's important to realize that it's not a simple disease with a medication, but it's more of a condition with many symptoms, and it evolved over a woman's lifespan with a lot of lifelong implications. And this is why a proper follow-up, screening, and treatment are actually essential. Thank you. Any questions?
Thank you very much, Dr. Sarah. It is an elegant presentation and up to date. I cannot see any questions in the Q&A box. I can ask questions, okay?
Yes, sure.
Okay, regarding
we'll follow you. And I will follow you.
And me too. And me too.
Regarding the use of metformin, do you routinely doing GTT or sugar test before proceeding with using of metformin or no?
It is actually recommended when you diagnose a patient with PCOS to do a glucose test. So it's done usually in the workup of a PCOS patient, not routinely before using metformin specifically, but as in the workup of a PCOS patient.
And what is the rule? I know Dr. Hatim, he will not be happy with it, but I have to ask it because now it's coming new in the market regarding the use of anisitol for a patient with PCOS pre-IVF or pre-infertility.
There are not enough actually evidence to say that inositol helps in ovulation induction or in the treatment of PCO patients. It's not enough evidence to conclude that yes, we can use it and it helps.
Now they started, I think, this study in Brazil with the adolescent PCOS. If I'm not sure, but you think it may work with the adolescent PCOS or no?
Honestly, I don't use it because for me the evidence is not convincing up till today. So
okay, thank you. Thank you. Dr. Salam, you can raise your question, please.
Hi, Dr. Salam.
أهلا دكتورة سارة. Actually, Dr. Hatim first.
Sorry.
تفضل.
It's okay, Dr. Hatim. Go ahead. I'll ask my question.
Dr. Sarah, I have 2 questions. If I follow the Rotterdam criteria, I am omitting the hormonal profile. So what is the role of the hormonal profile for you as in diagnosing of PCO? Will you rely on it or will you rely on the Rotterdam criteria?
I personally rely on the Rotterdam criteria. A lot of times, actually, I don't order FSH, LH, and estradiol. I only order.
You will not care for reversed ratio of FSH and LH or increased testosterone or DHA?
Yes, I order the testosterone, 17-hydroxyprogesterone, and the DHEA, but specifically I mean the FSH and LH. I don't order them because they are not part of the workup, and I don't know, you have more experience, so correct me if I'm wrong. A lot of times we actually diagnose patients with PCOS, but not all of them have the reverse ratio of a high LH. So I order all the labs as far as glucose and TSH, prolactin, the hyperandrogenic part. Of course, I ordered, but specifically the FSH, LH, and estradiol, I don't rely on them at all in the diagnosis of PCO.
The second question is, in all our clinics, we always face atypical types of PCO, which they are not obese or they are unilateral. So how you will deal with these cases? You will deal with them, the atypical. You will deal with them as PCOs or as normal?
I think this is the challenging part, because if you follow the Rotterdam criteria, they told you that yes, you can have a thin patient with severe acne and one ovary looking PCOS and you polycystic, and you diagnose it and treat it as a PCO patient. But I've always asked myself this question, is that are these patients at a higher risk of infertility? Should we label them at PCOS, treat them at PCO? But if you follow the consensus, it tells you, yes, you should label her as a PCOS patient and treat her accordingly. And it applies to her, all these. But personally, a patient who's ovulating and she has acne and polycystic, I'm not sure if she would really, she's an atypical patient, like you said.
Thank you. Dr. Salam.
Yes, doctor.
Thank you, Dr. Hatem. Thank you, Dr. Hatem. Dr. Farah, my comment is about IVM. We have the IVM, in vitro maturation of oocytes, is not experimental. We have done it.
It has been used, yes.
We have used it here in Bahrain. We have children born after IVM. We did some collaboration with the Nordica Center in Copenhagen, and we have some children born for women who are having PCOS, severe PCOS, through the IVM. And we reported that. The thing is, with the introduction of the antagonist protocol, we found that the antagonist protocol for PCOS is much more economical, and the outcome is much more better with the antagonist protocol. But still, we have a few cases which needs IVM as a treatment, and not with the ICSI, even with the conventional IVF. Maturation, in vitro maturation of oocytes is not an easy thing. You have to learn it. It's both the lab and the clinician should go together and discuss the case and plan the case together for IVM. It's not an easy thing to be treated if you want to have zero or least ovarian hyperstimulation syndrome.
Of course. But with IVM, you also found that the live birth rate is actually, the clinical pregnancy rate is actually less than with right? It's still not very high, even, no?
Actually, we did not do a large group. We shifted to the antagonist protocol because we found that is more economical and the outcome is better than the IVM. Still have some cases. We have done IVM for 2 patients last year.
Okay.
It's not experimental. It's proven now that it is one of the modalities of treatment.
OHSS.
Not for all cases, but for selective cases. That was a nice presentation, Dr. Sarah.
Thank you so much.
I don't know if we have time. There is one question. There are actually 2 questions. Why the increased number of PCOS patients? Is the second question, is there a percentage of PCOS that can get pregnant spontaneously?
Yes.
First, the question, why the increase? I know we read in studies that where there has been an increase, but we don't know clearly the reason. One of the causes that they say is that also it's not clear that it's the cause, but we also have an increase in obesity all over the world. It's the new actually disease, the obesity, first of all. And there has been some studies talking about the usage of the pollutants that play a role, like the BPA in the plastic and the estrogen that has been used also in the food that we eat. It also plays a role according to some studies. And also there's a familial trait and the genetic pattern somehow. So all of them, I think, combine that, although none of them is proven to be the cause behind this increase, but it's probable. And for the second question, what was it?
Is there a percentage of PCOS that patient that can get pregnant spontaneously?
Yes. In my experience, yes, because they have erratic ovulation, and sometimes, of course, it happens for them to be pregnant spontaneously. Especially like Dr. Hatem has mentioned, in these atypical patients where if you want to diagnose them, the one with hyperandrogenism and one polycystic ovary, yes, they have a lot of time, they have regular cycles and they can get pregnant spontaneously.
Thank you very much. We are running out of time, huh? We can go for the last speaker. Thank you very much, Doctora.
Thank you so much.
Thank you, Sarah. Thank you.
Yours is yours, Dr. ختامها مسك. Dr. Salam.
Thank you, Dr. Hafsa.
نحلي بخلود.
Pleasure now to introduce one of our colleagues, an eminent in the field of assisted reproduction and IVF, a senior consultant in the OBS, Dr. Khulud Drazi. She is a consultant and the founder of Khulud Drazi IVF Center in Bahrain. Her talk will be about IVF after 40, chances and options, and this is a very nice selection. Dr. Khulud.
Unmute your mic, please. Unmute.
It seems you are very anxious.
Do you hear me well? Do you hear me now?
Yes.
Yes, Doctora.
Okay, let me arrange myself for a minute. Okay. Hello, good afternoon, good evening after 5. We should call this really like after 5 presentation, not after 40. Thank you very much, Dr. Salam, for the presentation. I'm so pleased to be with you again. I really enjoy the program, and thank you very much, Hatem, for this organization. It's very, very nice. Informative, very nice. Hafsa, a beautiful presentation. I enjoy everything really being said today. And I'm not quite sure what I will say after you people. I'm going to share my, where is that? I'm a bit unorganized this afternoon. I apologize for that.
لأن أنت اليوم في البيت أمس كنتي في المكتب.
Yes, and you know my story. I'm sorry for that. I have a drama already. Sorry. Okay. Share screen. How come I can't really get my slides? I'm sorry. I thought my talk will be at 6, so I wasn't really. I apologize again for all of this mess. So my talk will be about 40 choices and option. It's a difficult difficult title, and because we start really getting those patients recently a lot, and you know, if you review any of your clinical data, and you will see that your patient, you increase the patient, the amount of patient really increase in the clinics. I don't think just my clinic, I think all over. We all as a woman, frustrated all the time between really
we cannot
our
see your
choices.
screen, Khulud. You have it? You share your screen?
Yes, I did.
We cannot see.
Oh,
anybody see or except me?
Do you see me now? No?
We can see you, but we cannot see.
How come? I already shared the screen.
Okay,
Maybe you should minimize the other things that are open.
No, I did everything. Let me try again. Sorry.
Take your time. Take your time.
Share screen.
No, we can't see.
How come? Share.
We can see only your beautiful face, but another we cannot see.
Tired face. Okay. How come you don't see it? I can see it on my screen.
No, this one now.
No, as a share screen.
Yes.
Now
Now share it with us. Yeah, that's good.
No, still not.
Still, I have a problem. Is it my problem or with you people? Because I say stop here, stop share. You are sharing.
Open your slides and then share it. You open it completely as a screen and then share it.
Yes, I did that. It's not working. I will leave and put it again.
Flicker for a second and disappear, Khulud.
This is your desktop.
I can't disconnect you, press and leave a meeting and come back with a share screen. Do you want to move to the last speech? Then we come back to Khulud till she organize her things or no? Dr. Hatem.
I think Dr. Hatem.
Oh, you are ready, Khulud?
Okay, back.
Okay.
Dr. Khulud.
Khulud, do you want to take your time and we'll go to the final speech, then we come back to you? She cannot hear. Hatem, where is Hatem?
Okay. Dr. Hatem, can we take the last speech? Okay, we'll wait for Dr. Let's say.
Yes.
Dr. Khulud.
This is Ahmed. We can go for the next speech as a recorded session from Merck.
Okay, sorry. Okay, we're waiting for you, Khulud.
If it is recorded, we'll wait. No problem.
She have an issue, I think, even connecting to audio.
دكتور خلود سامعتني؟ Unmute Dr. Khulud, please.
Unmute Khulud, we cannot hear you.
What is the problem?
Ahmed, you don't have your presentation?
It doesn't, I can't share with you. I used the same things yesterday. Share.
It's okay, sharing your slide again? Yeah.
Yes, I try to share my slide and it doesn't.
Where is your slide?
That's my slide.
Yeah.
Now we can see.
Can you see it now?
Yes.
Okay, great.
Yeah.
Okay, I'm sorry for that. I don't know what happened. I used the same thing yesterday, but I don't know what happened.
It's fine, Dr. Khulud. Go ahead.
Okay.
Take a deep breath. I know you can start, dear.
Okay. So when you choose your career, everything goes up in life as a career. But as the time passes, that's what I always tell even my students. As the time passes, unfortunately, you will be really like a CEO of your company, but the graph, it doesn't show this, that when you grow up and when you grow older, you will lose your chances because your pregnancy rate will be really drop till maybe reach even 0. And that's because of the increase of the miscarriages, which might reach even up to 90% beyond the age of 45. I'm sure we've seen all of us, we've seen this this pictures in the social media, and we bombarded at that time. I remember in the Instagram how you say that 45 they don't get pregnant, and we see this old lady. Unfortunately, they don't know that she was an outcome of egg donation. So this presentation of a patient, which we all see in the clinic, 46 years, women, late marriage, trying since 8 months, and normal sperm analysis with AHC of 4. The first thing I would say, she's really old for pregnancy. And what is the best really option for her case, and what is the pregnancy rate with IVF, and is it safe really with that much, with this old lady over 45, and whether she is medically fit? Do I need to run any kind of screening before I start my IVF, and what is her potential obstetric risk and fluidity when I know that her miscarriages is really high at this age? And where is the ethics and law in all of this? So maybe one of the treatment people might choose, and I will not really blame them, don't do anything, don't treat, try to be really polite and consider all her well-being. And as Dr. Tariq mentioned, save her frustration and depression and all of this, and just say that's life, and accept it, and maybe you need to consider other things like adoption. What about Clomid as a something simple, be used forever? Will it harm her? IUI, will it give her any chance? IVF for ICSI at PGTA? And what about the egg donation, which I believe is the best choice in this category of women? What is the best treatment option for patients who's really after 40? So Armstrong, put them really nice review to compare the ART option for women more than 40. And clomiphene, live birth is almost 0. With IUI, if you use a Clomid with IUI, the chances of having live birth is less than 1%. Or in other group, they said even not reported, it's 0. And with FSH, maybe it will reach 1%, but IVF, your chances to achieve a pregnancy if you're beyond 40, 13%. Another study to determine the optimum infertility treatment in women at the end of their reproductive potential. This was done in 2014 for couples when they were trying with unexplained fertility for over 6 months, and female age between 34 to 42. Still, our patient is older than 42. And they randomized them to either clomiphene for 2 cycles of Clomid, and IUI with IUI, or FSH and IUI, or immediately going for IVF. And of course, the IVF was the most successful in this situation. So when we say IVF, I think in the Middle East, we always say IVF, but we mean really ICSI, because we do a lot of ICSI. That's what is shown really even, all the literature, that the majority of our cycle in Middle East, we do ICSI. But we are questioning here, ICSI or IVF for non-male factor. That's what I mean. Of course, no hesitation. Any person in our situation with a little bit or mild sperm test, we will definitely go ahead and do really ICSI. But they're questioning if it's non-male factor. So in a randomized controlled trial in 2020, in a very recent one, ICSI does not improve of the reproductive outcome in advanced age group if done for non-male factor. Another earlier studies done retrospectively in 2017, no advantage of ICSI over IVF for women over 40. Another one, same conclusion in regard of the live birth. So what is the live birth? If everybody is concentrating now on the live birth with IVF cycle in women age 40 and older using their own egg. I know we might not really find much in the literature. I think that's the struggle, because in Europe, the law is in their favor. They see those patients and they say, well, egg donation, and people accept it. I think the struggle only with us. So this is a group from Egypt, a huge number, 2,386 cycles published by Sarur. And overall, live birth initiated was 6.7. The pregnancy loss was too high, almost 45%, and the cut age was 43. So when the pregnancy become really low after 43. So live birth varies in this study between 7.4 for people who's really less than 43 to 1.1 when they are beyond 43. And the live birth for the age, for less than 43 was really statistically significant compared to people who's really beyond that age. So they conclude that this is better, but they give a very decent advice. Once women had attained age of 43, alternative methods such as egg donation and or maybe you do accumulate frozen embryos and do them, as a single FET will be more effective. So if we look now to the live birth per egg retrieval in women beyond 40, we're still talking about people who's really more than 40, but in the literature, they will not specify that they are really 45 or 47. So in this study, the nice thing, they decided to go by live birth, stratified them in year after the other. So 40, 41, 42. And it's marvelous. They really impressed me, because this can tell you the answer at least. That when your patient is 45, then the chance is almost zero. When you are 40, when you touch 40, yes, we say, we receive a lot of those women. Sometimes even with us, they did their cycles. They say, well, I got pregnant with you yet? Yes, you got pregnant with me 2 times, but you were 41, you were 40, but now you are 46 or 45. So the chances will be really low at this age, unfortunately. Another study published by Fernandez, this was 20 years experience and the chances of achieving live birth in patient age 43 and older undergoing IVF with their own gametes are low, even in cases of patients with a relatively normal ovarian reserve for their age. Like our patient, like the patient I presented to you, you say, okay, if AFC is 4, why not? But really, even with a normal, encouraging, still their chances is very, very poor. So when I say this, I always carry this, this ethics in my head, and all of us, I'm sure, that when the live birth for 40, if we examine them, we will say, well, if you are beyond 40, then varies between 44 to almost 16%. But when we go in the real literature and go really by age, one by one, we then see it's different. It's really zero, almost zero when you are reaching really 45 or beyond. So is it really a futile treatment? Are we cheating our patient by really giving the hope that they will get pregnant? And we know very well that they will not, when the literature say that. So ASRM explain what is really futility. So in this particular context of my talk, futility refers to treatment that has less than 1% chances of achieving a live birth. So this is belong to people who's really beyond 45. And then very poor prognosis refer to treatment when you give the live birth between 1 to 5%. So it's a challenge between the patient autonomy of what her desire, and we have to respect, we learned that we have to really to always respect the autonomy of your patient, and between the beneficence, which we should really do no harm for our patient. And one of them mentioned very clearly to you by Dr. Tariq that those patients really risky. They go in a lot of psychological drama by depression and anxiety. I think all of us, when we are hearing his, myself at least, I got myself depressed, you know, what we are dealing with as a, you know, as a really high morbid psychological, for psychological morbidity. In most cases, we have really to balance between what we can do and between what is really ethically justifiable for our patient. And they concluded by this saying, when patients seek to receive only psychological benefit, limited treatment may be provided after a process of really a thorough education and examination of the values. And treatment with a very poor success rate, clinician must be vigilant in their presentation of the risk and benefit and alternative. It doesn't mean that you have one patient got pregnant in your clinic. That means we have really to go really dramatic and do 7-6 cycles just to satisfy ourselves that we might really achieve this miracle. Another group came up after this to challenge this concept. And I can't criticize us living in the Middle East. Maybe we just criticize them. And we challenge them, whatever they say. We say, well, we have as well pressure. Patients have a lot of pressure from the religious part of view, from the social, from everywhere. So shall we just still go and have donation? So this was one of the largest reported to date in the literature as a retrospective, and they recruited 1,078. Interestingly, they excluded even PGTA and the natural IVF cycle and the egg donation. So cancellation was high, not surprise, at 28%, but they managed really to have a pregnancy per transfer for 43 years patient up to 18.7. And when they calculate, but definitely we know very well back in our head that they will miscarry. And then this is confirmed. This as well, live birth per cycle start was almost 3%, per ET was 4%, and total live birth was, in this study, 21 only they got pregnant, and one of them is really 46 years. No live birth in any patient with less than 4 oocytes. So that's a clear message. So if you have less than 4, no point, whatever you are doing, no chance for her to get pregnant. So they concluded that IVF in women age 43 with acceptable ovarian reserve is not futile. Okay, that's maybe I would say satisfy us because we're not cheating people. However, it does not carry a very low prognosis. That means we have really to expend time in discussing and doing a lot of counseling. So patient age 46 and older should be counseled appropriately that live birth seems to be highly unlikely. So egg donation. I was saying this egg donation from the start. The live birth remain to be constant across age. So whether you are 25 and you get egg donation, or whether you are 45 or even 70, like the picture I shared with you earlier, still the chances is really high. Unfortunately, the law is not in, with us, not in favor of that. The law number 26 is number 26 for the year 2017, specifically in article number 7, the egg donation is prohibited. So we can't do this in Bahrain. So what can we do? Shall we consider modify natural? Maybe shall we go aggressively in that case if we opt to? Or shall we go just mild? So in a retrospective cohort study of 476 patients in advanced age group, they found that modify natural cycle will be more friendly approach and could be reasonable alternative in this difficult to treat really group of women, as you agree with me. So if we opt for mild ovarian stimulation with low dose gonadotropin, okay, or if we go really aggressively, or just a normal, I mean, if you ask me in my situation, I would say I'd go aggressive because majority of my patients, they are really big. And I think even Salam, Dr. Salam will agree with me. I don't think we will go mild for those couple when they come to you with BMI 35 or 40, but never mind. Let me just present to you what ASRM guidelines says. So they say they know data about live birth rate, a fair evidence that the clinical pregnancy rate no different when comparing mild ovarian stimulation protocol using low dose comparing to conventional gonadotropin protocol. The same ASRM say, okay, what if they use oral? So here we are using letrozole or using clomiphene, okay, not gonadotropin. So either with, of course, or without it, okay? And comparing this again to conventional IVF protocols. So majority of the study either small or underpowered and heterogeneous criteria for definition even for poor. Of course, no evidence that the clinical pregnancy rate after IVF are different. So the ASRM conclude that insufficient evidence to recommend for or against IVF with mild ovarian stimulation using oral agent alone over conventional gonadotropin stimulation, evidence that clinical pregnancy rate after IVF are not different when comparing natural to conventional gonadotropin protocol. Fair evidence that the clinical pregnancy rate after IVF are not different when comparing mild ovarian stimulation with the low dose gonadotropin than conventional. But of course, there is no data again about the live birth. When we speak about IVF, to me, IVF is really to have a baby home. And IVF, you do whatever you can to achieve this by having a successful and effective protocol to get more eggs for achieving a pregnancy. Sankara, I think when, this subgroup, and they're my group. I've been trained in guys, and this is my group. Interestingly, Sankara came replacing my position when I left guys, and she did this wonderful, amazing. I have to say, it changed my view and all the clinician working in IVF view. That they analyzed almost half million IVF cycle, and they discovered that there is a strong association between the number of oocytes and the live birth. They reach even 16% in women beyond age of 40 when at least 15 oocytes were obtained. But is it magic? I think anybody work in IVF and have little bit experience will say it is difficult to find 15. If it's not really to find 15 really when your patient is 43. I know we get PCOS patient and they entertain us by getting eggs, but this is not the rule. So that's she showed even in all age group that's constant this magic 15. And if you see here our group beyond the over 15, if it gives you, it's nice because it's predict even live birth with this graph. So it's very interesting. But what is the, if we say that this is the egg, we need the egg. So what the protocol can give us this magic by giving us this magic number of eggs to achieve the pregnancy? So we asked this question being raised, and in Cochrane review, there's insufficient evidence to support the routine use of any particular intervention. Very depressing message to say either for pituitary downregulation, or you do ovarian stimulation, or you use all this vitamin C, vitamin D. It doesn't matter. In 4, the IVF is very, very poor, and outcome is very poor. And they suggest that we really need good RCT with a relevant outcome really needed. So meta-analysis came up to say, in that case, GnRH antagonist or agonist protocol. And they found that there is no significant difference in the clinical pregnancy, although the trend favored the long downregulation. And they suggest that further RCT with a larger group is really needed. So another same group, guys group, they decided to randomize their patient to longer protocol and versus short versus antagonist and poor responder. Very interesting and very nice, decent paper came up with the literature in 2014. The conclusion was longer protocol versus and antagonists offer a suitable choice for poor responder, whereas the short agonist regime may be less effective because of the fewer egg retrieval. So we're still preoccupied by the number of the egg retrieval. Of course, when we talk about the poor responders and the number of eggs, we definitely will come to Bozedian group and their promising, all their work. It's one of my favorite group probably in the literature because their approach is different. They say we will, the main approach is to diagnose and manage low responder by introducing new measurement for successful ART. And that we need really a good number of oocytes for a specific patient to obtain at least, so their objective is completely different. So our objective is to reach euploid embryos. So therefore, they stratify their patient based on quantitative and qualitative parameters. And that's namely age, ovarian biomarkers, and ovarian response if they have any previous stimulation cycle. So that's, I'm sure you are all of us familiar with their groups. So this is not really to replace any of the criteria or classification of the poor. That's different approach. And the group, our group is really belong to group 4, that you get less, the HC less than 5 and AMH is less 1.2, and majority of the time they'll be like 40 or beyond, and many failed cycle. They even introduced this ART calculator where you can use it even in the clinic. So you put the age and you put in that age the sperm source, and then they'll give you what is her probability to get how many eggs. And based on that, you can individualize your approach. And you might say, okay, if she needs 11 eggs or 15 eggs, I need probably to do 3 in a row before I do the ET. So it depends as well, as we said, their approach in getting euploid embryo. So what is the success rate with the PGTA for advanced really maternal age? So this is an RCET for day 3 biopsy, advanced age, they kept it up to 41. So they didn't mention 43. They avoid that. And then PGTA superior compared with the control, not only clinical outcome at the first ET, but also dramatically decreasing the miscarriages rate and shortening the time for pregnancy, which is our aim, to shorten the time for pregnancy for this, difficult to treat and easy to lose as well from your clinic. This is another group of LD, which is one of those Bosadian group. This is with the DuStem stimulation, and he recruited 137 women, and to manage to get 150 cycles, and 68% of them, they managed to get the blastocyst. As Dr. Hafsa mentioned earlier, the blastulation rate is very, very, compromising in advanced age group. But that's impressive. 68 is not really bad. And then they managed really to have 14% euploid. They did like Dr. Salam by replacing only one embryo for a normal euploid, and the delivery rate was per AET was 57, but per patient and per cycle was lower. No euploid blastocysts were found for patients older than 45. So the same finding as the same impression, 45 is they are loser, unfortunately. So the good delivery rate reported in this study in women with good ovarian reserve age 44 should encourage the use of PGTA in this population. However, Cochrane review says the current available evidence is insufficient to support PGTA in routine clinical practice, but I present this to tell you people that this doesn't apply to everything. When they say it's not routine, that means it's not routine, not for people who's really 25 and presenting to you to say, well, I want a male baby. That's what they mean by not routine, because PGTA done for different and several indications. But I don't think 45, if you decided to do for her, I think it will be a crime not to at least discuss it PGTA with her in the clinic. It's of course her choice to say no, but I think it's your duty as a doctor to mention that. So dual stimulation, ongoing pregnancy rate can reach up to 20. We have a study, but we didn't present it. I will present it hopefully in future meetings. I'm doing DuStem for the last probably 4 years, and we collected a huge number really for and our success rate is almost 20, and we treat even people who's really 45. So we leave it for next meeting. The choice of gonadotropin, what do you choose? The Cochrane said the clinical choice of gonadotropin should depend on availability, on convenience, cost. Differences between urinary and gonadotropin were considered unlikely to be clinically significant. So in that case, recombinant FSH or urinary FSH. Recombinant FSH is superior to urinary FSH and HMG as a mean to increase the oocyte yield. Now, in this group, our aim is different. Our aim is really getting a lot of eggs. I know HMG is beautiful things. I use it a lot, but maybe not for this particular population. So in that case, shall we add recombinant RH? Insufficient evidence to encourage or discourage stimulation regime that include recombinant LH with FSH in IVF cycles. What about recombinant LH? In RCOT published in 2017, the result indicate no significant difference between the group regarding, and they include in that group people who's really poor responders beyond 40. But when doing a further analysis, they found that the moderate and severe poor, they benefited significantly from 150 IU recombinant LH supplementation in terms of high live birth rate and lower total pregnancy loss. What about the dose of stimulation? ISHRI guideline in 2020 said gonadotropin dose higher than 300 is not recommended for predicted poor responder. I think we should really challenge them in Middle East about the BMI. It's not there in the literature. And when Cochrane, ISHRI also depend on Cochrane, depend on meta-analysis, but in this is not much from Middle East. We keep quiet when we are giving 600, we keep quiet. When we go to any conference, we keep quiet, we feel shy to share our experience, thinking that maybe we are doing wrong. I don't think 300 sometimes with, especially BMI, when your patient come with a high BMI, I don't think from my experience, and I don't know what is your experience, you people. It will be really interesting to share that with you. But from my experience, I really did not find 300 is really a successful dose for people who's really with high BMI when they are 45 or beyond. So how do we trigger? The key success to reach an optimal LH, the whole thing of the trigger is to reach the LH activity as optimum after the trigger. And our aim was to result at least 75% of mature eggs, and without increasing the risk, of course, of ovarian hyperstimulation. I'm sure you'll see in the literature now, I think with the trigger, it's not the, I'm not gonna go through the HCG and why we are giving the, and I think that this is not really the context of or the aim of my presentation, but what we do difference in this cluster of women, we will hear a lot about the dual and double trigger. So to define this, the dual trigger is defined as the combined use of GnRH analog and low dose of HCG administered together, while double trigger is defined by giving the agonist as 40 and then 34. Unfortunately, very few in the literature, and those all came from Israel. And the very promising result, but unfortunately, large RCT is really needed. Adjuvant ovarian stimulation, I don't know about this, and DHEA, the Cochrane say, quality of the evidence is moderate and may be associated with improved live birth. Growth hormone, of course, not recommended. Q10, randomized controlled trial, and unfortunately, no placebo group was included. It reduced the mitochondrial oxidative stress and improved oocyte competence and minimize very minimum side effect. Why not to use it? Pre-treatment, they use in this paper 2 months earlier before they start their stimulation, and then they found that this improved the ovarian stimulation and as well the embryology. And in young women with poor ovarian results, so they're not talking about the old, they're talking about the new poor responder. I don't see any harm in using Q10. I mentioned earlier that is it safe to start patient who is 47? And I thought I will ask this question in the literature. Do we take enough care for preconception health in ART in general, not just really old lady? And then a cross-section study came from Florence, and 2020 and even earlier.
Khulud, 3 minutes, dear. 3 minutes.
Yeah, I'm finishing. I'm almost finishing. This has included 1,003 women, and it was internal medicine clinic in ART center, high prevalence of lipidemia. And they advise before infertility, very important to modify the cardiovascular risk. I leave this potential obstetric for tomorrow. I'm sure the guys will bombard you with this. I conclude my talk today that women after 40 is a challenge scenario. More research is needed to make firm clinical recommendation and future trial investigating pre-treatment strategy, ovarian stimulation strategy, and ovarian trigger strategy needed, and based on detailed patient stratification, such as suggested by Poseidon group. Clinicians need to be vigilant when treating this category of patients that encounter preconception morbidity, and must be vigilant in their presentation of risk and benefit and alternative, balance between what is possible and impossible to avoid providing a futile treatment. And thank you very much. Keep well and safe.
Thank you, Dr. Khulud. That was nice presentation for a nice topic, which is always there. The thing is that nowadays, the age of marriage of some women is coming to the 30s and late 30s. And by the time they start investigating why they are not conceiving, they are touching the 40s.
Yeah.
Again, some of them are in their second marriage and they want a child from the second husband, and they come to us in the early 40s, 41, 42, and they have children before they expect that it is easy for them to conceive again. Anyway, we should be decent and honest and explain that time has changed and the quality of eggs and oocytes have been different when she was young. Anyway, nowadays we are trying to get around this, how to get to the number of normal healthy embryos so that we can transfer and be successful. I agree with you on the amount of stimulation, how much stimulation we need. And I think it's different because of the ethnicity most of the time. The starting dose for some patients in their stimulation protocol might be 600, not 300, or the maximum they are talking about in their guidelines as an exception is 450. Stimulation is an experience. It depends on your experience. And again, when I was in Germany, the leading follicle of 17.5 is the triggering timing. Here, we trigger at 20 millimeter. So
exactly.
There will be some difference between us and them.
Yes.
We are not having the same environment, the same food, the same everything. Even the same genes is different. But anyway, also the experience of the group in the Middle East, for example, is a bit different. The setup is different, religious, cultural, all these things are different.
Agree with you, totally agree with you, Dr. Salam. And we are different, but unfortunately, our presentation is very, very poor as well in the literature. We're not much really around there. And I think I have to criticize even when their approach as well. When they do anything, they don't consider really ethnic background. You know, especially Arab. We should be really treated different. The BMI should be should be always to consider. I think we are running out. Maybe I can see another thing coming up. Or am I having any time for discussion or? we're finished.
I cannot see any question in the Q&A, but
Okay.
I read, if I want some information, I will share some information. I heard a lecture last month in New York from the Professor Nopar Tigricher. He is the pioneer of an IVF in New York. He mentioned a prospective study for 49 patients, and he published it in the Ovarian Research Journal. And the study, he mentioned about a patient who are about 45 years of age or 49 years of age who are poor responder. He said he will continue treat patient even if they are coming at the age of 50 after proper counseling and proper consent. He created a kind of protocol. It's called a rebound protocol. When he got a patient, around 49 patients, the rebound protocol is he's using patients, he will go through stimulation, any stimulation he will decide. Within 4 to 5 days of his stimulation, if he did not find any response, he will stop the stimulation for 4 to 5 days. In 4 to 5 days, he will ask the patient to come back. He will categorize the patient in 2 arms, either positive or negative. Positive rebound, if he see that in the ultrasound she has a follicle even of 10 millimeter, he will start the HMG with 25 international unit. If he saw no follicle, he will label it as a negative rebound stimulation. And he will continue the stimulation till he got a follicle of 16, 17, and he will retrieve it and refreeze. I said, I want to share this protocol with you in case if you face any.
But Hafsa, but you have to always, I know, I mean, that's the reason I mentioned really ethics here. And the cost, of course, is it cost effective? Is it cost effective? I mean, it's not funded cycles. And
correct.
It's different between what is really evidence, what is mentioned as a trial and research, and between what is really being proved.
That's why I said I want to share it with you because
absolutely interesting. But very interesting protocol as well. The other protocol we mentioned, but I treat Hafsa. I treat patients even 45, 46. It doesn't mean I think you, Dr. Salam, I think you and me, Hafsa, we work together, and we do treat them because. But what I'm trying to say that we have to be very clear in the counseling. There is many protocol in the literature. They try, but I think when we try something new, I think patients need to know that.
Yes, of course. That's why
when I introduced the use them in my set, so I'll give you my experience. When I introduced that in my clinic, I told them that's very new, and there is no evidence so far, but I will use it because it's very promising. And people, some people they say yes, some people they cannot afford it. Now, Dr. Salam, back to your point, ART calculator is beautiful because if you are stratifying your patient. With ART calculator, it will tell you how many eggs. And then at least you will say, well, I can then need 11. And when your AFC is 4, I might need 3 or 4, 6 times. It's good because it's very practical. So this is maybe you need to, because you do PGTA.
We have to stop here. We have to stop here.
Yeah.
Thank you very much, Khulud. Thank you very much.
Thank you very much. Thank you.
I'm sure
the discussion will continue.
Let us conclude this with the recorded lecture by Dr. Yasmin Sajjad. She is a senior consultant obstetrics and gynecology, andrologist, and assisted conception specialist, division, and chief and director of Al Corniche Fertility Center in Abu Dhabi. Can we have the lecture, please? Mr. Ahmed.
Good afternoon. I'm Yasmin Sajjad. Thank you very much for the organization committee to invite me to give this talk about the hyper-responder management in assisted conception treatment. In assisted conception treatment, controlled ovarian stimulation therapy is the starting point. And the main objective of individualization of this treatment is very important. And that is that it offers every single woman the best treatment tailored to her own unique characteristics to improve patient compliance, maximizing the chances of pregnancy, live birth, and of course, considering the cost implications. And above all, it's important to eliminate avoidable risk resulting from ovarian stimulation, especially hyperresponse or ovarian hyperstimulation. Now, treatment individualization is based on ovarian reserve markers like AMH, antral follicle count, and they are considered the most accurate, reliable markers of ovarian reserve, as you will see as we go further in our talk. So, what do we mean by hyper responders? This is actually iatrogenic complications. Ovarian stimulation is actually an iatrogenic complications of IVF stimulation when we give gonadotrophins, and this is characterized, this is actually a response. In some women there's an exaggerated response, and some women it might not be as severe as one thinks. But as we go further in the talk, it will become more clear as what patients are prone to have this exaggerated response. Now, this is, I just put this slide to show that on the left side, if you see this one, this is a normal looking ovary in patients like polycystic ovary syndrome patients. And this one is a start of stimulation, day 3, day 4, day 5, where the follicles have started growing up and multiple follicles are seen. So in fact, the ovaries become like a bunch of grapes. That's how I put it to the patients for their easy understanding. And OHSS is classified into early OHSS and late OHSS, which is sort of primary or secondary. The early OHSS is usually the first 3 to 8-9 days, and this is related to the trigger and initial response. And the secondary OHSS is usually after the embryos is transferred and the patient gets pregnant, because the pregnancy hormones, estrogen, prevents the ovaries from shrinking, prevents sort of the hormones to go back to normal, and that sort of leads to secondary OHSS. Now, what is the incidence? The incidence of moderate to severe OHSS is 3 to 8% of all IVF cycles, but it can be as high as 20% in high-risk women, okay? Significantly higher in these polycystic ovary syndrome patients compared to normal ovaries. And most of the ovarian hyperstimulation occurs with gonadotrophin stimulations, but it has been reported in spontaneous conception, which is not very common, and also being seen in patients who has ovulation induction with clomiphene. Now, any treatment you give, whether it's IVF or medical treatment and all that, you need to plan the treatment, okay? So personalization and planning of treatment in IVF should be based on prediction of ovarian response for every patient, okay? As I mentioned earlier on, that there are some ovarian reserve markers that you can take into consideration, and that's how you plan the treatment, the medication, the doses. And if you properly do risk assessment for these patients and identify if a woman is likely to have a normal, average, or poor, or hyper response, then you can choose the ideal treatment, which will basically tailor-make treatment for these patients, so that you can reduce the risk associated with these ovarian stimulation in high-risk patients. I put this that prevention is better than cure, okay? And it's important that we recognize the risk factors beforehand, so that we can give the medication, the dosage, adjusting the dose appropriately. Now, the primary risk factors in these cases, as I mentioned earlier on, that you have to risk assess patients. So if a patient has got PCOS, if she's the young age, she's got low BMI, she had previous history of ovarian hyperstimulation, and the baseline anti-Mullerian hormone is raised, and the antral follicle count is also raised. So those patients are potentially, at high risk of getting the complications. And secondary risk factors is once the stimulation is started, then they become evident, and those are the secondary risk factors. For example, when we start the stimulation for these patients, you see there's a rapid rise of estradiol level in the first 3, 4, 5 days. They might develop a number of follicles, and at the time of triggers, they have an excess of 20, 25, 30 follicles. And also when you do the egg collection, they have increased number of eggs. There could be 30, 35, 40. Even I have sort of got, my record is about 68 eggs from a patient. So that's sort of, it gives you a prediction that these patients are at increased risk of OHSS, and you have to be mindful and ready to deal with any complications that could occur. But none of the above are independent predictors of OHSS. Now, I kept on talking about the AMH and AFC. So these are certain markers that one has to take into consideration. So if somebody has got an AMH of more than 3.4 nanogram per mil, this is the baseline one, or the initial antral follicle count is more than 25. They are at increased risk of OHSS. And later on, during the stimulation, this patient develops more than 25 follicles, or at the time of trigger, she has got more than 3,500 picogram per mil of estradiol level rise. That would sort of indicate that these patients would be at risk of ovarian hyperstimulation. Ovarian response prediction, it provides information, of course, on the chances of success, safety, risk, and complications. And it's the ESHRA guidelines, which were published in October 2019. It also states that predicting high and poor response to ovarian stimulation, one should take into consideration the AFC and AMH to base their treatment and to adjust the dose accordingly. Now, this systematic review was based on 305 citations, which was published by Marka and Sankara in March 2013. They reporting the ability of AMH and AFC to predict response to controlled ovarian stimulation. And this literature review demonstrated that AFC and AMH are the most sensitive markers of ovarian reserve and are ideal in planning personalized controlled ovarian stimulation protocols. It also enables the clinicians to give women more accurate information on their prognosis and helps in counseling, especially the responders or those patients who have PCOS. And here, that's the graph, sorry, okay. Now, the ovarian reserve testing and prediction of a hyper-response was also published by Broer et al. In Fertility and Sterility in 2013. And they did individual patient data meta-analysis in 2013. This was to evaluate whether ovarian reserve tests add prognostic value to patient characteristics. And they showed that AMH and AFC add value to female age in prediction of excessive response. So those are independent markers. And if you combine it with age, they are useful for the prediction of these patients, that they will be prone to hyper respond to the gonadotrophin stimulation. And of course, it's important that whenever we plan the treatment, we always looked at the baselines, look at the age. As I mentioned earlier on, these are the primary preventive measures that one should take into consideration. This was a study done by Magnusham Magnusham et al., and it was published in Human Reproduction in 2018. And they actually did a retrospective population-based registry study on over 39,000 women undergoing a fresh and frozen IVF cycle between 2007 and 2014. This is they wanted to show whether to establish the relationship between the number of eggs collected and the likelihood of cumulative delivery rate and severe OHSS and any thromboembolic events that occurs, because thromboembolic events is actually recognized complications of ovarian hyperstimulation. So they showed here, if you see this green line, that the cumulative delivery rate per aspiration increases up to 20 eggs retrieved, and then it evens out. So this is the live birth, and this is the number. These are the number of eggs retrieved. So up to 20 eggs, it increases, but after that it evens out, and it really occurs after the ovarian. But after this, the ovarian stimulation, that is OHSS risk, increases, and OHSS risk really occurs, before 15 eggs. So they suggested that one should not aim for maximum number of eggs, but there should be a safety thing. And they showed that once you get 20 eggs, that's good enough. But after that, the pregnancy rate doesn't increase, but of course increases the risk of ovarian hyperstimulation. And then this was a study by Sunkara, and they actually did it before Magnusham in Human Reproduction publication in 2011. And they actually, this group obtained the HEFIA data. HEFIA is the Human Fertilization and Embryology Authority in UK, which controls all the IVF centers and collects data from them for the whole country. And this data was obtained from 1991 to 2008, and a total of over 400 IVF cycles were analyzed. And they showed a non-linear relationship between the number of eggs and live birth rate followed by IVF treatment. And from this data, they showed the number of eggs to maximize the live birth rate was around 15. So if you see this 15, but after this, it does not increase, it evens out, okay? So they concluded that the number of eggs in IVF is a robust surrogate outcome for clinical success, as we saw in the previous study as well. So what do we do about these patients, those hyper responders, or those who have got increased primary risk factors? In those cases, it's important that we have either the primary prevention and the secondary preventions. And we'll go through these points one by one now. So let's take what primary prevention should we be taking into account when we are stimulating these patients. It's important that we use unifollicular ovulation. So we should use one gonadotrophin rather than 2 or 3. And it's really, in my clinical practice, I never use 2 gonadotrophins at the same time. I always use the unifollicular, one gonadotrophins. And you should do low gonadotrophin dose with a step-up regime. So you start with a low dose and then you slowly and gradually increase it, basically monitoring the patient estradiol level, as well as you scan them to see the follicles development. So it should be tailored based on the gonadotrophin type. And in my experience, and as some studies I'll show you later on as well, it has shown that the recombinant FSH has a higher specific bioactivity than human menopausal gonadotrophins. And why is that? Is because the recombinant FSH dose increment is better than the HMG. You can increase it in increments of 12.5, tailoring the dose to minimize the ovarian hyperstimulation risk. So as I said earlier on, you start with a low dose and then you slowly and gradually increase it. So usually in these patients, I start them on 100 and I go up 112.5 and then at the increments of 12.5, rather than with the HMG, which you don't have this beauty. In those cases, it's actually 75 or 100, and that's not good because then you are subjecting your patients to more risk of ovarian hyperstimulation. Amirlas he did a UK multi-center study in 2004, and 21 centers were involved. They recruited about 1,427 patients, and they showed that routine use of recombinant FSH in normal clinical practice can be effective, safe, and well received by the patients, because one is the slow increment and also is the pen, so that it's easily adjusted by the patients. In my experience, in my clinical practice, in my clinic, the patients do like the recombinant one because of the easy use, and it's more compliance for the patients. This study was done by Friedman in 2000, published by 2000 in Human Reproduction, and Anderson in 2006 in a very reputable human reproduction journal. And they showed that they compared the recombinant FSH with HMG and showed that recombinant FSH produces significantly more follicles over here, and more eggs and embryos than HMG and urinary FSH. So again, sort of reiterating the use of recombinant FSH in these patients. This was a British Isles and Netherlands study. It was a prospective data, which was observational post-marketing survey done in over 3,000 non-selected treatment couples in 7 Northern European countries. And they showed that the moderate to severe OHSS risk is less than 3% in patients who were given recombinant the FSH, that is the gonal F. This is a pivot algorithm done for individualized control ovarian stimulation with the recombinant FSH, was published in 2016 by Jovic. And they made this algorithm to do adjustment of gonadotrophin that we use in ovarian stimulation, the dose based on age, AFC, grading, AMH level, BMI, and day 2 FSH and smoking history. And this, they showed that it helps in optimizing pregnancy outcomes with avoidance of OHSS. So as I said earlier on, it's not about creating pregnancy, and with a live birth increase, we have to be keeping the complications of these patients down as well. Okay, because our first priority as a clinician, my first priority is my patient's safety. Pregnancy comes second. This is a study done by Otshon, and it was published in Human Reproduction in 2017. And they wanted to know if reduced gonadotrophin dose or FSH dose in women with predicted hyperresponse, that is those patients who have got high antral follicle count, or if they are scheduled for IVF ICSI, it can lead to different outcomes with respect to cumulative live birth rate and safety. So in other words, they wanted to compare a dose of 100 to 150 and see if that would make any difference in the cumulative birth rate. And they saw that although in women with predicted hyperresponse, that means AFC of over 15, they are going under IVF, reduced FSH dose, that is 100 on the side, per day results in similar cumulative birth rate than the 100 and with the, sorry, let me put it again. So the cumulative birth rate with both 100 and 150 dose is the same, okay? But the risk of OHSS is much reduced in patients who have got who have been started or was given a dose of 100 instead of 150. So that again shows that by increasing the dose, you're not increasing the birth rate or pregnancy rate, but you are subjecting the patients to high risk of OHSS. So this in both these with those doses 100 and 150, the cycle cancellation and the severe OHSS was the same, but the mild and moderate OHSS was less. Okay, so we talked about unifollicular ovulations. That means giving one gonadotrophin with stimulation. Now we come to the individualization of controlled ovarian stimulation regime in these patients, and this is about the protocol. So for the hyper-responders, GnRH antagonist protocol is better than the agonist. And why? Because we use less units of gonadotrophins than the agonist, less days of stimulation. More importantly, it allows avoiding of HCG for ovulation triggering. There's low risk of OHSS because if you put some patients on agonist protocol, you can't give them agonist trigger. But with an antagonist protocol, you give them agonist trigger, and we will see in later on that why is that. And it also been shown that it reduces multiple pregnancies, and it's also cost effective because you're giving less number of stimulation, you're giving less dose, so of course it is cost effective. This study was done, this review was done by Lambeck et al. And published in Human Reproduction in 2017. And they looked at, they compared the antagonist with the agonist protocol, and they looked at the OHSS and live birth rate. And this is a forest graph which shows that the antagonist protocol is in favor of reducing the risk of OHSS compared to the agonist. And what happens to the live birth? Of course, it's not statistically significant, but it does increase, the antagonist favors increased pregnancy rate and live birth as well compared to the agonist. ASHRA, also in the 2019 publication, recommended use of antagonist protocol for PCOS women because of its improved safety and equal efficacy, as we saw in the last few slides. And this is predicted for the hyper responders. Okay, this study was a randomized open label assessor blind multi-center, actually a non-inferiority trial, which was published by Paul Deveroy in 2012. And this was done on 25 centers and almost 749 patients, women were involved. And this was to compare the efficacy and safety of HMG and recombinant FSH for controlled ovarian stimulation in GnRH antagonist cycle with compulsory single blastocyst transfer. And the primary outcome was pregnancy and live birth. And they showed actually non-inferiority of HMG with recombinant FSH for primary outcome. There was no significant difference in the ovum pickup rate, that is 30% with HMG and about 27% in the recombinant FSH. But there were no valid conclusions could be made on any secondary outcomes. The problem was this was a very rigid protocol because not conforming with the current guidelines because there was no individualization. All women had HCG trigger irrespective of whether they had OHSS risk, and all these patients had fresh transfer irrespective of ovarian hyperstimulation risk. And we'll talk about the freezing and all that in a short while now. The other primary prevention is alternative to ovulation for the trigger. In GnRH agonist trigger produces more tempered and short mid-cycle gonadotrophin surge, and it usually lasts for 24 to 36 hours. It actually stimulates the pituitary own LH, and that helps, in fertilizing the egg. And agonist-induced LH surge is sufficient to induce ovulation. So good enough, you can give 0.1, 0.2 milligram of tryptolin, and that's good enough for the maturity and the final oocyte maturation. But the HCG, which has got more risk of causing the ovarian hyperstimulation, and the half-life is more than 2 days. So be mindful that no agent can completely eliminate ovarian hyperstimulation risk, but of course, with agonists, the risk is less compared to the HCG. ASHRA also recommends use of agonist trigger in these high responder patients to reduce the risk of OHSS. And NICE guideline in 2013 also recommended use of agonist for triggering the final oocyte maturation if on the day of trigger the estradiol is more than 3,500 picogram per ml and the patient has got more than 20 follicles or so. The other one is, I think we also talked about that avoidance of the HCG trigger, and the use of, luteal support. These days, most of the luteal support is with progesterone, but some people do give HCG for luteal support, and that should be avoided in cases of PCOS or hyper responders. And routine use of progesterone should be used in these patients. Secondary prevention is, you talk about, there are 3 different things that we can use. One is coasting, freezing all the embryos, or cycle cancellation. So let's take coasting. Coasting is that when you reach the final stage of trigger and you see the estradiol level is very high, in coasting, we stop the gonadotrophin use and we let the estradiol level drop to a safe level, and then HCG or the trigger is given. Maximum coasting can only be done 3 to 4 days. After that, the pregnancy rates drops down. And why coasting is considered? Because the VGF factors, which are there to stimulate causes the leaky capillaries and complications, that is expressed in the granulosa cells, and by coasting, the granulosa cells die out and the estradiol level decreases and helps with the reduction in the risk of OHSS. The other one is embryo freezing. We do a lot of this to reduce the risk of OHSS, and there's a strong support for the use of GnRH antagonist protocol use, and the HCG, the agonist trigger, and embryo freezing. And these three things can actually lead to literally an OHSS-free clinic. Okay, this is the question is that whether freeze-all protocol can prevent completely get rid of the OHSS risk. And yes, there's evidence. And also the ESHRA guidelines also recommends the use of OHSS. This was, the freeze-all. This is a beautiful paper published by Christopher Blockill, was published in 2016, and they made a SWOT analysis for the freeze-all protocol and in favor of freezing the embryos in those patients who are increased risk of hyperstimulation. Paul Devereaux also did a segmentation on reducing the risk of OHSS, and the three segments which you use is that optimization of ovarian stimulation by GnRH agonist triggering in a GnRH antagonist cycle, optimizing of oocyte and then embryo freezing, and then optimizing of endometrial implantations by embryo replacement in a receptive endometrium in a natural or artificial cycle. So with all this sort of these measures, you can get a completely OHSS-free clinic. So there should be a balance between the desire for pregnancy and patient safety, which is a clinician's top priority. This study was done by Zhao et al., and this was recently published last year, actually in February 2020. This was a retrospective cohort study which was undertaken in one of the large centers in China. A total of 3,276 women up to the age of 35 underwent a freeze-all strategy from 2009 and to 2016. And they showed that taking both efficacy and safety into account, ovarian stimulation should be rational, because as the number of oocyte retrieved positively correlates with the cumulative live birth, but with the upper limit is 30. As I showed you earlier on, it's not that you get more eggs and you increase the live birth. It doesn't, maximum is 15, 20 eggs, and then it evens out. So this also favors the use of a freeze-all strategy. So therefore, optimization of ovarian stimulation for freeze-all cycle results in enhanced treatment, and equally keeping the safety of patients into view. And this study was also published in a reputable Journal of Human Reproduction in January 2020 by this Iranian group. Cycle cancellation, it is the last resort for the clinician to cancel the cycle, because it can have high financial impact and psychological distress to the patient. So this will be a last resort for it, but of course that could be one of the options that one can use. What about use of metformin? It has shown that reduces the risk if you give metformin with the stimulation, reduces the risk of OHSS. because it reduces the vascular permeability of the capillaries, which causes complications in OHSS. But ESHRA in 2019 did not support it and said that routine use of adjuvant metformin before or during ovarian hyperstimulation is not recommended with GnRH antagonist protocol. But cabergoline is a drug which reduces the VEGF-mediated increased vascular permeability. It's like the preeclampsia in women where they develop leaky capillaries. So cabergoline actually blocks the receptors and helps in reducing the risk and the complications with OHSS. But the important is that it has to be given before the trigger. And it should be commenced on the day of before the HCG and should continue for eight days or so, or till the patient has her periods. This was a systematic review published by Tayo et al. And again, it shows that with using of cabergoline, the risk of OHSS is much reduced. So it's important that we tailor control the ovarian stimulation for these patients to avoid complications. HMG, urinary FSH, and recombinant FSH equally effective to achieve pregnancy in PCOS. But of course, the recombinant FSH is slightly more in favor because of the dose escalation, the increment that you can use. Antagonist protocol with GnRH antagonist trigger is associated with a very low risk of OHSS, and mortality from OHSS is unacceptable. The balance between the desire for pregnancy and patient safety is our clinicians' top priority. And we are all aiming and wants to have the strategy to obtain an OHSS-free clinic, and will be beneficial for our patients and reduce their risk. So the endpoint is that one should individualize at all stages of treatment, considering the safety and efficacy of the treatment. Thank you.
Thank you, and I would like to thank Dr. Hafsa and Dr. Salam for chairing the last session, and sure thanks for all the speakers and the audience who stay with us till the end. Today we are closing the second day of the MAC Congress, and tomorrow is another, and we hope it will be another successful day with an eminent speakers in obstetric and pediatric and neonatology. Looking to welcome you tomorrow. We will starting tomorrow by 12, and the session is an obstetric session first, starting from 12 till 4 o'clock, and after that will be followed by a pediatric session, and at the end we will closing. We hope all speakers and audience to join us at the closing ceremony tomorrow by 7 o'clock, and thanks for all to be here with us.
Thank you.
Thank you,
Dr. Hafsa, for co-sharing with me. Your presentation was outstanding.
Thank you.
Thank you, Dr. Muhammad. It was a very fruitful evening.
Thank you. Thank you, Dr. Salam. With you. Oh, thanks.
Thank you, Dr. Muhammad. Thank you, Dr. Salam. I really enjoyed to be co-sharing with you, and we cannot wait to see tomorrow. I hope we ended with an excellent, as usual, conference. Thank you very much for all the attendees who stay with us till this time. Thank you very much.
Thank you.
Thank you. Thank you all. مع السلامة. مع السلامة.